Hi, everybody. Oops. Hi, everybody. Welcome to the third annual Diversity Medicine Conference. We are so excited to have you all here. We've been working so hard these last few months to get this conference together, and we're just really excited about what's been happening. Thank you all for coming in this morning. I'll just give us a brief introduction to the conference and to our first keynote speaker. So my name is Dina Balluz. I'm a fourth-year medical student at the University of Michigan Medical School. This year, I was lucky enough to act as the co-director of the executive board of this Diversity in Medicine conference, made up of over 20 third and fourth-year medical students at the University of Michigan, who have all worked tirelessly over the last few months to put this virtual conference together. This virtual conference obviously feels incredibly timely given the many events over the past year and even over the past week. However, everybody here knows that this work has always been and will continue to be incredibly important. What makes this conference so special is that it is medical student run. From conference planning to poster presentations, discussing diversifying medicine and health equity to some of the speakers you'll hear from today. And we're so excited to have panelists and speakers who have devoted their entire careers to this work. We hope you leave this conference inspired to challenge yourself to not only work in this space, but become a leader in this space. And we're so lucky that nobody exemplifies the mission of this conference better than our first keynote speaker, Lashira Nolan, who I'm so honored to introduce. Lashira, or Lash Nolan, is a Los Angeles native, deeply passionate about the concerns of underserved and marginalized communities. She's currently a second-year medical student at the Harvard Medical School, where she's serving as student council president of her class, the first documented Black woman to hold this leadership position. As you likely know, Lash is incredibly accomplished and inspiring, with published works in the Boston Globe, New England Journal of Medicine, Nature, and HuffPost, among others. She even had her, surgery clerkship rounds this morning, so she's incredibly impressive. She's also a Foster Scholar in the Health Policy Advocacy and Media at the MGH Stokel Center for Primary Care Innovation, and is also a co-host for the Clinical Problem Solvers Anti-Racism in Medicine podcast. Her work has earned her the honor of becoming the 2020 National Minority Quality Forum's youngest 40 under 40 leader in minority health, and she was named a 2020 Young Futurist by the Root magazine. I truly can't think of a better way to kick off our medical student-run Diversity in Medicine conference than Lash Nolan. Lash, thank you so much for being here.
Thank you so much for having me.
You want to start your video?
Yeah, it says the host has to turn it on.
Try now.
Okay.
Sorry, technical difficulties.
Okay, cool. I mean, it wouldn't be the era that we're in if we didn't have Zoom difficulties, right?
Exactly.
Exactly. But I am so honored to be able to share this space with you all. I'm looking forward to getting to learn from everyone who's going to be speaking today. And I'm so excited for the conversation that we're going to be having in this particular presentation. But before we get started, I wanted to share a brief form of poetry that I wrote back at the beginning of the pandemic, and especially during the time that we were starting to see a lot of civil unrest around all of the social injustice that we were seeing in relation to police brutality. And I feel like it really just embodies how we've all been feeling throughout this entire experience, throughout this entire year. And I think that it's just so interesting that I wrote it so long ago, it feels like, but it's still so relevant. So this is my piece titled When the Dust Settles. Since Memorial Day weekend of 2020, the dust has been unsettled. 4 centuries of oppression, blood, and tears unpacked from the soil, which they've ignored since their birth. Now the pain of my ancestors fills the air and their strength is palpable. Seems like white folks done got woke and are finally ready to be held accountable. I guess the racist, xenophobic president, a pandemic, 3 months of isolation, 21,000 Black lives lost, and a fatal lynching by Neil was finally enough. So you big anti-racist now, but tell me, do you really care about us? Because right now, anti-racism has suddenly become the status quo. But tell me, where was this energy from you 8 years ago? Trayvon, 6 years ago, Laquan, 5 years ago, Sandra, 4 years ago, Alton, 2 years ago, Nia, last year, Tatiana. These Black lives have always mattered to us. Now they suddenly matter to you, and you want us to trust that you won't leave us hanging after there is no longer any dust. Because when the dust settles, everything goes back to normal. The normal that makes your life so easy but hurts me so deeply. Look, diversity and inclusion, that's your illusion. A seat at the table or liberation of my people, which one you think I'm choosing? So you can miss me with the delayed statements and kneeling. Instead of like a 2-year plan on how you're going to prioritize my people's healing. In 5 months, we're gonna see what you really about. Are you really down for the cause, or was it all for the clout? I don't know, but I can say one thing without a doubt. When the dust settles, we'll be there to make her rise again. When it's time, just give me a shout. Dr. O.
No physicians are racist because racism is clearly illegal. Then why do the same lapses in judgment keep negatively impacting the same type of people? Well, I'm disabled and Black, so I gotta watch my back. Ain't no telling which part of me will be the target of their next attack. We all appreciate your passion, is what some will say to your face. But behind closed doors, they are the assassins silencing your voice as you just try to advocate. Please be patient. This is important to us, but you must understand that change takes time. But we've been patient for years now, so please tell me whose clock is off, yours or mine. When the dust settles, we may see what you really about. But I'm afraid I won't be around by then, because my time is clearly running out. Luckily, this next generation understands diversity, equity, and inclusion much better than us. And this conference is only one example of their impact. There's so much more to come. Just you trust.
Amazing. Thank you so much, Dr. O. And for really bringing something that started last year and bringing that connection to this moment was something so special that we really wanted to do. So I hope that resonated with y'all. And now we're going to get into the presentation. And today I'll be talking about the case for anti-racism in medical education. All right, y'all. So as I said, today we're going to be talking about the case for anti-racism in medical education. As was said earlier, my name is Lashira Nolan, but most folks know me as Lash, and I'm in my second year at HMS and currently doing a surgery rotation over the weekend. So first, I want to say that I have no disclosures, and I want to take this moment to really dedicate this presentation and all the work that I do to the many women and men who've been impacted by police brutality and social injustice in our society. And I especially want to dedicate this moment to Breonna Taylor, Don Wooten, and so many others who unfortunately are nameless because we might not know their struggles. I'd also like to acknowledge that the land that I sit on today is that of the Massachusetts tribe, and I want to honor their elders of the past, present, and future. And lastly, I do want to acknowledge that we all are amidst the pandemic. And I know that many of us may be presenting in different states of mind, whether we're personally dealing with how the pandemic has impacted our lives or how it's impacted our family, our communities, and our loved ones. So I just want to say thank you so much for sharing this space with me during such a challenging and difficult time. And I fully recognize that this is not normal. And it's sometimes hard to forget that. So before I get into the conversation that we're going to have today, I want to talk a bit about why this matters to me. And really, my entire journey started with the support and love of my mother, She raised me as a single parent in Compton, California, and she was the first in our family to get both her bachelor's and her master's degree. And despite me never seeing a doctor until my second year of college, it was really the love and the support that she gave me that allowed me to see myself in this white coat. And this is she and I at my white coat ceremony. Then there's my grandmother, who never had the opportunity to go to college, but she finished high school. And that is something that we're both so proud of because of all the different challenges that she had to go through in her life. And really just listening to her stories and listening to the ways that she's had to confront racism and push through is really inspired me to always make sure that I'm representing her voice in every single space that I'm in. And she still continues to be one of the most loving and important people in my life. Before going to medical school, I took a gap year. I was an AmeriCorps member in Chicago. And during that year, I got to meet some phenomenal humans who taught me so much about life and the way that inequity can have a direct impact on the way that you're able to live out your life healthily and happily. And these are some of my friends that I made working with an organization called the Night Ministry. And every week I would go out on this mobile clinic that served folks who were unhoused. And just listening to their stories and learning about their lives, it really just kind of reminded me of growing up and seeing the different struggles of my family members. And really, it's this beautiful community that you see on this slide that are behind everything that I do. And I try to embody their spirit in every aspect of what I'm doing right now with my social justice advocacy. So before I start any presentation, I always want to make sure that I show love to them because I wouldn't be if it weren't for them. So before we get into our conversation, I first want to make sure that we really define some key terms that you'll hear me use throughout. And I think it's important to delineate the differences between these things because I think sometimes people use them interchangeably, and that's very incorrect in a lot of ways. So the first is prejudice, right? And prejudice is like this prejudgment of another group or individual on membership and stereotypes. So it's this judgment that you have in your mind. And then bias is when you start to allow those prejudgments to turn into preferences for one group or another based off of those prejudgments that you've created. And then there's discrimination. And that's when you have prejudice and bias in action. So you go from having it conceptualized in your mind to actually acting out in such a way that displays that prejudice and that bias. And then we have race. And race is a socio-political construct that groups people based on their appearance. And it's important to understand that race is fluid and it depends on the context and the location. So people might have a different race depending on where they're geographically located, or some places might not even have a conceptualization of race because it doesn't exist in the space where they are. And it's extremely important to know that race came after racism, which is a power structure built off race that was created to primarily benefit those of the dominant caste. And in American society, that is a reflection of white supremacy. And the way that racism can present is through interpersonal racism, which is the racism that we experience between individuals. Then there's systemic racism, and that's when systems and policies come together to create experiences that benefit some and disprivilege others. And then there's internalized racism because of these experiences that you have where society is telling you that you're not worth it or that you don't deserve opportunity. And then you have the interpersonal racism coming in and you experience that on a personal level. You start to internalize that. And that's when you get internalized racism, where you feel like you're unworthy. And I'm sure a lot of you have maybe experienced this or have had patients or people in your lives kind of express how this might manifest. So I think that these are just some key important definitions to understand as we move forward in our conversation, because I think that they'll really help contextualize the rest of what we'll be discussing. So now let's think about racism in medicine. And the way that I like to think about racism in medicine is really in like a timeline fashion, because I think that oftentimes we jump straight to Tuskegee or we jump straight to Henrietta Lacks, but really we need to take it step by step and understand that from the very inception of medicine's existence and how Black people interface with it, it was a relationship rooted in oppression. So in 1619, when Africans were stolen and captured and forced to come to this land to do labor, The only reason why medicine existed, the only reason why these individuals were sought after to be healthy was so that they could continue to do the work of forced labor. So I think that that's really important to understand, because ever since we first started to interface with medicine, it was because you want to keep me healthy, not because it's coming from this space of wanting to heal, of wanting to help people, but because you benefit from this system of oppression that allows us to continue to seek the benefits of me doing this forced labor. So then we saw in 1758, Carl Linnaeus, he created this racial taxonomy, which was a really important event because it's a perfect example of why race is not a biological construct, but it's a socio-political one. Because I'm going to show you the graph of how he broke down this racial taxonomy. And based off the color of people's skin, he then attributed different types of personality traits with them: lazy, not smart, et cetera. And those are things that we still continue to associate with different groups. And then in the 1840s and 50s, that's when we start to see Marion Sims gain more popularity. And he operated on predominantly on three enslaved women: Anarcha, Betsy, and Lucy, without anesthesia, despite anesthesia being invented and it being known to help prevent pain during procedures. So here we have the father of gynecology, right? Even today, he still has his name associated with a lot of the tools that are used, a lot of the procedures, and it was literally founded on the backs of these three enslaved women at the cost of their suffering. And then we have Samuel Cartwright, and he created this mental illness called drapetomania. And what that mental illness described is when enslaved people wanted to escape slavery, he said, oh, well, they're mentally ill. So what that did is it normalized more oppression. Because if you try to escape the oppression, the medical institution said, no, that's not right, that's a mental illness. So once again, we see that this oppression is a common trend behind the experience that Black folks have with the medical institution. Then in 1868 and 1910, we see that there are these Black medical schools that are erected because Black folks were not able to enter our medical schools originally. So what ended up happening in 1910 is Abraham Flexner was commissioned by the AMA to go out and do a survey of the quality and to look at the medical schools that existed in the US. That led to 13 Black medical schools being closed. And in 2019, a JAMA report came out, or some folks published in JAMA, and it said that if those schools would have stayed open, in just 1 year, we would have had over 300 Black medical school graduates, 300 more Black physicians in our communities. And we all know how much of an impact that would have had on our communities, looking at the health disparities that we continue to see today. Then from 1932 to 1972, we saw the untreated syphilis experiment. And I'm very intentional in calling it the untreated syphilis experiment, because saying that it's the Tuskegee experiment really doesn't allow us to make sure that the onus is put on the actual perpetrators of the harm in this experiment. And that was the US Public Services Department. And I thank Dr. Kimberly Manning for teaching me that lesson, because Tuskegee is a beautiful institution in Alabama where people are loved, where so many Black scholars have been birthed and trained. So Tuskegee didn't do anything wrong. It was the US Public Services Department. And what's really important to understand about the Tuskegee experiment is that the reason why they conducted it is because they thought that syphilis would look different in Black people compared to white people. So once again, this idea of these racial differences that were put in our minds by Carl Linnaeus are already cropping up. And then on top of that, they denied these individuals treatment for syphilis, despite the fact that we knew that penicillin was the treatment. So that ended up impacting not only those individuals, but it also ended up impacting their partners and their children. So that means that an entire generation was impacted by the medical institutions' active oppression of our communities. And we see that continue to happen today, whether it's Dr. Susan Moore, who's a Black physician in Indiana, who on her deathbed literally went on Facebook Live to say that they're about to discharge me and I know that I'm not ready to be discharged yet, and died shortly after being discharged. We see it with Dawn Wooten and these forced hysterectomies that were happening just last year. She literally risked her career, risked her life to show that this is oppression that is ongoing and no one is talking about it. We see maternal mortality. We see death rates disproportionately during this pandemic. There's just so many things and examples of how racism continues to persist in this system. So I think that it's especially important to take this timeline into consideration when we think about this idea of vaccine hesitancy, when really what it is we Black folks are not fond of oppression, right? So when this has been the trend over time, you got to know how to protect yourself. So I think that this is a really important point and thing to think about as we think about how the medical institution has impacted the Black community. And this is just a quick look at Carl Linnaeus's chart. So you can see here that he had these different species: Americanus, Europaeus, Asiaticus, Africanus. And you can see all of these different stereotypes associated with them. For example, for Africanus, you see Black, phlegmatic, lazy, sluggish, neglectful. A lot of these same things continue to be associated with Black people today. So really, this was like implanted in our minds by the medical institution, and it's something that continues to be, unfortunately, abided by a lot of our society. So now that we've kind of thought about the history, now I want to just briefly discuss 5 cases of racism in medical education that I've seen that I saw during my first year of medical school, and then I'm now continuing to see as I'm in my second year. So first, there's this issue of representation. I remember when we first learned how to do CPR, we were in anatomy class, there was always this understanding or this idea that the bodies that we were going to learn about and the bodies that we were going to learn off of were always going to be white, because that was the standard of this idea of the dominant caste, right? So I wasn't even learning how to recognize certain physical exam signs, learning how to really normalize treating my community. And what really took the cake for me is like one day when we were learning in microbiology class about Borrelia burgdorferi, the spirochete that causes Lyme disease, we were shown this rash, erythema migrans, and told that that is often what presents in stage 1 Lyme disease. Not in everyone, but it does. And one of the students in our class, a Black man, raised his hand and said, "Hey, how would I recognize this rash in someone who looked like me?" And the professor really didn't know how to give him an answer. He said, "Well, it doesn't show up in all patients, and it's just more difficult to see in Black patients." And that was the end of the story. But that didn't sit right to me. So what I did is I did some Googling, and I went on to find that Black patients are more likely to present with later stage Lyme disease. And partially, people believe that that's related to the fact that we're not taught to recognize the early signs of Lyme disease in patients with darker skin. So this was just one example of how we see the education that we receive being inherently racist, leading to bad outcomes, problematic outcomes for patients of color. So that's why I wrote this piece, How Medical Education is Missing the Bullseye. I had never published in the journal ever, but this was kind of like the impetus where I was like, there's something wrong with this system, and I have to do something about it. We have to do something about it because it's affecting our patients and our communities. So then there's this issue of statistics. And I'm sure many of us have been in a class where they've shown a graph like this, showing us that people of color have been disproportionately impacted by said disease. Said disease, you can put in cancer, you can put in diabetes, hypertension, whatever you want. And oftentimes this is their attempt at showing us health disparities, right? Like 2 slides, they end here and that's it. But there's oftentimes no context around the discussion. We're not talking about redlining. We're not talking about accessibility. We're not talking about socio-political forms of racism. And those are all of the reasons that really drive a lot of these health outcomes. So what happens is a lot of our classmates will leave class thinking that these communities are inherently damaged when we know that's not true, especially because, once again, Carl Linnaeus, the medical institution, is what was really pushing this idea of race. So we know it's a socio-political construct. So therefore, we can't just say that, yes, these races have disproportionate impacts or disproportionate outcomes, and that's it. We have to dig deeper because we know it's deeper than that. And until our institutions really start to look at this issue, we're going to continue to see bad health outcomes because we're not doing the work to figure out what's driving these disparate outcomes in health. And then there's this issue of race-based medicine, which is directly related to what I was just talking about with statistics. Once again, we're being lazy. We're saying that, oh, well, these outcomes have to be related to race. The reason why this group has more creatinine than the other one is because of race, but we see that it has disproportionate impact on patient outcomes. In the case of estimated glomerular filtration rate, we see that for a 65-year-old Black man and a 65-year-old white man who have the same creatinine level, one is eligible for a transplant compared to the other because of the algorithm and how race is included in that algorithm. And then we think about spirometry, right? And we think about how Samuel Cartwright, who created this idea of drapetomania, he was a big proponent of spirometry, and basically said that Black people just naturally have worse lungs. And the reason why he was using this as an excuse to keep Black folks working in the fields, forced labor, so that my ancestors could strengthen their lungs, right? That was the reason behind him using this entire ideology. So we still see it today. We have patients who live in these areas where their lungs aren't doing well, but we're just saying, well, because you're Black, that's just how it is, because it's just ingrained in our systems over and over again, and it's lazy. We need to dig deeper. We need to do our homework to figure out what can we really think about that's behind the health outcomes and the patterns that we're seeing, because it's extremely problematic. But I am excited to say that I recently saw this on Twitter, and by Dr. Monica Hahn. She posted this and talks, and she's basically sharing with us that the American Society of Nephrology, after years of advocacy, most of it led by students and activists, have decided that race modifiers should not be included in equations to estimate kidney function. And it looks like there might be some good changes on the brink. And I think that a lot of institutions have gone out and said things against this. So I think that we're moving in the right direction, but it shouldn't have taken this long. So then there's this issue of fear and fatigue, right? Like I just talked about how the reason why this association decided to make this change is because there were so many people coming forward. But it takes a lot to come forward and say these things when you're a medical student, for example. And we think about this totem pole and this hierarchy of academic medicine. And then you also think about the intersectionality of being a person of color, or you think about being a person who is a gender minority. Like these are different struggles that you have to deal with. And on top of that, you're fighting against a system that's actively oppressing you. So that is why a lot of folks are leaving academic medicine. And this was a piece that was written by Dr. Uche Blackstock, and she talks about why Black doctors like me are leaving faculty positions in academic medical centers. And this is one of the keynote speakers for this amazing conference, and I'm sure that she'll talk more about this. But we can't continue to put the onus on those who are experiencing the oppression to rise up, right? Like, of course, naturally, we're going to rise up and we're going to stand for ourselves. But at the same time, we're trying to be students. We're trying to just survive, learn medicine so we can serve our communities. And it's a lot of pressure that you put on these individuals to be the advocates and also be the ones who are vindicating and liberating themselves at the same time. And then case number 5 is the buy-in issue. And the reason why I call it the buy-in issue is because for all this time, students have been leading all of these efforts of anti-racism. You have some of your faculty advocates, of course, but oftentimes it's put on the students to make these institutions better. So you spend your entire medical career or your entire medical training doing this work. And of course, you're going to do it because you're passionate about it. But really, if institutions in academic medicine seek to really be anti-racist, they need to be driving these changes themselves. It shouldn't be us having to do sit-ins and us having to write letters and petitions. Of course, we're going to continue to do that. But in reality, if these institutions care, they will be driving the change themselves. And if they want students to drive the change, they need to make sure that they compensate us. They need to make sure that they're giving us scholarships, financial incentives, making sure that we're taken care of for all the efforts that we're putting in addition to trying to be students. So these are really the 5 cases that I've seen, and I'm sure that y'all have seen examples of this at your own institutions, and I really look forward to learning more about your experiences later on. So now, way forward, steps toward anti-racism in medical education. So I think that number 1, we need to make sure that people understand that it's racism, not race, that is the risk factor. Then we need to incentivize social justice advocacy and mentorship. So in addition to making sure that students are incentivized, we need to make sure that the faculty mentors who are putting in the time to make sure that we're mentally safe in these traumatic spaces, making sure that they're also incentivized for that mentorship that they're providing us. Making sure that when we get a grant to do something in the community, that that's valued as much as getting published in Nature or getting published in an academic journal, because we need to make sure that we're incentivizing praxis, or else we're just paper. It's like this publish or perish mentality, right? So we're just paper pushing, but we're really not making sure that that results in actionable change for our communities. Then we need to increase recruitment and retention of Black trainees and faculty. And I think the next slide will be a perfect example of how we need to put in work there. And then lastly, lifelong learning. I'm going to give y'all some tools, some people to follow, some things that have really helped me throughout this journey. And I think that the reason why I say this idea of lifelong learning is so key is because a lot of people think they can stop at Robin DiAngelo or Ibram Kendi and the anti-racist books and be like, yep, I'm good. But no, anti-racism is something that you have to be working toward every single day. And the moment that you're not, that's when you start basically contributing to the oppression, because you're doing it in mindless ways and ways that you might not even realize. So it's an active, ongoing effort. So we've seen that when we think about this idea of retention, we've seen Dr. Dinar go through challenges. We've seen Dr. Corey go through challenges as well this year. Black women who have actively been pushed out of academic medicine for speaking their truths, for being too Black for certain applicants. This is a huge problem. And I think it's related to the fact that a lot of these institutions, they bring us to these spaces, put us on pamphlets, make sure that their diversity piece is a good look, right? But then what are you doing to take care of us? What are you doing to foster an environment where we truly can thrive and be joyous and really care for our patients and communities in a way that is promoting healing, right? So I think that these are things that academic institutions definitely have to work on. And I'm so thankful for these two women for their courage and for all of the work that they've been putting in to make these spaces better for us in the future. So then this idea of lifelong learning, I just want to give y'all some of the different tools that I found helpful and I think will help you. The Anti-Racism in Medicine podcast with the Clinical Problem Solvers. I get to do this podcast with these amazing team members. Dr. Essien and Derek Paul, they pretty much have led this effort and were so gracious to bring us on, and it's been phenomenal. I think the Prioritizing Equity series by Dr. Letha Maybank, who continues to be a phenomenal advocate, is something y'all should definitely check out. And Dr. Brittany James in Chicago, she's created the Healthcare Anti-Racist podcast as well. And there's so many others out there, but I think that these are really core ones that I think that'll get into conversations that'll be nuanced and extremely helpful. These are some people that I think y'all should check out and follow. This is not an exhaustive list, but these are just some dope folks that I think will be really helpful in providing some more context around this conversation. Please feel free to just take a screenshot of this and just give them a follow. I wouldn't be surprised if most of y'all are already following them because they're just so dope and are really big voices in this space. And then here are just some more resources that I think have been really great. Websites. The A&P Lab has been putting out great data around the disparities that we've seen during COVID-19. Kaiser Family Foundation has been coming out with some really great information. They just partnered with Dr. Rhea Boyd to come out with this series called The Conversation, where like Black health providers and scientists are answering the most common questions about the vaccine. Then there's books like Medical Apartheid, The Color of Law, Caste, all of these absolute fire. So I really recommend that y'all check them out. So with that, I just want to end with this quote by Toni Morrison. And she says, "The very serious function of racism is distraction. It keeps you from doing your work. It keeps you explaining over and over again your reason for being." And this is something that I hold close to my heart, especially when academic medicine is out here doing something wild again. When people out here saying the physicians can't be racist, when y'all see that they've been directly implicated in the active oppression of Black people. These are the times that I really call back to this quote. And I say, you know what? We have to just continue to ground this work in love and healing, because we can't let racism take that joy. We can't let racism make it so that it's all about fighting back at these individuals, right? But this work has to happen as a unit. It can't just be the individuals who are at the end of the oppression. So all of our allies here, please continue to step up and use your voices and privilege. And I really hope that this presentation was informative. I hope it was healing in some ways and really recognizing that these things exist and the gaslighting is real, but I hear you, I'm here with you, and I'm looking forward to engaging in dialogue with more of y'all later today. So with that, I want to say thank you. Please feel free to email me, follow me on Twitter, Instagram, DM me so we can continue this discussion offline. And thank you all again for just inviting me and having me share this space with you.
Awesome. Thank you so, so much, Lash. I think the quote, racism, not race, is the risk factor, is obviously something, a key takeaway, especially given, the recent tweet that we've all likely seen from a large journal. Thank you so much. That was a great start to the conference. Coming up next is our first panel called Getting Uncomfortable, How to Discuss Race, Gender, and Other Identities within Healthcare. So we will take a quick pause and we will then welcome our panelists in our next session. Thank you all so much. Also, feel free to stay on this Zoom link for the entire day. All speakers and workshops will be within this Zoom link. So we'll just take a quick pause before the next panel. Thanks so much.
Hello, everyone. Just hang tight while we switch over to our next panelists. Hello, everyone. My name is Majd Makbel. I am a fourth-year med student here at U of M. I'm going to be the moderator for our next session, Getting Uncomfortable, How to Discuss Race, Gender, and Other Identities Within Healthcare. So get your favorite blanket, your favorite drink. This is going to be very important discussion. We have amazing panelists here. And I will just ask them to introduce themselves whenever their video pops on. There we go. Dr. Cejas, do you mind introducing yourself?
Sure. So my name is Diana Cejas. Pronouns are she, her, hers. I am a pediatric neurologist at the University of North Carolina and faculty at the Carolina Institute for Developmental Disabilities. Most of my clinical work centers around patients with neurodevelopmental disabilities and complex neurological and psychiatric conditions. My research focuses on the transition to adulthood for that population and really improving communication between healthcare providers and young disabled individuals, particularly disabled people of color. And I kind of like to say that I live in the disability space full time. Because I also identify as a cancer survivor, stroke survivor, and disabled doctor. I'm really happy to be here today.
Thank you. All right, Dr. Palermo.
Good day, everyone. My name is Angel Palermo. I use she, her, hers. I'm the Senior Associate Dean for Diversity, Equity, and Inclusion at the Icahn School of Medicine at Mount Sinai in New York City. And I'm also faculty in our medical school. I work at the intersection of diversity affairs, medical education, and community-based public health. My training is in public health. And so I come into this conversation as self-identifying as a cisgender woman, first gen, second generation Puerto Rican, and also as a lesbian. And a Mets fan, by the way, even though I live in the Bronx. So I'm here and I'm excited for this conversation.
Thank you. Lou, would you mind introducing yourself?
Hi, good morning, everybody. Unlike my two co-panelists, I am not a medical doctor, nor am I in medical school. My pronouns are he and him. I live in Houston, Texas. I identify as a queer transgender man. I spend a lot of time talking to healthcare providers about the barriers for trans and non-binary folks when they access healthcare. And I know that if we could educate medical school students that when they go off to do their residencies and their fellowships, we could actually change a lot more, because I know that this generation is probably wondering why we're not doing this rather than what do you want me to change? So I'm really happy to be here. Thank you.
Thank you. And we have one more panelist, Dr. Hussein, but she's still in the OR right now, so we're going to give her a little bit of leeway, understandably, for joining us. So let's get started. I guess I will ask us the first question. It's kind of a general one. How can we become more comfortable addressing these topics with patients, peers, and learners in terms of discussing like race, gender, disability, and identity? And I will leave it up to whoever wants to go first.
I would say that the first thing that we need to do is start talking about it. I think that within medicine, there is just, I don't even know how to say, but there's always just traditionally seems to be this willingness to not want to address things, to just kind of sweep things under the rug. I think that, we can think of current events where people have maybe said or done something that was racist or otherwise discriminatory. And rather than addressing the harm that is caused when these events happen, which they happen all the time, there's just this tendency to just kind of be like, oh, we see you, we hear you, sweep the event under the rug, and then nothing is ever addressed, nothing is ever brought up. And I think that really, if we're going to talk about trying to address these issues and how medicine has been harmful to minoritized individuals, some of that is going to have to come with like this culture change. It's going to have to be like a top-down kind of a thing where it's not just the person who identifies as a minority is bringing up these issues and saying, hey, we need to address what's going on. I think that it's going to have to be where people who are at the top recognize, hey, we have this problem. We are in this system that has been perpetuating bias for as long as it's been here. Let's do something about it. Let's try to actually look and see what we're doing and see what we can't do to make things better.
I would just like to add, I think it's difficult because we hold on to this idea of a right to comfort, right? Like I don't want to make room for emotional and psychological discomfort. So I'm not going to talk about it. And therefore you maintain status quo. And I think those of us who have, we all straddle identities of privilege and oppression, right? If you're literate and you're native English speaking, right? You're sitting with identities of privilege. It brings you closer to, access to resources and power and privilege, right? But then there are several identities that many of us have that are housed in groups of oppression, and that is where we are experiencing a daily, persistent, chronic discomfort, disadvantage, you name all of those things. And so I think that absolutely I agree with Dr. Sejas is that dialogue creates an opening for stepping into the discomfort. I think it's just how not many people are equipped to set up the space for dialogue and actually facilitate using anti-oppressive techniques so that, it becomes, people confuse dialogue with a conversation or a debate or a discussion. And I think that medicine in particular, as much as I've taught in the medical school for the last 20 years, we don't teach you how to teach. Like we don't teach you how to teach. So, and yet that's like, the core function of your role is to teach, your patients about their illness, their condition, and then of course learn. So it's so ironic that, there's no accident as to why it's difficult. There's no accident as to why, there is a profound sense of resistance, avoidance, and denial. And yet those of us with marginalized identities or identities from oppressed groups that, trying to have that conversation is challenging because you're also negotiating the conditions of that environment in medicine, which makes no room for, these other ways of showing up, such as, collaboration and, conversation. And, instead, we're trying to adapt to the conditions, which is keep status quo, stay in your lane, don't disrupt, and be quiet and do your thing. And there's only one way to do this. And you deviate, there's a ripple effect that puts you at further disadvantage, pushes you further away from, accessing the resources you need to be successful in this journey of the profession. So.
Yeah, that's a lot. It's hard to follow the two of you. There are a couple things that I'd like to mention, though. I think that in our society here in the United States, and by society, I generally refer to that as being white, cisgender, heterosexual, and probably Christian of some form. That is our mainstream society in the United States. And we have been taught, being raised in a white family, I was taught not to have those difficult conversations about race, sex, or religion. And I think that that's one of the reasons that we are where we are today, because we're not taught to have difficult conversations. So we don't have difficult conversations. And we're terrified, I think, as humans and in those ways of making mistakes. And so instead of putting ourselves out there with some sort of cultural humility or anything, we don't want to learn because we're terrified of making mistakes. And I think that definitely comes to doctors because of the pedestal that our society puts doctors on, that they know all, and therefore their word is this. And so it creates, the disconnect between doctors and patients, or doctors and even I think medical schools, with that hierarchy. And so people that are entrenched in what they're doing, the doctors that have gone to medical school for a long time, don't want to learn anything new. And so one of the ways that I've learned that we can get doctors to even a CME to talk about sexual orientation or gender identity is through ethics, because it's one of the hardest CMEs that they have to get. And so it's like, but this shouldn't necessarily always be under ethics of why you want to be a good doctor and a good person. The other thing for me about medicine is that medicine also comes from that place of being around white, cisgender, heterosexual, Christian of some sort people at the top. And that is what is continuing to be taught. That is, from what I understand, the didactics are all centered around who is in the hierarchy. And so it's very hard for those of us, and I like what Dr. Palermo says, is just not just marginalized identities, but the oppressed groups, to have a conversation, because so many people don't want to hear it. And so we have to be able, that we need people in positions of power to have some sort of cultural humility. And when they don't, then we are stuck trying to continue to push and push and push. And so it puts the onus on the people in these oppressed categories to continue to have these conversations. And quite frankly, like, I'm tired, right? And when I'm pushing against a barrier, it takes a lot. And so it's very hard to get institutions to want to change, because sometimes you just get so tired as somebody who's pushing against the barriers of how to do it. And so who wants to make the change? I think they both mentioned that it's got to come from the top down. And if that top doesn't want to make the change, or they think, look, we're doing this and it's the bare minimum, we have a racial D&I thing, you showed up, you checked the box, you were here for that 1.5 hours, moving on, but you don't hold them accountable, right? There's so many extra things that need to be happening within a standard operating procedures of how things happen within your institution. So it's not just a good policy, it's good actions.
Wonderful. Thank you guys all for answering that question. Next question we have is, how can we advocate for patients who may be adversely affected within the clinical setting when the system overlooks their individual needs? I guess just to make things easier, we can go in the same order. So
I think, when I'm thinking about this question, one of the first things that I'm thinking about is how we as physicians talk about patients. Specifically thinking about some of the language that we use, which is really stigmatizing. Things like, a non-compliant patient, or this patient complains of this, or this patient, is, even if you're thinking about even more negative words, thinking about like drug seeking and words like that. I think we need to be aware, and this sounds like such a cliche, but our words have so much power. We're already in this, the difference between doctors and patients, there's huge power dynamics that are at play. And when we're using this stigmatizing language, I think that we need to take a look at, one, who are we using this language to describe? Is this traditionally a person that, is this a person who is not white? Is this a person who is disabled? Is this a person who belongs to another kind of minority group? And take a look and see like what that means. See how we are kind of, showing our own biases in the language that we're using to describe patients. I think if we can take a look, especially, one of the things that I talk about a lot in talking about advocating for patients is ableism, and specifically thinking about all of the ways that medicine is just a really, really deeply ableist kind of a system, where disability is something that's supposed to be fixed, and if you're not fixable, something is wrong with you. I think if we can start to, again, try to individually and on a systemic basis kind of address our own biases, then maybe we can start to realize, I could be a better patient and I can better advocate for my patient just in not looking at them as a pathology, not looking at them as something that needs to be fixed, actually looking at them as a person and recognizing that even in these situations where maybe a patient isn't doing what I want them as a physician to do, Maybe I need to come to them, talk to them, try to figure out what the situation is, so that I can figure out how to best help them and get them to where it is that I think that they need to be, and also where it is that they think that they need to be. I think in thinking about those things also, there's so much of, social factors that kind of they could come into the language that we use, the situations that patients find themselves in. And I think if we can kind of separate our, drive to put patients in a box, which is usually, again, a deeply ableist and stigmatized kind of a box, maybe we can try to see if we can, actually treat the person who's in front of us and try to advocate for the things that would make them the healthiest and get them to the places that they need to be.
I just want to add that, the profession itself needs to take responsibility for how we train you in medicine. We train you to be biased and prejudicial and, quite frankly, racist in medicine, right? So, you come into medical school with your biases, conscious or unconscious, right? You've been socialized, however you've been socialized in your upbringing, to have stereotypes and particular points of view, attitudes, beliefs, and judgments. And then we leverage that by teaching you how to overutilize and utilize those stereotypes, by teaching you medicine through pattern recognition, checklists, rubrics, using clinical decision-making tools that use binary variable, demographic variables. And so we reinforce it, validate it, confirm it, and then you adapt to the environment of advancement in the field by demonstrating that you perfectionism, right? That you get nothing wrong because we teach you what to pay attention to or what to expect. So everything else you're blind to. And we socialize you into that mindset. So that is your mental model as a medical student. And then you get rewarded because you've done well on the step in USMLE and and you're learning in the most rigid hierarchical environment next to the military, right? So that rigid hierarchical structure is bounded by power and privilege. So that mental model that we're socializing you to has become reinforced and tightened and sharpened. And so there is no accident as to why there are disparities by race, ethnicity as a result of provider bias, because you have been socialized, and that is the water you are swimming in. And it's so damn close, you can't even see it or identify it until something happens, enough to make you shake and sort of step back and reflect. And so what can you do for your patients is to stay ongoing self-interrogation. In academic medicine, we create this mindset of you, and I'm saying you as the larger you, not as an individual, to have this way of thinking that it only goes one way, and this is how you move through, and you stay intellectual about it. There's no room for deep thinking and reflection and dialogue. And so that's the answer to your first question. So within yourself, my recommendations are to stay in reflective. This is a journey. There is no destination to say, "Ooh, I'm anti-racist. Ooh, I'm anti-oppressive. Ooh, no." And even for people of color and BIPOC people, we are socialized into the same water, right? And then we internalize that oppression. And also we have internalized, supremacy around certain identities, right? I know that I have the privilege of being an able-bodied individual, and I recognize that privilege. But I also have to be responsible for how I manifest that privilege in my community, and don't make room for people who are not able-bodied. So it's complex, it's fluid. So you have to stay in ongoing reflection and recognize patterns, and stay self-learned about this stuff. Don't read about what's happening in medicine, read in the other disciplines as well about these issues. I think within your clinical practice and research, I think you need to recognize and challenge white supremacy ideology. It manifests in the most insidious ways, and I'm sure Lash called it out in her keynote. I think you need to talk to patients about racism and not just race, but you need to learn how to do that. And therefore medical schools need to teach our students how to do that, right? and tap into building your capacity to understand structural competency, not just social determinants of health. Those social determinants of health were produced by structures. They didn't just pop out of nowhere. And so, you know, we in medicine and medical education need to teach you that early and hold our educators accountable for reinforcing that knowledge and understanding throughout your training, and teach you the actual words to use to talk about, have you ever experienced discrimination based on your gender? Tell me about it. Have you experienced discrimination based on your race? Tell me about it. Have you experienced discrimination because of all these identities? What's that like? How does that impact your health? Who have you been taught that in medical school, right? And that's the missing opportunity here. And I just think in generally within your sphere of influence as a trainee, as an attending, as a you know, whatever role you have in medicine, is to call out and challenge structural racism within your sphere of influence or control, right? And take small steps towards working towards transformational change, because change happens, but it only happens at the pace of trust, and it's slow. You got to be patient. And throughout all of this, you need to have a healing strategy in place, because we're quick to act and do and activate and advocate, but when we're not taking care of ourselves along this journey, that is the most brilliant strategy of all, because that's called burnout. And then where's the gain?
Wow, I wish I would have gone first in the very beginning, because this is getting harder and harder after you two. But a couple of the things that I jotted down while listening was, I think sometimes patients need a navigator, right? As we're talking about this with a language that is being used by our providers that we don't always understand, we don't understand systems. As somebody who lives with chronic pain, like, sometimes it's so hard just to get myself moving and everything, and then to go to the doctor and then try to understand what my next step is. Like, I need help. And where is that help? And if you start asking for help, people get really frustrated and really just like, here's your information, make that call. And it's like, oh my gosh, I don't have the energy to make that call. Oh my gosh, now I have to get from point A to point B. And they make it so difficult. And I believe they want to make it difficult because, right, they only want to see who they want to see. And it's that way where people with social economic disadvantages are continued to be pushed down and continued to be held down. And we see that in many different areas as patients, but also as who ends up in medical school, right? So if our medical school students are coming from these privileged places, whether it's able-bodied, whether it's white, whether it's whatever, you know, from the richer kids in class, because they're more advantaged to get the better grades, to do all of these things, who's teaching who, right? And so these systems are continually perpetuated within our schools, within our institutions, as they get filtered out into our communities. And so that's also something I think we need to be thinking about as they go forward, as our students go forward. Also, I think that as Dr. Palermo says, right, if you say, have you been discriminated based on XYZ, you have to stop and listen. And how much time do our doctors give us? Like, I am so thrilled that my medical provider, my general practitioner, when she comes in, she brings her laptop and she sits and she listens. And I am more than happy to wait if my appointment is late, because I know that that means she's giving other patients the same attention that she's going to give me, and that she listens to me and says, oh, well, and if she doesn't know the answer, she looks it up on her laptop rather than expecting me to provide her with an answer. So this chronic pain that I'm talking about, I had a chronic pain doctor a couple of years ago, and I went to him and I was in so much pain, and I'm sitting there and I'm just like, I'm in pain. I'm like, I need some help. Like, something's not working. I can barely function. And he looks at me as I'm sitting there bare chested and everything. He goes, what are your scars from? And I'm like, I mean, it's all in my chart, right? I am a transgender man. I've had top surgery. In your world, it's a double mastectomy. He goes, well, can I ask you about that? And I'm like, oh my God, I'm in pain. I'm here because I need you to solve a problem. If you want to bring me back and have me educate you, I'm more than happy to, but you can pay me rather than me sitting here and paying you, right? Because that's what I'm doing. I'm paying you for your expertise. And while I'm in pain and I'm sitting here needing your expertise, you're wanting me mine. I was so frustrated, and like, I almost wanted to cry, but I needed this guy's help. I needed somebody's help that I wasn't getting. And And so I think that that's something that we're always expecting those that are most marginalized, Dr. Cheha said it earlier, of those that are most marginalized to be telling us what they need. And I think that comes to another point that I've learned last fall is like everybody needs two mentors, one older and one younger, or one more advantaged, one less advantaged, because like it's not always the people that are further along in their studies or in their workplace that can teach us things. Like I'm a 50-year-old dude. I don't understand TikTok. I don't understand some of these things. I have some of my college friends that are in their early 20s that are explaining new things to me, even about language around the LGBTQ plus community, because our language evolves and changes. And if I can't keep up, who's going to teach me? Well, go get a friend who can help me learn, right? And I think that that's where doctors get stuck in their niches of this is what I know. Nothing in this is changing. I went to a provider a couple of years ago and I was on PrEP. And so I wrote down that I was taking Truvada because, got to disclose it. She's like, oh, I didn't know you were, and she's like, I'm like, what? And she's like, well, you haven't disclosed that you're HIV positive. And I'm like, because I'm not, right? So she saw that I was taking Truvada and just automatically made an assumption based on the fact of what my drugs listed were. And so then here I am educating my doctor on what I'm taking PrEP, what Truvada and what PrEP is. And so it's that lack of willingness to learn outside, but then making those assumptions and attaching something to me based on the limited knowledge that she had. So those are just some things that I think that need to change. And I think we really need to listen to the students that are in school now over what they want versus the same thing happening over and over and over again.
Thank you all for those great answers. For those that haven't had coffee yet, I'm pretty sure that would have woken you up, all those three answers. Just a quick logistical things. When you guys are for the participants, when you guys are in the chat, make sure to put it at all panelists and attendees. So everyone watching this can also see your comments. I guess we have a question from the audience. Eric Kautz says, are there specific training modalities that would help to address bias or racism in medicine? I think many people feel that diversity computer trainings are only partially effective. I was wondering if there is a way to train that produces more uncomfortable, more challenging, and more memorable environments safely. And Lou, you want to take this one first?
I'm not a doctor. I don't know your modalities.
That's fine.
So I'll defer to the other two. Thank you.
I'll try to answer this question because it's I think in medical education this is a very new space for medical education to create a learning and training environment that that can achieve this. And it's super challenging because when you think about setting up the conditions for such an environment to learn in, you have to think about the students, the content, like who's teaching, when you're teaching it, how you're teaching it, and where you're teaching it, as Lou shared earlier. And so those modalities, and so remember, physicians aren't trained to teach, and they're not teaching with a pedagogy in mind, right? And this is where we need to step into other disciplines and invite them into medicine to transform the learning environment. So one of the things that we've been working on this at Mount Sinai for the last 5 years, right? How do we actually transform the learning environment so that it is an anti-racist, anti-oppressive learning environment? And the lift to do that is huge because you have to understand that there's resistance, massive resistance, because physicians and particularly the old guard of doctors, right? You have this mindset and there's only one way to teach. This is how we teach this because I was taught this. And that apprentice model is so deeply embedded in the way you teach and learn medicine. And so undoing that is a threat. And so now it's about, well, how do we actually bring in, how about we bring in, anti-racist educators, racial equity scholars, people who know how to teach in this space, folks who are trained in critical race theory, anti-oppressive frameworks, and bring and convene them with the content experts in science and medicine, and actually redesign the curriculum together, while equipping faculty with the techniques and teaching practices. You know, one of the things we started doing now is actually doing faculty development around anti-oppressive facilitation techniques, right? Because there's a ton of small group learning. There is teaching at the bedside. There is rounding. There's all these small group micro learning environments that happen in your training, and the attendings, the residents, the faculty, the preceptors are not necessarily equipped to how to facilitate those moments to ensure that everyone has a voice, that all points of view being considered, that there is a, you know, thinking towards the greater solution of the patient, et cetera. And disrupting, you know, the loudmouth, the one who always wants to be right, just, you know, disrupting all of that. So I think this is it's a wicked question, which I appreciate. And there is no specific answer, because I think the various medical schools are beginning to generate different strategies, and we have to pull in the other disciplines outside of medicine to actually do this work, because we can't do it alone in medicine.
Sorry, my cat is like scratching a bunch of stuff. I was trying to get her to get her to stop before I answered. But yes, I mean, I totally, just to kind of piggyback on that, when I was in residency, after multiple instances of, you know, various microaggressions and other things, which I can't get into at this period of time, one of the things that I recognized was, you know, we didn't have this education, we don't have this training in my particular training program. So what some of my co-residents and I did was we created a curriculum that was based around these things. But again, thinking about what Dr. Palermo was saying, we don't teach people how to teach. We ended up, you know, consulting with people outside of our department, people outside of the School of Medicine, to kind of help us figure out what it was. Because we thought that we knew what we wanted as trainees, the education that we wanted to receive, but weren't quite sure how to get that education, where to go to get it. So we ended up talking to a bunch of people in medicine, outside of medicine, in schools of education, to try to figure out how to develop our own curriculum. It was very much for the program that we were in the city that we were in, and also specifically kind of as a response to some of the micro and macro aggressions that we were personally receiving. I think it would be lovely if there were, you know, these kinds of big national or even international training programs against bias and racism and ableism and all of those isms. But I feel like some of the work is going to have to be at this kind of small local level, because there are so many different experiences. Every program has its own kind of flavor and various things that, I mean, that yes, certainly, you know, we should be, you know, trainees and faculty should be taught about like major biases, all kinds of things, but then you've got your own little cultural subsets within your communities, within the communities that you're serving, and you need to learn a little bit more nuance. So again, I would love to know if there are any of these bigger training programs. One of the things that I'm having, you know, an issue with now as junior faculty is, thanks to 2020 and everything that has come up as a result of that, now, you know, even within my department where I am faculty, we're having more conversations about these things, and people are like, I want to take some anti-racism classes. I want to take some anti-bias classes. And it's like, yeah, okay, yes, that would be nice. But we also need to do some more learning and consulting with people who can kind of teach us how to really learn and better approach these kinds of issues.
Hey, I'd like to make one comment. I'm not in medical school, but one of the things that I've noticed is that, because I talk on LGBTQ issues, if students are getting topics, conversations, classes, they're always electives, which means you're only opting in if you care. You're not learning this because you need to learn it, because I guarantee you, no matter what your specialty is, you are going to see queer patients somewhere, somehow. And if you don't have that knowledge, you're gonna that trust that needs to be there between patient and provider is never going to be done, because you're not going to ask the right questions, or you're going to say something that is triggering, so I'm not going to come out. And I think one of the things that providers need to be doing is thinking about whole health, right? As a 50-year-old queer trans guy who predominantly sleeps with men, who lives with diabetes, major depression, anxiety, and chronic pain, right? My whole world needs to function together in order for me to get out of bed. And if one of those things are off, I'm probably in my pillow fort just hanging out, right? And so everything needs to be learned. And when people are allowed to opt out of these other things, whether it's a class on race, whether it's a class on LGBTQ issues, that makes it, that it continues to other those marginalized and oppressed positions. And so how do they, I think what really needs to happen for our future medical doctors, providers, is we need to revamp the curriculum that is happening within our medical schools so that these things aren't taught as something that is there. And I battle this. I live within walking distance of the world's largest medical center. There are 3 medical schools within a 15-mile radius and one about 45 minutes down the road. And the way that that curriculum is being taught in those 4 medical schools is vastly different, even though 2 of them belong to the same system. And here in Texas, I think all but 2, we have 6, I believe we have 16 medical schools, and all but 2 belong to the exact same system. Actually, I think 3 now. And those 3 are private. 2 of them are private. One is whatever. Even the ones within the same system, the same big state system, don't have the same curriculum. They don't follow the same modalities. So if you go to, it's the University of Texas, and if you go to the University of Texas Medical School within Houston versus the University of Texas Medical Branch in Galveston or San Antonio or anywhere else, it's not the same. And that is so frustrating that when you're talking about people that have marginalized identities are having to push up against, where do I go to get the best education and what is it based on? There is so much to compete with, right? So I just wanted to add that.
Thank you, Lou. So we have one more question, or a few more questions. I guess you already touched on this a little bit about how Dr. Palermo talked about not just reading or about reading and self-reflecting, but how do we change this on a systematic level? Lou, you talked about standardizing it, making it part of the curriculum, not making it opt out or opt in. I was wondering if Dr. Palermo and Dr. Syphilis have anything else to add to that.
The answer is not, do this, do this, do this. I can't give you an answer like that. I've been at Mount Sinai for 21 years in diversity affairs. The last 5 years has been the most exciting part of my career at Mount Sinai because there has been a pivot to go beyond diversity, equity, and inclusion, really diversity. Diversity in my mind, I know it's in my title, it's the space that I occupy in the academic medicine, but it exists because of racism. So that's not lost on me. And yet in the last 5 years, it's been, the pivot has been, let's actually confront this and talk about it. And I have to say that we have been at changing the water, and I'm going to refer the system as the water, right? The culture we're all swimming in. It has been 5 years of chipping away at changing the system. And that has taken multiple kinds of multiple people, students, faculty, leadership, and everyone has a different level of readiness to engage in this space. And some are still managing their resistance, even when it's not obvious, it's a hidden resistance. And so, I just want to really just say that, wherever you are in this learning environment, because it is hierarchical, pay attention maintain a critical consciousness, pay attention to how the system works. You know, even if you're someone with, you know, as a BIPOC individual and you are witnessing or experiencing specific events of microaggressions, macro assaults, all of those terms through the lens of race or through the lens of gender or ability, disability, pay attention to the patterns and the trends, right? And pay attention to the structures or the conditions or the policies or the practices that enable those patterns and trends to happen. Those structures, what COVID did, COVID revealed the system onto itself. COVID said, yeah, well, here's COVID, and then boom, racial injustice is parallel pandemics, revealed the system onto itself and showed us what the structures are and that exist and don't exist. That's why there's no accident as to what we're seeing, because we're seeing the system now at play. And so pay attention to what's at play with regards to this layer of structures, because then you want to think about, well, who's responsible for the structures? Who's responsible for the policies and practices that are at play? Who's responsible for setting up these conditions? And when you think that through, it's about, well, what's the mental model that's happening right now? And, you know, I tried to articulate that earlier, that it's really deeply embedded in a sort of paternalistic, perfectionistic, individualistic mental model. So there's no access to why the structures are the way they are. There's no access to why your learning environment is the way it is. Because those who have positional power designing that have a particular mental model and mindset that is deeply rooted and informed by norms and values and cultural norms of the profession called medicine. And so to change all of that, it's going to be incremental, and it needs persistent, consistent, critical analysis wherever you are along the professional journey and hierarchy. And it requires being able to understand the systems, have a systems thinking lens. It's not just what's happening in front of you. It is all, there's no accident why disparities continue to persist, because there is someone is benefiting from it. Someone's benefiting from health disparities. And there are various entities. So when you deconstruct that, you can reveal the system onto itself, because you know, when you see something, you can't unsee it, or when you know it, you cannot unknow it. That's what's happening. And so I invite you to develop a critical consciousness lens as a strategy to begin systems change through your various spheres of influence and control.
Thank you, Dr. Oh, sorry, Dr. Sayas.
No, go ahead.
Dr. Hussein has joined us. Thank you, Dr. Hussein, for making the time for us. If you wouldn't mind introducing yourself first.
Hi, everyone. Sorry I'm late to the conference. I'm post-call and had a very big trauma call night. Hi, Dr. O. I'm a trauma and critical care surgeon practicing in Florida, or I was practicing in Florida. I'm in Arizona right now. I am not your typical surgeon, not white male, made very well aware of that throughout my training. And so I'm also a mother of 6 whom I've had all of them during my training: intern year, second year, 4th year, chief year twin, fellowship baby. And those are other reasons why I was told not the typical surgeon, but I use all the experiences in getting to where I am today to point out that, you know, I'm sorry I joined late, but the speaker who went before me, that it's an entire system that is that we operate in that is designed to exclude us. So while we say we want diversity, equity, and inclusion, the very systems in which we operate are designed to keep diversity out. So, yeah. You know, currently not inclusive.
Thank you, Dr. Hussein. So we only have 5 more minutes left. I want to get to one more question I think is a very important one. As a minoritized provider, how do you balance the minority tax when often expected to educate peers and colleagues on this? How do you not burn out or how do you draw boundaries in this work?
I'm sorry, can you repeat the question again? You dropped off.
Yeah, sorry. As a minoritized provider, how do you balance the minority tax when often expected to educate peers and colleagues on this? How do you not burn out and how do you draw boundaries in this work?
So, you know, I've spent a lot of time and energy over the years trying to, you know, really take on that minority tax of educating, you know, everyone around me to make sure that they are, you know, comfortable with my presence or comfortable with the presence of patients who we serve, that who are, you know, not treated equitably. So, and I've transitioned over the years to focus more on changing the system from within, as far as addressing policies, addressing shortfalls within within our care of patients, and giving more attention to that than educating a single person. So I think it's important for us to realize that, you know, you may educate one or two people, and a lot of times they question your experience. They question, you know, whether your feelings of, you know, being murdered or being discriminated against are real. So, you know, and that gaslighting takes extra toll on you. And so I personally feel that, and this I teach all my minoritized students and residents, is that we don't have to take on the burden of other people's ignorance. If you have people who are actively resistant to change or to see your experience as real, then they are not deserving of our attention and our emotional labor. So one of the things that I focus on is, how do we change policies to make sure that, yes, I may be going through this emotional labor, but the next person who follows me will not have to face that. So I've, you know, focused a lot on changing policies when it comes to, you know, wearing a hijab in the operating room. Every hospital I've ever been in has had a problem with that. So, you know, we went above the hospitals and went to the AORN, which is the Association of OR Nurses, who, you know, write guidelines for all hospitals to follow, to change the policy to say it's discriminatory that, you know, you keep certain people out of the operating room because, you know, they happen to wear a hijab. Within hospitals, you know, our pain management regimens, we look at, you know, how do we treat patients equitably? So instead of focusing on one individual provider who may be mistreating patients, you look at the entire system. So I think if we focused our emotional labor and energy in educating people who just may not know better, I think it's worthwhile for us to take that energy and put it into something that is going to be more effective, more helpful for our personnel who are minoritized, as well as our patients who are being treated inequitably.
Thank you, Dr. Hussein. If anyone else would like to add in, I know Dr. Palermo, you have to head out soon. So if you want to take this one before you go. All right. Well, all right. I guess we could go to the next question. So this is one is, as a third year student, it's difficult to call out racism or gender bias in the clinical space because of the power hierarchy. You never know how an attending or resident will take this feedback or report it in your evaluation. Given that this hierarchy and the ethos of professionalism creates a conservative space that stifles change, how can we transform these inherent models of learning?
I'll say a little bit about, I'll respond to that just from experience at our institution. You know, we are where we are as a medical school in addressing racism and bias in the learning environment because of our students. They organized both our Black and brown students and our white students. You know, it was a cross section of students led by Black and brown voices And I'll never forget, it was the first time I heard the term anti-racism. They formed the Anti-Racism Coalition and had data. And so what they did was they requested a meeting with the leadership of the school, and they knew exactly who they were talking to. And they presented it like it was like a grand rounds. It was literally an academic presentation. They presented the problem. They had data to back it up. They had high anecdotal evidence. They had they did survey data. They had examples from the courses of slides, of quotes. They had documented evaluation data, and they laid it out. And they said, this is what's so. What's so is that you are actually training us to and priming us to be biased in these ways. And so we're sharing the problem, and here are potential pathways of solutions that we would like to create together or ask you to take on, since this is your job, right, as educated leadership, that this has to change. And so you could not see that and not respond. And as an uncle, we responded in a reaction, defensiveness, right? We got defensive and we were like, no, that can't be, right? Because it was disrupting our right to comfort of like being right. We know what we're doing. We're trained medical educators. No, actually, guess what? And you know what did that? Is because we're a medical school that practices holistic review. We bring in a diverse group of students into our medical school. We have the words activist and advocate and catalyze change in our mission statement. And then you want it to be convenient on how they advocate and call out the system? No, it doesn't work that way. We brought in this group of students year after year. We deemed them acceptable to be a student here, and then they call it out. No. So we got defensive. We had to move through that, and then we moved towards, okay, let's actually figure out how to create transformational change. And so, you know, I just say that it unfortunately in those environments that are deeply conservative and holding on to the tradition, it is the burden on the student. You know, it wasn't diversity affairs. We couldn't call it out. Now, behind the scenes, we'll help them out and strategize, but we couldn't call it out. And so the other piece is that the students worked with allies in other medical schools. They also worked through the national platforms, whether it was SNMA, OSR, other, White Coats for Black Lives. And they rallied and created external pressure points. And unfortunately, that was the only way it worked.
Yeah, just kind of adding to that and thinking about, doing things on an individual level. I'm thinking about, going back to the evaluation thing and having negative evaluations or evaluations that you think are inherently, racist or biased in some way. And I mean, I dare say that probably all of us on this panel have had something like that happen to us in the past. But thinking about an experience that I had with an attending where it was a pretty racist evaluation, one of those definitely dog whistly kind of evaluations where I knew what was going on. The person probably knew what was going on, but if you look at the evaluation, you can have plausible deniability. And one of the things that I did was, just as Dr. Palermo was speaking about, was I found an ally. It was an attending that I trusted. This was another attending with another Black woman, talked about my experiences and tried to figure out exactly what I could do within the system in which I worked, which was a deeply conservative institution, to really just protect myself and, protect myself from that other attending, also protect myself and continue to be able to make progress in my environment. And thanks to her, I mean, this is kind of where the idea for our cultural competency and anti-racism, although we didn't quite call it that at that point, curriculum, that seed was kind of planted then. And I worked with her, and through, working with that attending and getting connected with other Black and Latino women that were in the organization where I was, I kind of had this, it was like a mentorship, also kind of a safety net, safe space for me, that I was kind of also able to connect some of my friends who were other Black and Brown residents, and we were able to kind of come together, develop this project. And we took it to our program directors, our leadership. We were saying, you know, this is something that we need. But, you know, it really didn't get as far as it probably could have until we had that buy-in, until we could say, yes, we have attendings that are here. Yes, you know, these are people who have position, who have power in the institution. These are people who think that they believe in what we're trying to do. And then we could really try to make changes, you know, on our little microsystems level and try to make bigger changes. But I really don't think that we would have gotten anywhere if we didn't have the protection of people who were farther up the food chain than we were. And then, you know, even thinking about it now, trying to find allies, you know, both within my department, within the School of Medicine, outside of the School of Medicine, and then really making sure that you've got to, I mean, it's terrible to say that, like, you have to have allies who are have enough power in the institution to really make these changes, but you really have to do that. And thinking about some of the things that we've been working on at my institution now, I think, again, probably we would not have had, you know, much success with any of the DEI efforts that we're working on now without having these people who are, you know, these high level, you know, endowed chairs have all this power to say, oh, yes, we believe in you. But of course, they wouldn't necessarily believe in what we're doing if we didn't have those, one, personal relationships, and then two, the data to back up what it is that we're saying.
Thank you, Dr. Zahas. Unfortunately, we are out of time. I want to thank you guys all for joining us this morning and spending time with us. It was definitely a great experience, great words, great lessons learned from all of you. I hope we all carry it with us going forward, especially as we become those higher ups wherever we go to be those allies for everyone else. Thank you again. The code for, there's like this code for attending this session. It's uncomfortable is good. After this, we have our poster presentation, and that will feel free to go to the attendees to go there and you know, browse around, see what posters speak to you. And the other panel after that will start at 11 a.m. So thank you guys all, and have a wonderful morning and enjoy the conference.
Hi, everyone. Just to answer a couple questions that have been coming in order to access the poster session, please log into your profile on the Socio account, and then you can go down to our poster hall where you'll be able to view our 80+ posters that we have from amazing presenters all over the country. Make sure to engage with them via the chat function and ask them any questions or comment, and our presenters know to be monitoring that and engaging with you back as well. If you have any questions about the poster session and you're hanging out in here, you can feel free to ask it in the chat as well. Thank you, everyone. Feel free to stay on this Zoom until 11. The next panel will start at 11 here. Otherwise, the link to the Zoom is through the Socio account or through the email that we've sent earlier this morning. Thank you all. Please go check out our posters from our wonderful attendees and presenters. Thank you.
Recording in progress.
Hello, everyone. We are just a couple minutes from starting. We're making sure that all our panelists are here, but we will get started in just a few seconds. Hello, everyone. Welcome to our second panel. We're waiting just a couple seconds for our panelists to all join in, but I will introduce myself. My name is Michael Broderick. I use he, him pronouns, and I am an able, cisgender, heterosexual white male. For our non-visual audience, I have a standardized blue and yellow DIM conference background highlighting our logo, and I'm wearing a blue suit and white shirt. I'm an M4, and I'm the co-director of programming for our Diversity in Medicine conference, and I'm hoping to start a plastic surgery residency next year. Being involved since our inaugural conference 3 years ago, I'm elated with how many individuals are listening in and engaging with our virtual platform. So thank you all. To all our prior and future speakers, I'm always wholeheartedly thankful for each of you, and I'm able to listen and learn from each of you in many, many ways. So I'm excited for this next panel. I wanted to welcome you to the second panel because while our first was addressing how to talk about diversity and inclusion within the hospital, our second tries to highlight how we can talk about it and advocate for initiatives outside of the hospital. We all have busy lives. We all have our own responsibilities and employees of various companies. And it's often hard to make sure that we dedicate time to the things that we are passionate about. And so this panel is about how we can use our own platform, our own perspectives, to advocate for patients and the general public in terms of public health and the other issues that are plaguing our society today. For the panelists and for all those listening, if you could continue to state your name before talking each time so that our viewers that are using the CART system can identify who's speaking, that would be amazing. And also, if each of you could just take a second to introduce yourselves in whatever way you see fit, but also touching on your advocacy highlights. How about Dr. Brown, if you could go first?
Good morning, everybody. My name is Dr. Italo Brown. I am an emergency physician, assistant professor in emergency medicine at Stanford, and I am also the chief impact officer of TRAP Medicine, which is a barbershop-based intervention where we try to increase the health literacy of Black men and boys. So we use a lot of different advocacy efforts, and I just am so happy to be with you all today.
Dr. Shapiro.
Nice to meet you, everybody. I'm a pediatrician, also the medical director for health education and wellness. He, him, his, wearing a green shirt, white background right now. You will notice the accent. I come from a small city called Mexico City. Have been very involved with community efforts with underserved communities in Chicago, Florida rural area, and actually migrant workers. And right now working in LA County and Orange County to make sure that everybody has the information needed to take charge and translate medical to a language that they can actually do something actionable with. Then it's a pleasure to be with you.
Dr. Montiel?
Hello, everybody. My name is Gloria Montiel. I'm not that kind of doctor, but I'm a PhD and a researcher, and I'm one of Ultimate Health Services leaders around the civic engagement program. My pronouns are she, her, hers. I'm a Latina, undocumented, currently under the DACA program, and a lot of my advocacy has been around immigration and immigrant health. So yeah, happy to be here. Thank you.
Thank you. And Dr. Nodima Parra.
Good morning. My name is Dr. Ijeoma Nodimopara. My pronouns are she, her, and hers. I'm so excited to be here this morning. I am wearing a, now I don't even know how you begin to describe this for folks, but just know that it's gorgeous, multicolored African print shirt, and the same for my head wrap. I'm sitting against a gray couch with a yellow background and plants on the left. And on top of me is a multicolored picture. My little history, I guess I would say positionality, is that I am a Black, Nigerian, Igbo American woman physician. I am cisgendered, heterosexual with invisible disabilities, and I'm MedPeds trained. In terms of my advocacy, I start a lot of initiatives, 3 of which is health equity and justice in medicine, healing between the lines, and global and urban health equity. And these are curricula that I founded and direct, and one of which I co-founded that is applicable at Wayne State University and throughout Detroit, Michigan. And finally, I would say that my area as a physician, scholar, activist is really disrupting and dismantling structural racism, especially in medicine, and particularly race-based medicine. And finally, if you don't remember anything about me, remember that I am a recovering perfectionist and I am a professional Y-ologist. Nice to meet y'all.
Thank you all to all our panelists for introducing themselves. I think all of you touched very well on some aspects of the first panel, specifically perfectionism and how that's led us to medicine, but also just our advocacy and how important that is to each of us. I was hoping that each of you could talk about what influenced you to originally get into advocacy to begin with. I know sometimes our identities or our backgrounds do so, but I think it's important for our audience to understand why each of us is passionate about the topics we've chosen to get involved with. Dr. Brown, if you'd like to start.
Sorry, I'm making sure that I'm here again. Sorry. Dr. Brown, he, him, his. I didn't say it originally, but I am African-American male. I have a blue shirt. I identify as he, him, his, and my background is the diversity in medicine backdrop. So I got into advocacy probably around the time I was at Morehouse College. I started first just being involved in what I would consider to be legislation, like trying to go to different legislative meetings and seeing what that was about, what the process was in terms of how policy was passed and understanding how policies can be inequitable. So that started in terms of public health. And I went into public health because of seeing the like constantly disproportionately disadvantaged communities of color. I think that it was around the time like 2010, 2011, where I really started to understand that to be an provider, I'd have to know how to advocate for my patients. I'd have to know how to advocate for communities, because very rarely are there people who look like them inside those spaces. And it's this miraculous song and dance that occurs between people who understand and can speak that language and those who don't get disenfranchised like chronically by it. So I wanted to learn the technical tools to speak that language and then be the person who can advocate and then translate that information across a variety of different communities. So just like someone can sit there and tell someone, you know, the ins and outs of a sporting event or the ins and outs of a food, a certain particular type of cuisine, I wanted to be that type of tool for my community when it came to like talking about, you know, why this community is starting to get gentrified or why this community doesn't have access to healthy foods. And then at the patient level, being able to tell them like, you know, you can ask for certain monies to be allocated to your retirement or for health issues or for them to come in and do certain training. Like those conversations didn't happen commonly. And I noticed that the best platform for me to do it was in barbershops. So around 2014, a buddy of mine started Trap Medicine. He brought me on as his advisor. And ever since then, we've just been having these, what I would consider unconventional conversations in barbershops in different locations across the US. Started out in Oakland, California. I'm from Sacramento, California. And I just remember seeing their faces light up when you're having these conversations and bringing material that is what I would consider to be high level to them. And it's very granular, and they understand it, like, why would they, leave us out of this conversation? And you have to be the person to come back to that body and say, you're leaving out a large swath of people. And it's important that you listen and that you have representation in those spaces. So my advocacy journey just kind of stemmed from interest, being a part of like NAACP, being a part of different advocacy groups in college, and then downstream as a physician, realizing that people needed a voice and someone who looked like them, who wasn't afraid to go to bat.
Michael here again. Thank you for sharing, Dr. Brown. Whoever would like to go next. I don't want to keep going in the same order and get things dull.
I can step in. This is Ilan, and again, him, his, and for all of you. And I actually have an interesting background on the way that you get Ilan Shapiro from Mexico. My entire family was looking for the American dream probably like 200 years ago. And especially the last part, like 150 years ago, 100 years ago, and they moved from Europe, from Poland, Russia, and Lithuania. And without knowing Waze, Google, or anything else at those moments, they ended up in Mexico waiting for actually to come to the real America. And we stayed there. And I saw the struggles from foreigners coming to a new country, and the language barriers, and actually everything, and going with your grandma to the same thing that I was seeing replicated when I was actually going with my grandma and translating with different languages, and having that conversation from different languages to Spanish and back and forth. And I understood the importance of being there, and how a doctor, it's not just a doctor, but like the initial key. And when I came to the States, I had the pleasure to be the liaison between Mexico and the WHO. And when I saw what was happening in my little towns around Mexico City, and in the middle of the jungle in the south part of Mexico, and what was happening in Geneva, I saw the complete disconnection between the reality of where we're supposed to be going to the reality of how are we trying to do that part. And I work in Chicago, the real Chicago, the one that actually has Puerto Ricans, Mexicans, African Americans, and all the absolutely conflict of the world inside of a corner by corner. And it got to a point that I started seeing, the problems with, and it got to a point that I'm a pediatrician. I was doing trauma care to kids that are 14, 15. And that was not, it happened, like he got a couple of bullet holes inside of them, like, once a week, or he fell in a knife. No, it was like a daily basis in the hospital. That was my reality. Then I started seeing a lot of diverse backgrounds that we were not helping. I saw the pandemic in the H1N1, how that was actually my first pandemic, how it was actually hurting our communities, and our communities were hurting, not because the doctors were not there or we didn't have the vaccine. They were hurting because they were not having channels to get information, and there were a lot of fears. And right now, moved to Florida, where I was working with migrant communities that, they didn't have running water, and that's U.S. soil. They have running water. They didn't have, sometimes electricity, and I was helping with the kids. And right now here in LA, and especially with this pandemic, one of the most important things that I have seen is that in order to be part of the conversation in the table, you need to be there. If not, you're the main dish. And we have seen this with underserved communities back and forth. And the problem is not just translating English to a different language, or it needs to be relevant, culturally appropriate, and most importantly, given by the trusted source of the information. And sometimes that's why I love, going, the concept of going to barbershops. We haven't found that magic key in the Hispano community, but for sure we want to, and the other thing that I'm very trustworthy with is that I think that when you unite all the colors and flavors, you can amplify the message. And we are missing that boat, especially right now with the pandemic, where, it's nice to have a Google translation from English to whatever, but if it doesn't hear well, or it doesn't translate the words, and that's how you're missing the entire boat. And right now, this is the problem that we're going to have. We're going to have tons of vaccines out there, but our communities will go like Dr. Shapiro, I just want to wait. Like, wait for what? You have been waiting for 13 months. You have like abuelitos and abuelitas have died. You have your partner that died. You have a lot of people around you that have been severely damaged by this disease, and you don't want, no, I just want to wait. And that part is when we are going to fail. And the problem is that if we don't see it right now, and we don't understand that as a medical system, we just are there for 5, maybe 10% of their lives of the patient, or, and that's actually why we can actually help them. But the magic part of it is actually that 80-90% that happens on the streets, on their communities, on their schools, on the toxic stress, on the food that they eat. And that's where the magic starts. And that's, I think, where diversity and energy will start making the difference.
Michael here again, and I think that's so true. Dr. Montiel, I know you've done some work with the pandemic as well. I think that'd be a good flow to some of the work you've done with zip codes and things like that.
Yeah, absolutely. So I became an advocate because out of necessity. I went through school and entered college at a time when even the word undocumented student wasn't really heard of. So I had to leverage my story in a very public way to bring attention not only to the personal struggles that I was facing, because I was very privileged. I actually got a chance to attend Harvard as both an undergrad and a graduate and get into the PhD. But for me, the celebration of that success didn't address the structural barriers that the majority of undocumented students face. And so I use my own personal advocacy on social media. I also grew up in the age of social media. And so that was a tool that I used to mobilize communities moving forward. What that also allowed me to do is really bring the issue of public health into my social media and into my network in a way that people were able to understand what they could individually do. Most recently in Orange County, the County of Orange wasn't publishing zip code data. So one of my mentors working at Latino Health Access, we gathered a group together and demanded that the county actually publish that zip code data, because that's what would allow us to be able to focus testing sites and then prepare for the vaccination. So we've been mobilizing a lot through social media. Latino Health Access has actually been coordinating the response. And another piece that I never really understood that could be a piece of advocacy was grant writing. My main functions in community has been as a senior grant writer for a long time. And that not only allows us to change the way we're perceiving our communities. For example, oftentimes grants or funders ask to describe the target population, but it's my opportunity as a grant writer to shift that language to talk about partner community and priority community instead of a target. And in that sense, bring, uplift the voices of the community, but their status also as partners in bringing solutions. And then most recently, in terms of vaccine efforts, we're really going out there and doing that peer-to-peer communication as well. And now Ultimate Health Services, as one of the largest FQHCs in the country, has now been partnering with communities to bring additional access to the vaccine into communities rather than expecting communities to come to these large vaccination sites. Just one quick example, because I've been posting so much on my Instagram and really telling the story of how the pandemic has been impacting our communities, a couple of people who I'd never met before, but who had followed me for a while said, hey, we want to help you do outreach. What can we do? And so last night after work, I ended up meeting with them at one of the parks in Santa Ana, which is one of the most impacted cities here in Orange County. And we distributed flyers to the Orange County vaccine line. And we ended up signing up 2 people to receive their vaccine, elderly people too. So this is the power, right, of being able to tell a story, of being able to communicate with our own networks in a way that also mobilizes them to act and to be an advocates for our community as well. So I'm really grateful for that opportunity also.
It sounds like you've made a large impact. I know all three of you are working on the West Coast. Dr. Opara, I know you're able to speak a little bit more towards our Detroit community here, where our Michigan students are ingrained. Kind of how have you addressed advocacy in our own community?
Thank you. So this is Dr. Opara, and so I will answer your question in three steps, or three modes. So first, I want to talk about purpose and mission. What brought me to this work? Why that's my why, so to speak. And secondly, I'll talk about origin and the power of and the role of culture and background and origin. And then thirdly, the role that education and preparation has played for me. So firstly, I believe that I'm of the belief that we're all here with a purpose. You know, we're all here with a purpose. We've been equipped, regardless of your belief system or your spiritual sort of origin or context, whether the presence or the absence thereof. For me, I do believe that we have been equipped with strengths, and there is a purpose for which we are in this world at this time, and for a reason, to meet a need, to highlight a cause, and then ultimately to make our part of wherever we are better. And so for me, I very early in life, and as I've grown older, have refined my mission statement. But I wrote a mission statement for myself, and I believe that I'm someone whose purpose can be summarized in 2 words: joy and justice. To embody joy fully and completely in every aspect of my life, and to fight for and promote and move for justice wherever that I'm located. For me, going to the second point is, where did that come from? So I told you I'm from Nigeria. Well, after colonization, or rather the freedom from colonization, independence from England in terms of my country, Nigeria, we were then plunged into a civil war, because the part of Nigeria where I'm from originally used to be called Biafra, where the Igbos resided, wanted to secede from Nigeria. Well, we lost the war, but it was one of the bloodiest and most impactful conflicts in world history, and actually is what was the origins of Médecins Sans Frontières. What you know as Doctors Without Borders was founded as a result of the Biafran Civil War. Well, the thing of the matter is, just like the United States, we haven't gone through our own truth and reconciliation process to really correct and redress harm and pay reparations for the loss that was experienced by the Igbos during that time. So there's still remnant injustices that continue and persist till today, and is embedded and codified in structures of power and government. So my parents fought in that war. My parents have always been very active. My mother is a social worker and educator, and my father is a physician and researcher. So as children, my father fought in the war, and my mother, and I correct myself, she didn't fight, but she was very active in terms of protecting her family as the first child, first daughter in her household, to keep her household and her siblings safe and help her parents. And then, of course, to survive and thrive afterwards. So this is my heritage. I grew up with this sense of that there is such a thing as injustice, and that we all have a role to play in correcting this injustice. And then superimposed upon that is, I happen to be the first child and the first daughter. And in my culture, that has a title called Ada. The Ada in Igbo culture is the first girl of the family, and she's imbued with enormous privilege, enormous responsibility, and accountability. She holds the family together. In fact, she holds the community together. They all do. We all do. So there's this sense of that, again, your role is to ensure that there's balance and equilibrium at home and in the community. And part of that is conflict resolution, leadership activities. We didn't call it leadership then, but it was totally leadership training. And part of that also is ensuring there's justice and all voices are heard and you're taking care of folks. So this is how I grew up. This is my heritage. And so how does that relate to what I do now in medicine? Well, it turns out that as I continue to grow and discover myself and refine my mission statement, starting to listen to and stay true to what are my strengths, what are the things that drive my passion, that you don't have to pay me for, you don't even have to ask me for things that I would stay up nights working on with no request. And as I began to clue into that in college, and I'm graduate, this is my alma mater, I'm a graduate from U of M Lulu, and I changed because I was pre-med majoring in biology. I changed my major to African studies, and there was a whole process to how that came about. As I began to realize history that I never knew about, was not taught to us at home, and certainly not taught here, about the role of colonialism, the role of white supremacy, anti-Black racism, intersectionality and oppression. And it began to open my eyes as to why things were the way they were, both in the continent, in my country, and certainly here in the US as it relates to BIPOC communities, especially Black communities and throughout the African diaspora. So so what that training did, as that became my concentration, was to teach me about structures and power dynamics and how oppression works throughout all sectors of society within this context, but also globally. And that began to trigger and really create that passion for justice within me. So that is what translates into the work I do right now in terms of addressing structural racism, period, but also in medicine, particularly in race-based medicine. We recently scored a victory here at my institution around removing race-based estimated glomerular filtration rate equations, from our calculations of renal function at our institution. We're still in very preliminary phases, but we're moving forward. And my educational curricula and initiatives that I organize highlight and focus and shed light, like Dr. Montiel was talking about, on the structures that cause the disparities, not focusing the blame on the actual recipients of victims or the people experiencing the oppression themselves. So a lot of my work in terms of this of shining a light on structures and how structures play a role in oppression and in inequity is to flip the script. And I love what you did, Dr. Gloria, flipping the script and taking control of the language to say, nope, it is not that Black people or BIPOC communities, their behavior or their whatever issue that is going to be focused on them. And the big one is this, you mentioned vaccine, this mistrust of the healthcare system, mistrust. And so what I've started to reframe in my circles is, no, this is not an issue of mistrust. This is an issue of trustworthiness. The medical system and the healthcare system has proven themselves to be untrustworthy. So then this begins to drive the conversation as to focusing on the structures and the system rather than focusing on the community to fix something that is perceived as broken or deficit within them that doesn't exist. So these are some of the ways that so I would say strategies and approaches that I bring to my work. I'll pause there because I think I've taken enough time, and I'm happy to build on that in as the conversation proceeds. I would like my colleagues to add their perspectives as well.
Thank you, Dr. Opara. No, I think you touched on a lot. And Michael here again, especially you as the oldest woman in your siblings. I am an only child myself, and I understand the pressure that brings to address things that you see injustice and the traits that your parents passed down to you. So I completely understand where you're coming from. I think the question that I want to open up and kind of the purpose behind our panel is the idea of, we have a lot of younger or at least less experienced advocates on the call that are starting their advocacy journey. And so how can different skills be used for advocacy, and how can someone become an advocate? If you guys just want to have a back and forth of what kind of insights you may have to people just starting out their journeys.
Don't feel that you need to do social media. Don't feel that you need to write newspapers. You need to find your joy with this. You heard right now from all of us that we have found, for whatever reason in our lives, a way to transmit what's actually our passion and what's actually our little point that we have in our hand or in our foot. Then you need to make sure that you're channeling that energy. You heard about war. You heard about legal status. You have heard about discrimination, color, flavors. You need to find where you are And most importantly, there's things that you need to know. You need to know about at least basic writing. You need to know about how to, mobilize and connect. In order for an idea to be heard, it needs to have a lot of little steps. If you do not know, that's perfectly fine. That's why you have us. That's why you have us. You need to just connect. In the old days, it was like a miracle, and that was the importance of actually going to a big conference. Right now, we have this amazing things like diversity in medicine that we can connect and empower each other. And sometimes it's not recreating the wheel. The process is there. It's actually finding someone like you that has the power to do something different, to dare to break the model of the things they have been doing. And that's why I'm actually wearing this shirt. I was waiting for the final part, but that's the important thing about grit. That's where actually you come with absolutely everything for the things that you're doing. Because if you're not there, you can do it on social media, you can do it in policy, you can do it with everything. And the beautiful part is when we actually combine absolutely everything, the empowerment of your knowledge, the empowerment of your passion, and put everything together, and that's where the magic comes.
I want to build on that. Thank you so much, Dr. Shapiro. So what I would say again, starting with three questions. Number one, what is my why? And I'm building on what Dr. Shapiro said. What is my why? As you know, my story, I started with my mission statement. Do you have one? Start with why. Why is it? What do you care about? Why are you pissed off when you hear certain things? Why do you laugh out loud when you hear others? What is your why? Because that is what's going to sustain you. Because remember, advocacy and activism, change work is lifetime. It is not one day, it is not one tweet, it is not one post, it is not one article, it is not one volunteer activity. It is forever. I'm committed to, and I'm sure my colleagues on this panel are committed to doing this until they come and take us kicking and screaming to the other room to go lay down somewhere or until our last breath. So this is a lifetime of work. It is. So the first question is to be clear about your why. What gets you going? Because this is not easy work. And so when it gets hard, when the obstacles come, when the challenges come, what is going to sustain you is connecting back to that why. Why do you care about whatever it is that you are identifying? The second question is, who do I connect with? So in medicine, especially, we're taught, well, I need to go do, I need to go help, I need to go save. With this rugged individualism that has Eurocentric roots, is highly problematic. In fact, it's harmful in a lot of ways, okay? Rather, the next question, who do I connect with? Who do I collaborate with? And a hint is with people that have been doing the work much, much longer than you and know so much more about it than you. And and preferably people that are closest to the issue, whatever that might be. All right. And so that's the second thing. Who do I collaborate with? How do I build coalition? That is it. Not how do I go forth alone and be the savior, cape flapping in the wind. No. Okay. Number two. And finally, number three, how can I learn more? And when I say learn, I mean critical engagement in education, not just the acquisition of knowledge about the issue, not just learning, okay, what is structural racism? Okay, what is gender inequality? Okay, what is xenophobia and all those things? You can read the books, you can attend the webinars, you can talk to the people. But I will emphasize on Paulo Freire. I was going to list a few of my heroes and I can do that later in the chat, who really influenced me, people like Frantz Fanon, Paulo Freire, and there's a whole list of folks that when doing this work, is so critical to have them as guideposts. But he talks about the power of reflection and action. You cannot have, your action needs to be grounded and informed by critical reflection. We need to be reflective inwardly. How do we, in our conscious and unconscious, active and in passive ways, actually contribute to the problem? Otherwise, we'll move forward without that reflective piece and actually perpetuate harm or participate in the cycle of producing the inequity that we are so passionate about correcting. So in summary, 3 questions. What is my why? What is that mission statement? Who do I connect with? How do I build relationships, collaboration, and coalition? And finally, how do I learn more? By critically engaging with knowledge acquisition in a reflective manner that is introspective first before being externalized.
Yeah, and Michael here again. I think that's a very good groundwork. Oh, sorry, Dr. Montiel.
Just very briefly, and just to add to that beautiful sentiment also is the concept of unlearning, right? Because oftentimes we think that advocacy is supposed to look a certain way and that we're only an advocate if we have acted on this macro level, but just also know that us really unlearning what sort of some of these general kind of knowledges or ways that we're supposed to engage, and really going back to what can we do on a personal level? What are we aiming to do as an advocate? Are we trying to change someone's perspective? Are we trying to actually get an action done, or engaging in policy, engaging in conversations, actually helping community? There's so many ways to become an advocate that I think a lot of that gets lost in the general narrative. And so we need to see where we can plug in and not see it that we have to do it all, but really where are we comfortable, and going back to what Dr. Opara said, really using our own personal narrative and where we stand as a way to build. And if this is just the starting place, it's okay. We may only, be able to maybe speak or advocacy within our own families, for example, when a comment gets made that is anti-Black or anti-dark people, etc. So that's one sphere to advocate, and from there, building on our skills and building on our comfort levels as well onward.
Thank you. And Michael here again. Dr. Brown, I'd love to have you answer the question as well, but I also want to add another point to it that Dr. Opara brought up is for a lot of our young learners or advocates, identifying the population and whether they want to be helped, or how to talk to them and how to identify those community partners that may already exist, especially for people like myself that may not identify the same ways as the groups that I'm attempting to help with. I think it'd be a good thing to touch on for some of the people in our audience.
I just believe in really taking an inward journey. A lot of people skip that step where they have to learn who they are. They have to understand the critical elements that make them want to do this work, but also like who it impacts. How do you sustain yourself over time? How do you build community and have networks of support in doing that? Is there opportunities for overlap? Because as everyone said, this is a lifelong thing, and it has its real toll. It has tremendous upside, but there is gravity to it. And so you have to make sure that you have a connection to whatever you believe in or whomever you believe in before you start to really, really get in, because this can literally be one of those like breaking down, deteriorating, but also rebuilding moments. So I definitely encourage everybody at that step to take the inward journey, understand that why. And also I would say like, it takes a lot of patience and listening. You have to develop an ear. I mean, we love medicine. We love the idea of hearing patients, but truly trying to listen with a different lens and accepting whatever they say. When you're in certain spaces, and it may not be that you are the savior. It may not be that you are the hope, and seeing what your role in that space can be. And then finally, I would say the development of tools and seeing what tools you already have and repurposing those things. I used to grow up, I grew up listening to rap music, man. I love hip hop music. And I come from a family that loves music. My mom is from Detroit. My dad's from Saginaw. Like that's where I'm from. And so kind of getting that vibe made me appreciate how language was used, how to literally like tap into different people, and finding that as a vehicle created the nexus for me to communicate with a variety of different individuals who normally wouldn't open up. But when the conversation turned to health, I realized that they closed down. When it turned into situations that were community oriented, they kind of closed off. So taking my knowledge of music and creating some type of nexus between us became my vehicle. So there are things that were uncommon that I used as tools all the time. The reason why I have locks, I walk in the room, I've had locks since 2010. And it's very difficult to navigate medicine when you have long hair. It's extremely, it's essentially set up to like, this is an anomaly, to be a brother, to come through the entire process and never cut my hair. But I knew that that was a part of my connection. That was a part of connection to myself, but to the people that I was really struggling to reach. And I wanted represented, and I wanted the patients to see their grandson in me. I wanted the people who I was working with to see people that were in the community in me. So those are the tools that I say that I kind of harnessed. So everybody has these tool sets, and they are a Swiss Army knife of people. So just make sure that you are aware of those things and figure out how you can use them in unconventional ways.
Michael here again. Dr. Brown, I liked how you touched on it as a lifelong commitment. I think, no one wants to start the race and not finish it. There was a question in our question and answer panel that someone in the audience asked regarding the fact that because this is a lifelong commitment and we also have other things that we have to do in our lives, kids, children, families, our own employees' responsibilities, it can lead to burnout, especially among people who have to constantly explain themselves. And so how can we avoid that? What are each of you doing to address burnout, or how do you take a step back to avoid that and be able to continue along the journey long term?
And I think that, and I feel the energy from Dr. Brown, we don't see this as a fight or as a thing or as an objective, or this is what we are. We're channeling, this is, if you ask me right now, yes, I work as a pediatrician, and yes, I'm the medical director for whatever, and I wear those hats. But when we have this forum, this is actually what we are. That's the internal fabric of what we are. Then the same way that when you grow up, you have growing pains. There will be growing pains, but you do not need to see it as a barrier or as a problem. It's part of the journey. The more scars that we have between the four of us that are in front of you, the more scars that we have, that means it's not that we bled and we died. No, we survived. And we didn't survive. And Dr. Opera actually said something amazingly well. We're here from the part, not from happiness. Happiness goes away, but we're coming here from the part of joy. And that's where it makes a huge difference, because we already have had a lot of barriers and we have a lot of things. The thing is, the way that you perceive it and the way that you project it, it's different. We can tell you that the four of us, I'm Mexican Jewish living in the United States. I went from Chicago to Florida and LA and Orange County. Then, unless, we have, I was giving in the middle of Florida, and I'm going to share with this, care to people that were on the extreme right in the middle of Florida. And I started with 2 patients, and they had like beautiful tattoos, remembering where it came from, like swastikas and stuff like that. And I saw them as patients, and the work that we're doing, that I'm here to make a difference. Then they can come from whatever aspect of their lives, but I'm doing this for me. First of all, yes, I'm egocentric on that part. I'm doing this for me first, to actually start being part of everything. And I'm not here to educate anybody. I think that it's not about education, it's about information. Translating medical-ish to something that we can actually do and translate into action. And I think that's where I'm coming from.
I think that it's important to just know that you're tapped into the source. Like, just being in this space with you guys is re-energizing to me. And that's what I make sure that I'm doing. I'm constantly looking for, where's the plug? And that's how I navigate it, is I build a community of people who come with a certain type of energy. We use each other as those levers and pillars. And then knowing that the source is limitless, because this is good work. I never have to question that. And I see the downstream results of it daily. And then when you start to see these goals being reached, all it does is reignite you. So anytime I hear these victories, it takes all of that sense of worry away from me. It just literally reignites me. And so I don't find, when I say burnout, I'm more so talking about the management, the logistics, the actual tug of war that you have to go through with individuals. Sometimes that creates the burnout, but the burnout doesn't come from the fight. We got juice.
Right. And if I may build on that, thank you, Brother Brown. Really, I would say what Dr. Shapiro said is so key. And that's why, for me, again, I always come back to purpose, joy. This is joy.
Yeah, man.
This is a Saturday morning. I am chronically sleep deprived because I have 3 babies. I have a husband. So some people might say I have 4 babies, but you didn't hear me say that. Oh, don't let me hear. So, and right, okay, we have 3 babies. Let's do that. And I have full-time jobs. You know, I got jobs. Okay, I'm a Black woman, physician, academic. So, you know, I have 2,500 hats just off the top.
Right.
So when you talk about exhaustion, sure, yes, but this is my purpose, right? This is like, I love how Dr. Shepard said, this is who we are. This is who we are. I love that. Yes, because it is purpose driven. This is why we're here, right? So when I'm tapped into my why, I don't understand burnout. I really don't. Right. But let's be realistic. Yes, you are right. They and I love what Dr. Brown said. He said the exhaustion comes from dealing with folks. That's true. You know, it is resistant folks.
Right.
It's like dealing with Howard Buckner from JAMA for his just highly
real facts
disgusting letter of apology for JAMA's podcast talking about physicians are not, no physicians are racist. If you don't know that, someone please put the link in the chat and let the people know what's really going on. Okay, what we're dealing with.
You see, I'm rubbing my temple right now.
That's right. Yeah, that's right. Absolutely. In the spirit, we're all rubbing our temple, right? That is the head of one of the largest journals. Do you understand that policies and politics are based on science? You understand that science informs politics and policies and laws. You understand that, right? Like what we do is not a game. When we talk about structural oppression, structural racism and isms and systems of, you know, we're talking about mutually reinforcing, interlinked, interconnected systems that form the reality in which we live. And medicine and science is critical to that. We are informing these folks that sit in these halls of power, making decisions that then come back and affect us in terms of our access to, you know, housing and education and policing and criminal justice and wealth building and what resources come to what neighborhoods, et cetera, et cetera, et cetera. It comes from the work we do. So we cannot afford, right, to be the vehicles and channels of these reinforced producing and then reproducing and maintaining these same structural inequities, but then come together in little pods to talk about why there are inequities, right? And so things like Howard Buckner, dealing with them folk, that's exhausting, right? But calling it out, developing the solutions and the tools, building collaboration, coalition, working with partners, that's joy, right, towards justice for me. And it sounds like for my brothers and sisters here on this panel. So I really want to lift that up. I also want to very quickly just say to your question, Michael, in terms of, and again, I think I heard one of my panelists, co-panelists here saying that, you know, we say in global health is basically built on 1,000 cups of tea. It's all about relationship building. I heard something about going into communities and asking if they need help. Dr. Gloria said this already. We need to unlearn the assumptions. We have to unlearn a lot. And a lot of it is the assumptions we bring into these spaces.
They need help.
That they need help in the first place, or that the help is you. It's you,
right?
For some reason, for some very, very strange reason, right? We need to start asking different questions. You know, how can I partner with you? How can I support you how can I remove barriers so that you can shine? You know, this is not being the voice for the voiceless. People have voice, is that they're not heard. How do you change structures and systems so that folks that are already excellent and brilliant and not deficit, but are full of assets, can actually blossom and thrive? How do you engage in those systems and disrupt them, dismantle them, undo them, deconstruct them, and then work in partnership with folks to reconstruct that which is better? These are different questions we have to start asking different questions and then demanding from the powers that be to also reflect the same. Somebody I saw in the chat was asking about deans and leadership. Absolutely. I hope that there are sessions such as this for folks that are the Howard Buckners of our medical schools and our academic health centers and other, institutions like this, right? But it does come to us and to you all as young folks, as students. I need you to know that you are chock full of power. I tell my students all the time at Wayne, you are not powerless, you are powerful. Students have always been at the forefront of change historically. If you know your history, which is why you need to know your history, right? Always. You are powerful and there's much that you can make happen. It's just a matter of coming together. And so the key Swahili saying, if you want to go fast, go alone. If you want to go far, go together. So focus on relationship building, getting to know folks. Start with that. And then building coalition, collaboration, organization. Start with that. And out of that, solutions will spring forth.
I completely agree. And Michael here again. And thank you to Dr. Montiel and Dr. Shapiro for answering some of our questions in the chat. I am sorry to end this conversation a little bit earlier. Oh, actually, we've given it a couple more minutes than we promised, but thank you so much to all our panelists. I wanted to briefly have everyone look at the question and answers, because I think we had a couple questions that were regarding the idea of our learners often hopping between institutions, jobs, training locations, and how the longevity of their efforts seems diminished in the light of their own need to advance in their careers. And so I just wanted to let Dr. Montiel get in the final word regarding what she advises for our learners as they go through their path, and then maybe some final points by any of the rest of our panelists, and then we will say goodbye to you and all go to lunch.
Absolutely. Just want to echo this idea of joy as a form of resistance, right? Everyone talked about the structural oppressions, but it's in these moments of joy that we not only re-energize ourselves, but also our community. And then the other thing I'll share is find your people. Find your kindred spirits that are going to hold you up. Dr. Bettina Love actually wrote a book. It's called We Want to Do More Than Survive. And it's really about the educational journey. But in there, she talks about this idea of home place. And this idea of home place is usually those elders, especially women. It usually tends to be people of color that really ground you in what this idea of home. Some of you talked about in the questions about displacement between jobs or people, but wherever you go, I want to say, find your people, find the people that you want to uplift, find the people that uplift you, and let that carry you throughout your journey. Thank you so much to everyone.
Any final words from the rest of our panelists before we log off?
Thank you so much for having us. And it was such a pleasure. And like my brother, Dr. Brown said, my brother, Dr. Shapiro said, my sister, Dr. Montiel said, and of course, my brother, Michael, this truly has been rewarding, reinvigorating, re-energizing. We feed off of each other. And so I hope that this is only a beginning. I hope that and look forward to continuing this relationship beyond this moment, long term. So keep me, in the loop. I put in my email and my Twitter handle. I'm on IG too, but I'm more active on Twitter. And I hope that again, this is one tea in the 1,000 cups of teas for relationships long term. Thank you. Joy and justice.
I'll just say, lean into sharp edges until they don't really have power over you anymore. Love endlessly, like deeply and abundantly. Be a servant and do it selflessly. Don't expect anything in return. Do it because you can. And then finally, come back and open the door for somebody else. That's all I got.
This is Ilan. I'm honored to be here, and it's a beautiful way to start the weekend with energy and joy. And I hope that the mission of vaccinating right now, especially our communities against fear with a dose of truth, continues to resonate in all of us. And it's an honor and a blessing to be sharing this panel with you and this time with you, and we're here to help.
Thank you so much, panelists. For all audience members, we have a small lunch break now, but we're going to come back at 12:25 to hear from Dr. Randy Vince, who's a urologic oncology fellow here at the University of Michigan. Until then, thank you so much for listening, and panelists, again, thank you so much for being involved. If through the Socio app, attendees, you were able to interact with some of our panelists, you can find their social media accounts there for those that have them, and please feel free to continue this conversation. I think it's important that we keep talking to those around us and anyone who's willing to chat with us. And for those of you who are interested in continuing some components of this conversation later, our Changemaker conversation at 1:30 will highlight some similar discussion from some other speakers. So again, thank you all, and thank you to the panelists. Have a great day, and I hope we can walk forward with fully engaged in this venue. So thank you so much.
All right, I see you now, Tanya.
Hi, everyone. For all our folks who are here right now, I'm just going to add one quick thing. I'm Tanya. I'm helping out with logistics for the day. We will be using our lunch half hour to also present some awards to folks at the University of Michigan who have been doing work in this space. These awards are being presented through our Student Diversity Council at the University of Michigan. We welcome anyone to stick around, and please be in the audience while these awards are being presented. And that will begin shortly.
Hello, everyone. Good morning. It's a pleasure to be here, and thank you so much for an amazing conference already. It's been a powerful morning, and just so excited to be here today. So my name is Erica Odukoya. I'm a fourth-year medical student here at U of M, and I have a pleasure of serving on the Student Diversity Council. The goal for me in the next few moments is really just to honor a few folks that have done amazing work in the realm of diversity, equity, and inclusion, health equity, and social justice here at University of Michigan as either a student, resident, staff member, or faculty member. I want to give a brief overview of the awards as well, but I think what I'll do right now is just go ahead and transition to start sharing my screen, and so you can kind of focus your attention on that. Awesome. So everyone, just to give a brief introduction, the Student Diversity Council is a consortium of student groups and individuals here that aim to promote health equity, social justice, anti-racism, and critical race theory in the curricular and extracurricular space here at U of M. This year, we've partnered with the Diversity in Medicine Conference folks to really help recognize and affirm some very special individuals that have been doing incredible work in a few specific domains. What I want to do right now is to go into the awards themselves, but I also would like to give a description of the namesakes of these awards, as they've been very meticulously and intentionally selected based off of individuals that have also been doing incredible work here at U of M, locally, regionally, or broadly. And we want to make sure that we also honor those incredible folks as well. So I will first, I'll let you kind of see the names as well. Also, please forgive the spelling error for inclusion, but I want to go into the awards right now. And I want to start off with the description for the Dr. Roland Alexander Blackwood Award for Excellence in Mentorship to Diversify the Healthcare Workforce. So just a brief description, Dr. Roland Alexander Blackwood, also known as Dr. B, is a pediatric infectious disease specialist here at Michigan Medicine and faculty lead of the Leaders, Learners, and Pathways of the Office of Health Equity and Inclusion. Among his extensive research and clinical career accomplishments, he is highly regarded for his commitment to mentorship and pipeline development. His mentees have accomplished amazing feats, including a myriad of publications, grant awardees, national and local recognition. His commitment to ensuring that students who seek matriculation to the medical profession is just as profound and deep-seated as his passion for medicine. This year, the inaugural recipients for the Dr. Roland Alexander Blackwood Award for Excellence in Mentorship to Diversify the Healthcare Workforce are as follows. Miss Eris Bryant, she is a fourth-year medical student matriculating into family medicine. I'll give a brief description of Miss Bryant as well, soon to be Dr. Bryant. She has done incredible work in supporting student matriculation through the Success Connects program, through her presidency in the Black Medical Association and pipeline efforts with the Black Undergraduate Medical Association. She has a profound commitment to mentorship, and we truly appreciate her work, and we're honored to give her the inaugural student award. Next is Tyrone Elliott. Mr. Elliott is a house counselor for the Hamilton House here at the University of Michigan Medical School. Just notably for Mr. Elliott, he is known not only for creating a welcoming and positive environment for diverse students based off of race, ethnicity, ability, and financial status, but also based off of performance here at U of M. He is known as an encourager and energizer, and really creates a positive space for every student here. And we honor him in that regard. Next is Dr. Valeria Valbuena. She is an amazing surgical resident who has received incredible nominations for her work in creating pipeline efforts in overseeing and developing programs like the LEAGUES program, in advocating and championing and sponsoring students, not only into surgical specialty, but also into transplant, and also in general through medical education. Finally, we have Dr. Marilyn Rubidoux. She is a fantastic radiologist and a part of the radiology department here. She is known for her incredible work in supporting students through various STEM fields, through master's and PhD. And her work in terms of diversity and equity is greatly renowned. We appreciate her. Next, I'd like to speak a little bit about the Award for Innovation. This award is the Dr. Senait Fiseha Award for Excellence in Inclusion and Innovation. Just to give a brief description of Dr. Senait Fiseha, she is an MD-JD global leader in reproductive endocrinology, international grant making, teacher, lecturer, and leader. Among her many positions and accomplishments, she was the first medical director for Michigan Center for Reproductive Medicine, the first African elected director general for the World Health Organization, and helped to forge various sustainable training and capacity building partnerships between Michigan Medicine and many hospitals in Ethiopia. Her dedication to quality care and equity knows no bounds or limitations, but essentially is fueled by innovation. For that, we would like to award a few individuals who've represented those ideals and characteristics. The first is Dr. Jessica Santos Parker. She is a current fourth-year medical student. She holds a PhD, which is why we'd like to honor the work that she's done as well. She is matriculating to the general surgery field, and she has been known not only for incredible mentorship, but also for innovating new opportunities for students to be able to matriculate not only into general surgery, but into medicine. She was the co-director for the Scrubs group here at University of Michigan, as well as the League's fellowship. She holds various positions in the surgical department, not only as a student, but just as a leader to advocate and champion for others. So we appreciate her efforts there. Next is Carrie Grobe. Carrie Grobe is a staff member here in the Office for Medical Student Education. She has done incredible work in the realm of advocating for critical race theory, anti-racism, and is currently developing a history of racism course here. We truly appreciate all of her efforts. She's also the co-director for the co-advisor for the Student Diversity Council. As far as resident acknowledgement, we'd like to provide this award to Dr. Shannon Faison. She is currently an otolaryngology resident here. She matriculated from Ohio State University and has done an incredible effort in terms of ensuring not only matriculation of students into the field of otolaryngology, but mentorship and support. She holds various positions in the DEI committee for that department and also helped to create the Black Otolaryngology Network to ensure that students, regardless of their experience, can see the representation in the field of otolaryngology. Finally, we have Dr. Oluwafemi Okunlami. He has very politely known as Dr. O. You would know him in terms of his incredible work, not only for the Disability and Adaptive Sports Program, but also in the Family Medicine Department. Also his work in terms of advocating for every individual BU student, resident, faculty is known and renowned. He currently is also the co-advisor for the Student Diversity Council. He also knows no bounds in terms of innovating and advocating for students and all individuals who have a physical, invisible disability or any other form of ailment. Next, we transition into our Dr. Arno Kumagai Award for Excellence in Institutional Change to promote health equity, social justice, and compassionate care. This award is in acknowledgement for Dr. Arno Kumagai. Dr. Kumagai is an internist who, although is no longer working here at University of Michigan Medical School, he left an indelible mark on our institution's approach to educating the youth of MS community about social justice, compassionate care, and equity. During his tenure here at U of M, he was instrumental in developing the Clinical Foundations of Medicine and Family-Centered Experience longitudinal course, transitioning now into the doctoring course, and it emphasized clinical skills, patient advocacy, and compassionate care to med students. He's encouraged structural change regarding social justice and cultural humility in medical education curricula here at U of M. In terms of acknowledging the recipients of this Institutional Change Award, the student that we'd like to acknowledge first is Claire Collins. Claire Collins is a force to be reckoned with regarding raising awareness about mental health and equity for various students and access. She has spearheaded various initiatives related to the wellness committee, related to the M-Home Peer Support Program to provide students opportunities to access mental health, psychotherapy, and support. Next is Rachel Privet. Rachel Privet is our staff awardee of this. She has done incredible work in the DEI committee in the Cardiovascular Center for several years and was greatly acknowledged and recognized for her efforts by her colleagues. As far as faculty, the awardee is Dr. Jen Stojan. Dr. Stojan is the faculty director over the doctoring course. She has done an incredible amount of work to ensure and champion health equity and social justice in the doctoring course as it continues to manifest and change over the years. She is as selfless and forthright as she is an incredible physician, and we appreciate her work. As far as the resident award recipient, it is Dr. Ryan Tushita. He is an emergency medicine chief resident and has done incredible work, not only when he was in the Student Diversity Council, but also at the local, national, and regional levels for raising curricular changes awareness in the emergency medicine department for vulnerable populations. And finally, we transition to our last award, the Dr. David Gordon Award for Quiet Influence in DEI. The Dr. David Gordon Award, Dr. David Gordon, is a professor of anatomic pathology and emeritus faculty here at U of M. Among his many positions, he has served as the Associate Dean for Diversity and Career Development at the University of Michigan Medical School, Medical Director of the largest federally qualified health center in Genesee County, with special focus on improving health and wellness of individuals that are underserved or returning from incarceration. Dr. David Gordon has done incredible work in DEI for recruitment and retention of individuals into various health spaces, and he's done this quietly but poignantly, and we'd like to honor him in relation to the individual awardees. The first is Ruth Bishop. She is a medical student here at U of M who is known for incredible work in advocating for individuals that are homeless, suffer from addiction, or need any type of mental health care. She's done incredible work with Wolverine Street Medicine. She also does great work with a community-based participatory research project now in trying to ensure that individuals who need mental health are able to get that through primary care. We truly appreciate Ruth and all of her work so far. For the staff awardee, we have Miss Becky Weeks. Becky is amazing. Becky does an incredible job in terms of the admissions committee, but also is very present in all other aspects of U of M to ensure that we're promoting awareness of how we can matriculate more students of diverse backgrounds into the medical school. She coordinates the admissions process. She's also very present in so many spaces, and we appreciate her as well. For the resident awardee, we have Dr. Juan Andino in the urology department. Dr. Andino is an incredible advocate and champion for DEI. He does this also very quietly in his influence, not only in work in telehealth, but also ensuring that students have mentors, have access, are sponsored, and are able to provide their work at the local national level in abstracts and publications. He's a part of the Euroversity program, the Urology Interest Group, the DEI Committee in Urology, and we truly appreciate his work. And finally, we have Dr. Mark Prince. Dr. Mark Prince has an incredible career in the otolaryngology department as being a former chair and program director. He's also a champion for diversity, equity, and inclusion in ensuring that that program is increasing representation as well. We truly appreciate all of his work in that regard. Thank you everyone for your time. Congratulations to all of the awardees for your amazing contributions. They have been notified today, and we will make sure to ensure that they are recognized and affirmed moving forward in the future. Thank you so much, everyone. And thank you for the Diversity in Medicine Conference for allowing us to share this platform and space with you.
Thank you, Erica. Thank you for sharing the details for all those amazing leaders doing work in this space. So everyone, we have a little bit more time for lunch. Please use this time for that. Use this time to engage with poster presenters, view their posters, and connect and network with any other attendees as well. And we will see you back here when the next keynote begins.
Is it cool to start sharing my slides now? What? So they could be up while you do the introduction, or would you want me to wait?
I think either way is fine.
Okay. Can you see the slideshow?
Yep.
Okay, good.
All right, we will go ahead and get started. Hello, everybody. My name is Quentin Pedro Solano. I use the pronouns he, him, his, and I'm an able-bodied cisgender male. I'm a Mexican Polish American born in Detroit. I'm wearing a blue polo shirt today with the Diversity in Medicine football backdrop behind me. I'm a third-year medical student here at the University of Michigan Medical School, and I have the honor and privilege of introducing our next keynote speaker, Dr. Randy Vince Jr. Dr. Vince was born and raised in Baltimore, Maryland, and is the oldest of 4 siblings. It is in Baltimore where he developed a passion for athletics, and after graduating high school, he went on to attend Towson University, where he was a varsity letterman in football. At Towson University, he double majored in MB3, which is molecular biology, biochemistry, and bioinformatics and chemistry. He went on to attend Louisiana State University Health Science Center in Shreveport, where he earned his MD. He completed urology residency at Virginia Commonwealth University Health Systems. During his intern year, he earned the Department of Surgery Best Teaching Award. He developed a passion for urologic oncology, particularly renal cell carcinoma. This led him here to the University of Michigan for a urologic oncology fellowship. While at Michigan, his research is focused on using genomic platforms to enhance clinicians and patients' diagnostic and prognostic data. Additionally, he is aimed at using genomic panels to highlight the impact of systemic racism, not racial biology, on disparities in cancer outcomes. Outside of his impressive academic work, Dr. Vince enjoys weightlifting, traveling, spending time with loved ones. We will have a few minutes at the end of this for a Q&A, so please, I encourage you to input your questions into the Q&A chat, and I will be moderating that. And with that, Dr. Vince, please take it away.
Yeah, thank you, Quentin, for that kind introduction. Hopefully everyone can hear me well. So for those of you that I haven't met before, I'm Dr. Randy Vince Jr. I use the pronouns he, him, his. I am able-bodied and I'm cisgendered male. I'm wearing a blue blazer with a white collar shirt, and my slide background's a Michigan medicine slide backgrounds. So I want to thank everyone for the opportunity to be a keynote speaker. I must admit, it makes me laugh a little bit hearing the word keynote speaker attached to my name, because in my heart, I'm simply a kid from Baltimore trying to do the right thing. But with that, let's go ahead and get started. So when it comes down to today's conference, the overall discussion is around enacting change, the physician's role in social justice, diversity, and intersectionality. And so, for me, I like to look at things from a broad level and then kind of hone in on exactly what I mean. So at a broad level, I think we have a role in education, outreach, and mentorship. And I'll go through each one of these and explain specifically what I mean. But before I do, one thing that I'll constantly say throughout this talk is that every physician has a certain amount of social capital. And it will be wise of us to leverage that social capital, to impact change. Before I get too far off in the presentation, I want to give a caution to everyone. I talk about racism, and specifically structural racism, in pretty honest and blunt terms. And so I know this makes some people uncomfortable. I'm of the mindset that being in these uncomfortable spaces is when we can actually make the most growth. So I'm just cautioning people now. There's nothing, too graphic or anything in my slides, but the reason I do this is because I think racism is arguably the oldest and most lethal form of social injustice in this country. And so, there is an overlap and intersectionality with many of, the social injustices we see as it relates to people with marginalized social identities. So some of the things I talk about are applicable to other forms of social injustice as well. So when we talk about education and non-education, the sister Lashira Nolan, she gave a great talk to open up the conference today. And she was aiming to really shine a light on, educate people on exactly what's going on and the history behind what's going on. And so with this, I think it's specifically, important to uneducate ourselves. And I'll tell you exactly why. So I want to discuss a concept called the big lie. This guy, Joseph Goebbels, he was the minister of propaganda in Nazi Germany. And he said this quote, "If you tell a lie big enough and keep repeating it, people will eventually come to believe it." And I think Isabel Wilkerson in her book Caste eloquently highlighted that many of the oppressive systems we've seen throughout human history actually harbor the same elements. And one of them is the big lie. And if you need a current day example of this, look at the 2020 election. It was a lie that was repeated over and over again. And ultimately we had the violence that was perpetrated on January 6th of this year. But I want to take it back to a historical perspective. And so first I want to look at this document, the Declaration of Independence. In opening lines of the second paragraph, it said, "We hold these truths to be self-evident, that all men are created equal, that they are endowed by their creator with certain inalienable rights, that among these are life, liberty, and the pursuit of happiness." And so this is something that James Baldwin has, if you ever read any of his work, has touched on, because now what happened is you have this document that is now declaring independence from Britain, and you have a system of slavery that exists that's the economic engine of a developing country. And so these two things are contradictory. And so now you have to reconcile this contradiction. And how did that happen? Well, racialization. That was a social concept of race that was created. And then within our country, that deemed that Black people were inferior and whites were looked at as superior, right? So now you can see how they were trying to reconcile this contradiction. Because if Black people are seen as subhuman and inferior, they don't need equal rights. They don't have inalienable rights. So that is the way that they reconciled that contradiction. And so since that time, we've seen experimentation on Black slaves. We've seen the concept of eugenics. We've seen racialized medicine. And all of these things have an impact on where we find ourselves today. So I think it's really important that we unlearn the things that we may have been taught about race, re-educate ourselves on the true foundation of this oppressive system. And part of that is combating a dominant narrative. So undoubtedly, most people on this call have heard something like this. You can obtain anything in this country if you just work hard enough. This insinuates that our country is truly a meritocracy. And to take that a step further, it insinuates that there is equitable access to all resources in this country, such as education, the ability to build wealth, no matter what your social identity is. And even within that, there's this concept of rugged individualism. And so many of you have probably heard this. When my grandfather came here from country X, whatever country that was, he only had the clothes on his back, and through hard work, he became successful. So this frame of mind starts to make people assume that all citizens, regardless of their social identity, had equal access to resources, which just isn't true. And that's the reason why Martin Luther King said in his 1967 interview, "It's a cruel jest to say to a bootless man that he ought to lift himself by his own bootstraps." And so I want to just kind of take a second to highlight how inequitable access to resources like wealth building and education have current implications in where we find ourselves at today. So to highlight this point again, I'm going to touch on wealth building and ability to obtain higher education. So I want to start with wealth building. I think in this country, it's widely accepted that home ownership is a primary tool of wealth building for most Americans. Specifically, that wealth can be passed from generation to generation. And if you know me well enough to know, if you know me well enough, you know that I'm constantly referring back to a lot of my experiences in my hometown of Baltimore, Maryland. And so I dug up this map. And this is a map of 1937, and it shows the red line districts within Baltimore. And for those of you who are unfamiliar with the practice of redlining, this is a policy that was implemented to designate areas that were too risky to provide mortgages to. So while in the policy, it didn't say specifically that these areas had to be in Black communities, they were predominantly Black communities that were deemed too risky. So I'll zoom in really quickly just so I can highlight exactly where my family is from. And then I'm gonna zoom back out, because what I wanna do is I want you to see, look at this pattern. This is the Patapsco River, if you can see my pointer. And then I want you to look at the pattern of the red and yellow communities here. Now, these are the areas that were deemed too risky. And again, this is in 1937. And so I want to highlight how this has current day implications. So this is a map that was published in the Washington Post in 2018, which highlights home vacancies within the city of Baltimore. And so you can see that there's a similar pattern and a similar distribution when it comes to those red line areas and home vacancies. And so let's put this together really quickly. So I want to walk you through this vicious cycle. So if you have home vacancies, anyone who has a working knowledge of real estate knows there's a word called comps or comparables. And so your property value, if you're a property owner, is greatly influenced by the community around you, the properties around you. And vacant properties, the more vacant properties, the worse the property value. And so when you have a large number of home vacancies, you have decreased property value. Well, what does that cause? If you think about it in these terms, property value is how we assess what taxes should be assessed to that property. So if you have decreased property value, now you have decreased property tax revenue. And property tax revenue is a major part of the mechanism to fund schools. So then you end up with decreased school funding, and then you end up with decreased resources within schools, and then you end up with poor performing schools. And it's this vicious cycle that perpetuates itself generation after generation. Additionally, I can build on this, if, just quickly. If you have an area that is poor and impoverished, what makes you think a store like Whole Foods that sells produce that is pretty pricey will want to move into that community? So this is how we end up with things like food deserts as well. So this kind of just highlights the wealth building concept that I wanted to touch on. Now I want to touch on higher education, and I want to give an example. Take it back to 1944, which was after World War II, when the US had passed the GI Bill. And this was aimed at allowing veterans to obtain homes and get a higher education. So we talked about, all of the things when it comes to home ownership and wealth building, but I want to focus specifically on higher education. You see, it wasn't wrote into the GI Bill that Blacks couldn't obtain tuition assistance, but many institutions of higher education were just flat out not even accepting Black people. And so when people say they're skeptics of structural racism, it's because they don't really understand how, these policies might not actually explicitly say that Black people cannot do one thing or the other, but the implementation of the policies in the real world society shows that this is, the actual impact. So this is a picture of George Wallace, the former governor of the University of Alabama, preventing integration. And so many of the institutions and within our country of higher educations simply weren't accepting Black people until the late 1960s, 1970s. And to take that a step further, there are a lot of grade schools around this country that were not integrated until the 1990s. And I, saw proof of that when I was living in Louisiana. So this is just two examples of how our country is far from the meritocracy that is presented as. And then I want to just take a second and hit on racialized medicine and past practices. So these three gentlemen, from left to right, Hugh Cummings, Talia Farrell Clark, Raymond Vanderleer, they all presided over the infamous Tuskegee experiments at one point in time. And they all learned racialized medicine. And during that medical school training, they gave scientific credence to the eugenics theory. And so there was a belief that there were biological differences between Blacks and whites. And so why does this matter nowadays? So all of those gentlemen attended the University of Virginia, and that's where this study in 2016 was published from. And many of you on this call have probably read this study. And within it, you can see here highlighted in red, these are several false notions that state biological differences between Blacks and whites that are still believed to this day. And so as I wrap up education, and I spent the most time on this because I feel like this is the most essential and imperative part of the talk. I want to say that physicians inherently have social capital, so we must unlearn things that have been incorrectly taught, educate ourselves on the true history, take steps to educate the future generation, and acknowledge our country's history and its current day implications. And if you need an example of why this is so important, look no further than this podcast that was put out by JAMA. And no physician is racist. So how can there be structural racism in healthcare? This just highlights a lack of sensitivity and a lack of education as it relates to actual true history and how these things manifest themselves in current day. So I want to move on to outreach really quickly. So to me, community outreach and community engagement is so important because even within structural racism and other forms of social injustice, health disparities are a form of social injustice all within themselves. And so community outreach and engagement can actually help improve health literacy, increase participation in clinical trials, and increase diversity within medicine. And I'll touch on each one of those specifically. So as we unpack this, I want to start by referencing a book that was published by the Institute of Medicine, Health Literacy, a Prescription to End Confusion. And within this book, they said efforts to improve quality, reduce costs, and reduce disparities cannot succeed without simultaneous improvements in health literacy. And so these don't have to be million-dollar projects. All you need is a desire to impact change, and you see that the problem is there, and you go out and you do something, right? So it doesn't have to, while I'm not gonna lie, additional resources are definitely needed when it comes to this work, but community outreach and community engagement can improve health literacy in simple ways, and all it takes is simple acts. And I'll show you, this is an example of a webinar that I did, and I'm not doing this to highlight myself in any way, but just to show you that I believe exactly what I'm telling you. And so with this webinar, there were over 100 men there, and I gave a simple talk on prostate cancer. It didn't cost me any money, just a little bit of my time. And then speaking with several of those gentlemen afterwards, they felt as though now they had a working knowledge of the disease of prostate cancer. And so this allows patients to now advocate for themselves and have a better understanding of everything that is going on as it relates to healthcare. And they show you proof of this and data of why health literacy is so important. Let's look at when low health literacy is and its impact on health outcomes. So this systemic review looked at over 100 papers, and they concluded that low health literacy was consistently associated with more hospitalizations, greater use of emergency care, lower receipt of mammography screening and influenza vaccine, poor ability to demonstrate taking medications appropriately. And I know that's a wordy way to say low health literacy is associated with poor outcomes and a poor use of healthcare services. So again, getting out into the community and doing community outreach and community engagement is a way to improve health literacy. Additionally, it's been shown in study after study after study that community engagement can increase participation in clinical trials, as well as improve physician mistrust, which is so important nowadays, especially within the COVID-19 pandemic. And there's a huge mistrust within the Black and minority communities when it comes to getting vaccinated. And that's based off of the history. But one way to kind of combat that is to go out and do community outreach and community engagement. And lastly, I'm gonna touch on increasing diversity in medicine really quickly. So, there is well known that there is a lack of diversity in medicine. Otherwise, we wouldn't have a conference like the one that we have today. And why is this so important? Well, study after study have shown minority patients taken care of by minority physicians get better quality healthcare. And so, obviously there is a need to improve diversity in medicine. And if you want an example of that, I'm gonna just highlight Doctors of Tomorrow here at University of Michigan really quickly. When I first got here to University of Michigan, I remember sitting down with Ganesh, the chair of my department, and telling them how passionate I was about community engagement, community outreach, and doing this work. And he emailed several people. Ironically, Jonathan was probably like the only person who actually responded. But we were able to, I'm talking about Jonathan Finks, and we were able to sit down and talk. And he said that he told me, I'm not from a disadvantaged background, but I saw a need and I wanted to impact change. And so now this program is something that many people from across the nation are trying to find a way to implement. And so this kind of highlights the fact that, you don't have to have $1 million startup to actually go out and start to impact change and enact change. And so lastly, I'm gonna talk on mentorship as we kind of round out these three things that I wanted to highlight. And so, when I sat down to make this slide deck, I thought about all the different ways that I could highlight the data showing the importance of mentorship. But one of my mentors, who I highlight here shortly in my talk, told me, Randy, whenever you get the opportunity to give a talk, share your story. There's power in it. And so when I thought about how could I really emphasize the fact that I think mentorship is so important, I went to the NIH website and I looked up factors that they classify you as being from a disadvantaged background. And so free or reduced lunch growing up, I checked that box. Had no parents who graduated or received a bachelor's, I checked that box. Now I will say this, I want to give credit to my mom who had me at the age of 19. She did go back to college, and she graduated college when I was in college, and I'm extremely proud of her hard work. But moving on, eligible for Pell Grants, I checked that box. Parents receive WIC, check. Grew up in a low income area, check. But let's take that a step further. And, I want to share with you all things that I've personally seen and been through in life, so that way I can kind of reinforce why I feel like mentorship is so important. And so I had multiple family members and friends who have been incarcerated for over a decade. I attended low performing schools. I lived in areas that were food deserts. I had multiple friends and family members who have either been shot or killed. I know what it's like to lose a parent suddenly at an early age, and I was exposed to drug deals and drug use well before I graduated elementary school. It was something that, at the time, me and my friends would joke about as we got older, that we knew how to spot a hand-to-hand drug deal before we even knew our multiplication tables. Additionally, I vividly remember walking home from elementary school and seeing addicts shoot up. And because they had bleed the veins in their arms and their necks, they, started to use the external genitalia to inject heroin. So, I'm not saying this for pity from any of you. I'm saying this because this is not a game. People are literally struggling and dying every single day as a result of these oppressive systems. And we can no longer sit on the sideline and talk about these things in our little bubbles. We got to get out there and we have to impact change. And so I'm gonna highlight one of my mentors, Mrs. Shirley Roberson. She said this to me. She said, sometimes your mentors can see things in you that you can't see in yourself. And why is this important? Well, this quote, talent is equally distributed, but opportunities are not, shows exactly why it's important. It's extremely difficult to become something that you have never seen. Additionally, it's extremely difficult to walk a path that you don't even know exists. So again, we cannot sit in our little bubbles and talk about these things and not get out in the community and actually interact with these young people and provide mentorship and exposure. So in conclusion, I'm gonna say this: physicians have a certain amount of social status and we have to use that to impact change. Simple steps: unlearning inaccurate information, learning and combating the history of racism and the resulting narratives that we touched on. Become involved in community outreach and increase mentorship to the next generation. So I want to give some quick thanks to my parents. My father, this is a picture of me and my father here on the left. I lost him at the age of 12, but every day I navigate this world. I hope I'm a man that he could be proud of. And then my mom on the right, who is by far the most hardworking and generous person I know. It's been a long road to get to this point, to be able to, give these keynote talks from where I grew up. And for my family, I want you to know that I always put on for y'all and I'll take you every step of the way. And so I want to give you this final thought. Gandhi, who was perhaps the biggest warrior for social justice in the history of mankind, he said, be the change you wish to see in the world. So I challenge everyone attending this conference today to not only talk about enacting change, but to actually be the change we wish to see. And with that, I want to again thank you all for the opportunity. That concludes my talk, and I'll be happy to take any questions.
Thank you, Dr. Vince. That was an amazing talk and very emotional. Thank you for that. Everyone, I encourage you to put your questions in the Q&A and we can ask them to Dr. Vince. We have a little bit of time. I'll start with one question. Dr. Vince, as an early learner myself and many early learners alike, we're encouraged and we feel the pull and need to give mentorship back to the communities that we serve and are surrounded by. And you highlighted Doctors of Tomorrow here, which many members of the leadership group are a part of. What recommendations do you have for the M1s through M4s as we begin that journey of mentoring a high school student coming from a background that may not be similar to our own?
Mm-hmm. Well, I think it just starts with being open and honest, right? Like, someone from, so I come from a disadvantaged background, right? But I'm not going to say to someone who's trying to provide mentorship to me that, oh, you don't come from the same neighborhood I come from, so I don't want your mentorship, right? But being open and honest about yourself and allowing that person to get to know you will establish a trust. And then from that point on, everything else you do, they'll know is genuine, and they're more likely to receive it. So that would be the first step.
That's great advice. A question I was curious about, how have you bridged your work with genomics into combating systemic racism?
Yeah, so, there's been studies done. I do a lot of, I'm in a urologic oncology fellow. So we focus on urologic cancers. And there's been studies done in other fields that show the impact of poverty, the impact of daily racial discrimination on epigenetics, which is not someone's actual genetic code that they're born with, but it influences how that code is now transcribed, right? And so I feel as though we need to do a better job with that within the cancer biology space because, I gave an example in a recent interview that I did with the health lab. One of the things that is commonly accepted is the fact that cigarette smoke can increase your risk of cancer, right? That's an environmental exposure because of the impact that it has on your epigenome. And so why is it that we think that there are no other environmental exposures or lifestyle choices that can actually influence the epigenome? And so that's really where my research is. I'm trying to take it down that path so that way we can really highlight how these inequities have a cost on our on our health outcomes.
Awesome. Thank you for explaining that. Curious on your thoughts about recruitment versus retention. Is one more important than the other, or do we really need both?
I mean, yeah, I think there needs to be both. Because it's hard to recruit somebody to come to your institution if you're not retaining any minority faculty, right? So I think it has to be a combination of both. But that comes with fostering an environment that allows minority faculty members to feel like themselves and to flourish. We could do a better job of that within medicine. I think I don't know if people are posting it in the chat or what. Like I see like little questions popping up.
There was a question put in the chat and the Q&A, so I'll take from the Q&A first. From the Q&A, I really appreciate your uneducation/relearning approach, but you briefly mentioned increasing diverse patient populations in research studies. Have you had any opportunities to have those conversations within the community?
So when I do these webinars, I do talk about the lack of diversity in clinical trials, but I'm just one person, so I can't, impact the change that needs to be, that needs to actually happen on a large scale. And again, there has to be collective buy-in in order to do this. So, so yes, I have acknowledged it as I do community outreach. But again, I'm one person, so I can't speak for everyone at Michigan Medicine, so it needs to be a collective buy-in at the institution level.
Couldn't agree more. There's another question on your thoughts on intentional recruitment. I'm guessing that's in relation to recruiting a diverse group of faculty members.
Well, I mean, we just kind of touched on that, like, intentional recruitment and retention is imperative. Again, but it has to be intentional and it has to be at the institutional level. There's many times a lack of institutional buy-in, right? And so these these places with privilege and a huge platform oftentimes lack a buy-in, right? And so, I mean, I think that was kind of highlighted in that JAMA podcast that recently came out, right? Because people were, it's hard for me to expect someone who benefits from a repressive system to want to make changes about it if they don't even know that it exists, right? Because they're just reaping all the benefits. And if that podcast highlighted anything, that's what it highlighted to me.
Definitely agree. Another question in the chat. Traditionally, mentorship and outreach haven't been rewarded the same way as other academic medicine pursuits and achievements. Do you think that this is changing, and what can we do to ensure that this work is being recognized appropriately?
Yeah, at the fair, sounding like a broken record. There has to be buy-in at the institutional level, right? Like, so this work of doing community outreach, of mentorship. You know, we people who engage in it, we have the same 24 hours as everyone else, right? But this is extremely important. So it should be rewarded and compensated as such, but it's not right now. And so again, at the it sounded like a broken record. There has to be institutional buy-in.
Understood. What advice do you have for junior faculty to advocate for changing an unjust systemized policy within executive department members who talk about DEI, but you know, those that may not be in attendance today?
Yeah, well, I mean, like I said, I'm a fellow, so you know, while I'm considered faculty at Michigan Medicine, like I'm not even in the assistant professorship position right now. So, but in my experience, you know, you share exactly why it's important to you, you know, and sometimes people aren't going to get it, and it's going to be extremely frustrating. But that doesn't mean you stop. You know, I always like one of, you know, I'm a big hip hop fan, and so I always quote like Nipsey Hussle when he says the marathon continues. Like, so when you get that pushback, you keep going, because the marathon continues, because what we're after and what we're chasing, that is so much larger than that interpersonal, you know, interaction you have.
Definitely. Another question, how can medical ethics committees incorporate an anti-racist agenda? And this is being asked from a pre-medical student.
Yeah, you know, that's a good question. I'm not sure that I exactly have like a systematic answer to it. But again, I think everything starts around educating yourself about, you know, the actual history of our country and how structural racism has been implemented, and then you can build off of that. Knowledge and education has to be the foundation, and then you can build off of that.
Great. We'll make this the final question. It's actually from Dr. Finks in the chat. On the topic of retention, we struggle to retain underrepresented students who matriculate to the University of Michigan. They often leave and drop off of STEP pathways for many reasons. What are some ways that you think we can act to ensure their success after we recruit them to come here?
Yeah, well, I think, to be honest, you have to find out what the experience of those minority students are when they get to University of Michigan. If, you know, if I come to a place and I feel as though I'm out of place, it's not welcoming, and it's a semi-hostile environment that is not allowing me to, you know, really reach my potential, why would I want to stay? Right. So, you know, the best people to ask on how you can improve things are the people who are not sticking around, right? Because at that point, they no longer have an obligation to try to sugarcoat things for you. That tell you the truth. You know, I left because X, Y, and Z. And it's up to you to listen to it and actually make changes, or, you know, you can try to allow things to keep going and stay with the status quo.
Awesome. Well, thank you, Dr. Vince. Thank you for your time today and for talking with us
thank you,
and
guys.
answering questions. Everybody, I want to put a plug in for the poster session that's happening right now. The posters from the bottom in the session were moved to the top. So things were moved around a little bit. So go ahead and take a look at that. And we will be back at 1:35 for the Changemaker conversation. Okay. Thank you again, Dr. Vince.
Yeah, it was my pleasure.
Hello, everyone. Welcome for those of you trickling in. My name is Maria Santos. I am the co-director of programming for this wonderful conference. I use she, her, hers pronouns. I am an able-bodied cisgender woman, first-generation immigrant from Bogota, Colombia. Very, very proud Latina, raised in Atlanta, Georgia. I'm currently an M4 here at the University of Michigan, going into family medicine this summer. And I am so excited to be moderating this panel today. It's gonna be an incredible conversation. I think I will have all of our panelists turn on their cameras so we can see everybody. But before we go around and do introductions, I just wanna frame everything for everybody. So we started out the day with Lash Nolan discussing the history, the troubled past of medicine, where we're coming from, which is important in understanding where we can go. We then had panelists discussing the advocacy needed within the exam room and beyond the exam room. And then we just had a wonderful session from Dr. Vince about the importance of uneducating ourselves and these systems of oppression. And this changemaker conversation, I want to emphasize it's a conversation between all of us. It has the intent of presenting several, not only physicians, but students that have already started to do this work. And of course, when you do this work, it's not always all rose petals and colors or whatever the saying is. It's not always pretty. And so that's what we want to get into today. So I will hopefully keep good track of time so we can allow for some audience questions. But like I said, this is supposed to be very conversational. For now, I'll have the panelists introduce themselves. And I also want you to tell the audience what you are most proud of as you do that. So Dr. O, can we start with you?
Good afternoon, everyone. Thank you, Maria. I am Dr. O. I use he, him, his pronouns. I am a cisgender heterosexual man, young to middle-aged Nigerian immigrant. I'm wearing a white coat with a block M, a plaid collared shirt with a wooden bow tie. I've got dark rimmed glasses and brown skin. I've got the diversity in medicine background that is maize and blue. I'm an assistant professor of family medicine, physical medicine, and rehab and neurology, and the director of adaptive sports and fitness, and the interim director of services for students with disabilities. I am most proud of all of the students at the University of Michigan right now for this conference, because every single thing that you see going on right now is because of the collaborative efforts of the students, from this conference to Doctors of Tomorrow to the Student Diversity Council. All of that is student run. So I'm proud to be part of this institution and get the opportunity to work with these students.
And Dr. Cowrie?
It's Aisha Khoury, she, her, hers, cis, queer, which is the first time I've identified as that in such a large forum. I consider myself a Black American immigrant born in Canada to parents from Lebanon, Sierra Leone, Trinidad and Tobago, India, and Spain. I was fired for having such a discussion. And I'm willing to continue to have that discussion. My background is a bookshelf and a print of scientists and physicians of color in white coats and scrubs. I'm currently wearing a white coat and a red blouse with my favorite red tortoiseshell glasses. I am brown with blonde brown hair.
And Erica?
Hi, everyone. It's a pleasure to be here today. My name is Erica Odukoya. I'm a fourth-year medical student at the University of Michigan, currently on a research year. I am from Southern California, specifically San Bernardino County, about 45 minutes from LA, depending on how fast you drive. I am the descendant of two Nigerian parents, specifically they're Yoruba in terms of their tribal ancestry. I went to UC Berkeley for undergrad and did some work in public health afterwards. I am incredibly proud of my team. I'm proud to be on a team of incredible students and colleagues that are relentless and diligent and selfless in this work. I am currently wearing a Black turtleneck, and my background is bright orange. I have deep, dark melanin skin, probably a little lighter from the lack of sun in Michigan. And I have dark brown hair. Just a pleasure to be here. Thank you so much.
And David?
Hello, everyone. My name is David Mata. I go by he, him pronouns. I'm an able-bodied cisgender male. I am Mexican, originally from Mexico City. I grew up in West Michigan. I went to Western Michigan University as an undergrad and a graduate student. Let's see, I have a diversity of medicine background, and I'm wearing a blue polo, just got a fresh fade on my haircut. I'm a rising third-year medical student at Loyola University Chicago Stritch School of Medicine. Thank you for being here.
And last but not least, Edith.
Hi, everyone. I'm Edith. I use pronouns she, her. I'm an able-bodied cisgendered female. I'm Mexican, originally from Ciudad Juarez, Mexico. I grew up commuting across the bridge to go to school in El Paso, Texas. So I claim them both as hometowns, as they're really just one big city from above. I am currently in my office with paintings behind me. I love my art. I'm wearing my favorite gray blazer with a purple scarf, my glasses, and my hoops that give me strength. And I also have black hair with natural gray hair that started coming out when I was probably like 10 years old. I'm also a second-year MD PhD student at the University of Minnesota Medical School.
Okay, great. So as I mentioned, this is going to be a conversation. I do have a set of questions, but if the conversation flows any direction, we can go in. My first question is, it's easy to be a bystander in this space, and I'd love to hear why you specifically chose to do something to change the status quo or implement some kind of intervention at your institution or sphere of influence, and what that journey was like for you. And anybody can chime in at any time.
I'll start, since I probably may have the least formal change maker status, in that I was suspended and ultimately fired from the new school, the Bernard J. Tyson School of Medicine, within 9 hours of having a discussion similar to this format on bias and racism in medicine. I was silent about my suspension for 4 months. In hopes that the school would eventually do what's right. Eventually, because of the significant distress this was causing me, and at the, I think well, I'll keep it brief because we don't have a lot of time. I've decided to continue to talk about my story and try to advocate for diversity inclusion in medicine, because my story is simply one of thousands. And there is a crisis of Black physicians in academic medicine specifically that is going on unheeded.
I want to jump in then, and I will support Dr. Curry to say that, as Maria mentioned earlier, this is a conversation that needs to happen. It's a conversation that people often invite to happen, yet what is then discussed during those conversations tends to make people uncomfortable. I think that if you have been present during this conference thus far, we've had sessions about the discomfort that exists. And unfortunately, I say that that discomfort needs to exist because the comfort that our country has had for too long with the injustices that have been continuing and perpetuated is the reason why lots of things haven't changed. And while we have this change maker conversation right now, I will say that this is only one small group of individuals that are trying to be change makers, because there are lots of individuals that in private circles and DMs and in little Twitter groups and Slack channels are having these conversations. And I think that if we can continue to support one another by recognizing that it is not always safe to have this conversation, and it's extremely isolating and lonely to feel as though you're the only one going through it, that by having these conversations and making others uncomfortable with the status quo, we'll recognize that that needs to change.
Yeah, I'll jump in after that to piggyback off of that really important statement of bringing comfort to the discomfort. And I think that that's something that's necessary, and that's something that people pride themselves in saying they can do. And then once they're thrown into it, it's too uncomfortable. As I said before, I'm currently in the University of Minnesota, which is in Minneapolis, where recent events happened last summer, after the murder of George Floyd. And when the events were happening in the city, the people of color at the school knew that we needed to do something about it. And when we brought these conversations up, we just weren't getting support for it. So instead of just letting it go, we had to really stand up and be louder and be more uncomfortable. And that's something that is constantly being brought up because as some of you may know, tomorrow starts Derek Chauvin's trial. And so the city is getting ready for more. And so now it's the time to be louder.
What I would add to that is my engagement in this work is motivated by the fact that I'm personally affected in some way. There's a really interesting but simple phenomenon in a lot of research circles called me search, which is to say that a lot of us engage in work that is driven by how we are saliently affected by it. And I think that is an impetus that is not incorrect. A lot of us get into healthcare because we were personally affected in health in some capacity in our lives and various other spaces. The reason why I stay engaged in this work is because the people that are not me, that do not have the platform that I have, need me to use the platform that I have. Because ultimately, I think this work, once you engage in it based off of it being about you, you realize that it is not about you.
Yeah, that was a perfect lead into what I was going to say. You know, I used to be undocumented. I started my journey way back in 2011 in Michigan, advocating for a lot of different comprehensive immigration issues. And I think there, my mom really motivated me actually to start, you know, saying something. You know, this is before DACA even existed. So speaking out was pretty dangerous. It was something that I was really uncomfortable with. But the more people I talked to, the more voices I got to hear and the more voices I got to express publicly, I started putting a face with the story. You know, like Erica was saying, I think as you go through this journey, you start realizing that, in fact, it's not about you, it's about other people that need you to speak out on their behalf because they can't or they're too frightened. And so I've continued that work and a lot of life lessons to start developing advocacy curriculums at our school. And so I'm hoping to, you know, kind of teach people kind of like the wisdom that I've learned throughout the years.
Thank you all. That was excellent, excellent, excellent advice. I think in the theme of meeting resistance and institutional resistance and, you know, going against the status quo, let's talk a little bit about failure in that and what failure looks like and how you have not only overcome failure, but maybe reframe the way you looked at failure in this work. I'd love to get people's thoughts on that. I don't know if anybody wants to jump in first, or I'll call on you, Dr. O.
I'll jump in, and actually the way that you even posed the question, this is Dr. O speaking, the way that you posed the question is actually perfect, because as you asked it, I was about to say, I don't even want us to consider it failure, because when you come across a barrier or even a closed door or even a wall, right? Not being able to get over that wall should not be seen as a failure, because we might need to go under the wall or around the wall, or maybe what's on the other side of that wall is not the place that you need to be in the first place and is not the way that you're going to then make the change you need. And so I think that when we think of things as a failure, lots of people talk about how it is through our failures that we then achieve success. And I think we all talk about how it's important to fail, right? I've told people, many of my students know this. I don't publicly talk about this, just like Dr. Curry said that this was the first time she mentioned certain things in as large of a forum. Most people don't know, most of my colleagues don't know, that I failed step 3 the first time I took it. This was after I had been given a role here at the University of Michigan, and I called my chair terrified, thinking that I wasn't going to be able to have a job anymore, right? Because I'd wrapped up my worth in some silly exam that I thought that now somehow I was different because of that failure. And so I think that when we see failure, when we have something that we thought we needed or wanted that we don't achieve, it gives us an opportunity to then learn from what that is and reframe or reposition the way that we choose to achieve that goal. And if the goal is what you're looking towards, we tell people all the time that there's a difference between work and a job. And the work is something that you can continue to do regardless of what job you have and where you're doing it.
And I'll share, I mean, I now have a lawsuit against the medical school, but the medical school is supported by a multi-billion-dollar organization. And part of that organization employs me. So they know exactly how I make and how much of a lawyer I can afford. And I definitely have to redefine what my wins are. So for me, again, when I went onto Twitter and shared my story, I only had 20 followers. I did not expect a response. So the win was having a response. The win was being able to get my story told through Medscape and through Forbes and through our British Medical Journal. It would be easy to be bogged down in the failures, right? To say that, well, I was suspended. And let me tell you, as an immigrant child, that suspension was hard to admit to my father. And then I was fired, also something difficult to deal with. And now the dean of the school, who is responsible for behavior antithetical to the missions of diversity, equity, inclusion, will be speaking on what? Bias and discrimination for the Macy Foundation. And contrary to JAMA's recent commentary, this is exactly an example of systemic racism, because the president of the Macy Foundation is who? The chair of the board for Kaiser School of Medicine.
So, go ahead, Edith.
Oh, I was just going to talk about hearing you talk about your story, Dr. Corey, just reminds me of the isolation that comes when we feel what we may describe as failure, and just going home that day when something happens and thinking, I'm done, this is it. But then, you mentioned Twitter picking you up and kind of giving you that strength. And I know in my past, when I've gone through some of those failures, talking to friends, talking to advisors, that just built me up, made me realize what Dr. O was talking about, how it's really just a wall that is just temporary, and you'll figure out how to go around it or how to find another path that'll take you where you want to go. And I know that that's definitely something I've learned, and specifically within what we call a ladder here, which is really just like when you're on a certain step, looking around at your community, but then, just as we look up to advisors, we also look down towards people that are coming up after us, and making sure that we're loud about what happened, just to make sure that they can prevent it, that they can do something about it after us, which I think is really important to remember as well.
I'm a slow thinker. That's why I had to take a break. Interestingly, I study failure as far as academic and performance, which I think dovetails nicely into how you experience failure and other things that are important to you. What I want to say is that as far as DEI, social justice and advocacy work, where I experienced failure was conflating this concept that I think is important to understand, which is the difference between a value and a belief, the difference between something that is true for somebody versus something that is important to them. And working with anybody that is not yourself, we oftentimes, which is why having conversations about politics and policy and racism and everything gets so confusing, is because we make an assumption that something that is true for someone is important to them and vice versa. And that's not the case. And when working with institutions, it may be important to them to uphold some standard, but it may not be a true enough standard for them. It's important to understand how to engage in a conversation with someone that's different from you, understanding what is important to them and what is true for them. And whenever we engage in work relating to equity and standardized exams, relating to, as a medical student, so this is where my life is right now, clinical performance, related to money for this organization. If the resistance is coming from one angle, we have to understand that it may not be because it's not true, it may be because it's actually more of important to that particular stakeholder. I think for me in general, I failed a lot my first year academically, and then I began to fail personally and socially, thinking that the most important thing to me was advocacy. But advocacy was true for me, but it wasn't the only important thing for me. I had to learn that about myself, and it helped me become more impactful in other spaces.
Yeah, I feel, Erica, I think you and I are in the same wavelength. I think we were thinking about the same thing. I think failure, I also, I didn't pass a class my first year of medical school, and, it put me a year behind. And, I was really, 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 really hard on myself. Because like some panelists already mentioned, we put so much worth in that failure. And, now that, it's over, I'm a rising 30er now, things are fine. New opportunities have come up. I almost take it as a blessing sometimes. I've gotten so many opportunities from this year, and I know there's 231 people. I know there's some of you out there that maybe are in the same boat, and I just want to tell you, you're not alone. The challenges will come your way, and we will. Lo vamos a vencer. We're gonna keep pushing forward. So yeah, and as far as my advocacy work, pushback always exists, I think, and I know we're probably going to talk about this later, but I think it's always important to, find your allies, get buy-in, and really share your story. Share your story. It's the most powerful thing you got.
So, oh, go ahead, Dr. Rowe.
Sorry, really quickly, I'll say, because since we're talking about sort of when you meet resistance to your cause, and we're mentioning institutions, I think that something I'll connect to that sort of faded JAMA podcast that was out recently was the fact that they said that we shouldn't name it racism, and they said that we need to change policy, and they said that we should not see this as something that's about people. Now, people are the ones that create policy, and then people are the ones that create the policies that guide the institution. And so there's no such thing as an institution. An institution is merely a group of individuals that have the power to move the needle. And so when you recognize that those individuals sometimes don't want the needle to move, that is why things are difficult. Now, this isn't meant to be a negative conversation. It's to say, how do you then get to those individuals? It might be that you have to then cut to people that are proximal to them. It might be that you have to just continue saying the things that they may not understand, because one of the things that I failed to say in my introduction, which is something that we'll be doing in a panel later today, but I also identify as disabled. And so there are things that I did not know about disability prior to then entering the world of disability. And so while there are sometimes people that don't understand it because they haven't seen it, we have to recognize that there are sometimes people who understand it very well. They know exactly what they see, but they don't want it. Those are two different categories of people. And we first need to identify what those people are, because sometimes we push against the people that are the former, that they just don't know. And we then conflate them with the latter, who know quite well, but just don't want to make any change.
This is a perfect segue to my next question, and it's in regards to allyship. And I'm going to spice things up a little bit, you guys. I want to talk about performative allyship, and I want to talk about real allyship and like what that looks like. I would love for all of you to sort of get your thoughts on what performative allyship, that I think is very relevant to today's Twitter scape, so to speak, and where the meat of the work really is and what that can look like. And then I also want to, the background of this, and preface this with, a lot of us doing this work are minoritized individuals who have a lot more on the line when we talk about this stuff. So I want to talk about how we invite people with privilege to sort of like reap some of the repercussions, and not just us. Because if we look at, who's getting fired, who's getting dismissed from medical schools and residencies, it's students of color, it's faculty of color. So I want to get into that conversation now. Does anyone have any initial thoughts?
Oh, sure.
I love it.
Because during my suspension, my organization was featured in Time for its diversity. They published in Academic Medicine about how they were a school that wove diversity, inclusion, and equity into the fabric of the institution, and had, et cetera, trainings to help them achieve this. All of that's performative. When you look at the school's social media, when you look at the dean's social media, when you look at the senior associate deans, multiple of them, social media, they give you the sense that I should have been able to have the conversation that I have. I should have been able to be myself, right? But it clearly was not the case when we actually look at their action. When they decided to suspend me, they never spoke with me, right? So I was not included in that conversation. That conversation was not equitable. It was clearly one-sided. And you know, we can continue with the lack of due process when it comes to my firing. And again, this same dean gets to speak about bias and discrimination on March 11th through the Macy Foundation. That is an incredibly huge platform. But where is it and how do we hold people accountable for their belief or their truth and their action?
Yeah, I have come up, this has been a struggle for the last year and a half. And it started even before recent events in the city. I came into medical school really wanting to be a part of SNMA, the Student National Medical Association, because I had heard of it while I was working in Baltimore. And then I learned of the Latino Medical Student Association and that it didn't have a strong foundation here. And so I figured I would want to do that. I became the president. I'm currently the president of LMSA here. And I took on the work of wanting to get a seat at the table. And it was hard. It was one of those where my incoming class was close to 200 people, and there were only 5 of us that identify as Latinx. And so that shouldn't matter. And I was, demanding a seat at the OMAD, the Office of Minority Affairs and Diversity meetings as a person from LMSA. I was asking for funding that other groups were getting, and it was a constant no. You just don't have enough representation, and that was difficult to see. And through that, I got to meet several people who became part of my crew throughout the civil unrest that happened after Mr. George Floyd's murder. And many of my classmates were, on social media, sharing these information, these support for Black Lives Matter. But when it came down to doing the work, no one wanted to do it. No one wanted to put a face to it. And we were out there, organizing protests against things within the medical system that we thought were not okay, and being brought to light after many things were going on in the city. And we had deans that were, again, sharing things on social media, having press conferences, sharing their support for the movement, but within the school, within the, the medical system, there weren't changes happening and there wasn't support happening for people of color. So it's really just finding ways to keep people accountable and to say, well, if you support this, how are you going to show up at meetings? How are you going to advocate for students of color that need your help and that need your significance as a mentor?
So this is perfect, because as someone put in the chat, students with disabilities often have the same response made, that there are not enough of them. I think that by definition, minority groups all have that same concern, because since by definition, we are the minority, there are not as many of us. And I forget who it was, I think it was Dr. Opara said it earlier today, that we are not a voice for the voiceless. They have voices, they just aren't being heard. And it's because those voices are devalued, undervalued, marginalized, discriminated against, is the reason why those voices are not being given a seat at the table. And you should not be saying, how many seats do you have here, in order to then say that your voice or your life is to be valued in the same way as someone else's life. And so I think that this is, to continue bringing this back to the question that she asked about performative allyship, and how we can then demonstrate that there's true sort of effort behind this. I was a visiting professor at UCLA last week, and one of the leaders there said, if you want to know an institution's priorities, take a look at their budget. And so if these are things that we are not actually prioritizing in the thing that we do, because what we hear too often is that we don't know how to do this. We now recognize that this is important. Thank you so much for calling our attention. Thank you so much to letting us know what it was that we missed. This is right. Racism is terrible. Sexism is terrible. Ableism is terrible. But then we expect our learners and trainees to be the ones to educate us about what we need to change. Yet they expect us to come up with some 25-year plan as to how we're going to get there, but they don't want to start until we've given them all the answers. These things needed to happen yesterday. Therefore, there should have already been a plan in place. So if you want to put resources towards it, there shouldn't be any more questions as to where the resources should go if this is something that you truly cared about before just now. I'm perfectly fine with people recognizing that they just started caring. And then if you recognize that you just started caring, then let's put something together. But we can't say we've always cared about this, yet that not have a plan that we can tangibly put in place and resources behind it to do so. So that's that change-making part, is the allies that are able to then do something actively to support are those ones that we want to pay attention to. Because you don't need to bang your head against the wall when it's clear that someone doesn't want it. Because unfortunately, that's the reality. We don't all have the same thoughts, opinions, and emotions. And therefore, you cannot always force someone to think differently than they might think. But there are plenty of allies out there that when they've been exposed to this information that they truly just didn't know, they do want to help. And we have to be careful not to ostracize those majority, because then they will just continue to make it even harder for the change that we need to happen.
The experience that comes to mind when I think about this conundrum of performance allyship and how to translate it into something that is tangible and sustainable and longstanding, is just this experience where I had an incredible privilege to be able to address Michigan medicine at a town hall shortly after George Floyd was murdered. I think it's interesting that that's the precipice in which things apparently changed, but that's not the actual event that changed in most people's lives. But from an institutional level, I guess due to the level of transparency, that's when a lot of institutions wanted to start becoming more prominent and vocal about anti-racism. Anyways, that is to say that I was extended an opportunity to speak to the Michigan medicine community, which was some 5,000 people. And I was asked to speak on behalf of the incidents that medical students experiences in the setting of racism and discrimination. And to say that I was nervous is an understatement. But the reason why I was nervous, if I was to be transparent, is because I felt as though I needed to do diligence to the experiences that were shared with me, but I was scared for how it would impact my own seat at the table. I think a lot of the excitement about being an ally is that one day when I get to the table, I'm going to make this incredible change. And I would be less than transparent if I didn't say, I'm terrified that when I get there and I say the things that I want to say and speak on behalf of the cause that I want to speak about, my seat will be removed from me. My seat at the table is as important to me as it is to the people that I hope that I'm reflecting. But I would say that I asked classmates to give me their experiences, and I got maybe 48 plus experiences from people texting me, emailing me, calling me. And I felt as though I owed it to them to be true to their experience and share it. But I knew it would be coming out of my mouth. So the last thing that people would hear was me saying this institution has inflicted racism on its own people in some way. And the backlash of what that would do to me personally, I was terrified about. I think in the context of being an ally, there is no one that is infallible, or people are not machines. We are concerned about our own mortality in the space of advocacy. I'm truly honored to be in the space with Dr. Corey, because I can't imagine that experience when you feel as kind of you're forced to martyr for something. And I think there's a lot of excitement in wanting to speak on behalf of other students and and other constituents, and you feel as though it's a calling and it's necessary. But there's a lot of fear and loneliness for the backlash after the lights are turned off and it's just you, and you are receiving the brunt of what you seemingly asked for. Or feeling as though you asked for it. I'd say that it's still an honor to be able to serve my classmates and be in spaces, but every time I open my mouth to say that this experience impacted somebody that's not me, and I have to be just as vocal as though it happened to me, I am concerned about what will happen next to me and to them.
Yeah, I wanted to add, as I'm hearing you talk about this allyship, it really brought me back to when I was living in Baltimore. I lived in Baltimore for 2 years before starting med school, and I was thrown into a culture that I was honestly hadn't been exposed to before. And this was during the time that the community was grieving and Black Lives Matter was kind of on its upswing. And I wasn't sure how to be a part of that. I wasn't sure how to be an ally, and I didn't want to, I didn't want to like block the light from a culture that I'm not a part of, that I don't know much about. And so I didn't really get involved as much at first. And I learned over the years with a lot of my friends that were very vocal about it and that taught me a lot about it, was that it's okay to be an ally as long as you listen, as long as you read up on what it is you're talking about, and as long as you ask people within the community that are grieving, what is it that I can do to help? And that's kind of what's going on here in Minnesota, is one of those where our class is mostly just scared to speak up about it because they're not part of this culture, they're not part of what's going on, and they don't know how to be an ally. And I think when you're scared to be an ally, you get more thrown into performative allyship without wanting to be. It's very easy to be a part of that now through social media, but we've started workshops where we try to, bring exposure to books, to resources out there that really explain the perspective of certain issues that are at hand, and how can you really read up on it, how can you help, how can you get in there and be involved without overshadowing those that really do need their voices to be louder. So a lot of times it's really just supporting and even just lifting up other people, sharing their voice, sharing their story, so that you can just help amplify that.
And I just want to add, I think to your point about knowing that you're an ally, even when you're like a minoritized individual, knowing you're an ally in certain spaces versus others is so important. Like for me, like the LMSA, the Latino Medical Student Association, is a space, but then I'm uplifting my Black colleagues, and that's not part of like the burden that I'm carrying and pretending to carry for them. And then I want to talk a little bit more about like how allies who are not minoritized look at minorities and sort of group us all together, and the dangers in doing that. Because we all have very unique struggles, and they're different struggles. And so I'd like to start off with anybody who wants to talk about that, just the danger in grouping minorities together and generalizing the struggle for all minorities.
So this is Dr. O. I will attack this from both sides. I'll attack this one by saying, I think that the primary thing that we could achieve is the recognition that the basis upon which this has all been created is inequity. And all minoritized groups experience this inequity, but it doesn't mean that the resource that is needed or the attention that is needed is the same for each group. And so that's one thing, because I often think that sometimes minority groups don't do a good enough job of recognizing that the struggle is a shared struggle. And it seems as though it's a zero-sum game, that you can't be an LMSA, not saying this is what you're saying, Edith, but that one can't be an LMSA and in BMA, right? Black Medical Association and the Latino Medical Association. You can't be, supporting LGBTQ rights and also supporting Black Lives Matter. You can't be supporting gender equity and be supporting disability. And as Milady said, it's the intersectionality of experiences that is everywhere. So that first answer to say that intersectionality of all of us is what humanity really is. And so therefore we shouldn't have to then choose which group we want to support, because the goal of what we're supporting is equity for all of us. However, what people then do is the same thing where they lump groups together, just like they say all Black people act this way, all white people act this way, not every white woman is a Karen, and not every whatever demographic person here is insert racial slur or stereotype name there. However, this doesn't mean that there aren't some Karens that need to get checked, and this doesn't mean that there aren't some Black people that need to sit down. And so I think that is the difference, is that we make it some division where it's a Black or white literally, and that someone has to be all this or all that. And I have even been told that I have to decide whether I want to support disability or I want to support being Black. And I said, I cannot split those things up because I'm both at the same time. And we both have that sort of multiply marginalized sort of exponential factors that then add to this that make it hurt me so much more, where everywhere I turn, I feel like whatever it is that I am is being told it's not good enough. So both of those have to happen. where yes, we need to support because the overall theme is that there are systems in place that devalue entire groups of people. That it's like a lion splitting up the pack of gazelles and going after the weakest one. And then each of us have this marginalized identity that then makes us weak to the majority. But if we come together and recognize that the same goal is what we're looking for, we can get people to focus on the specific needs of each individual group to then make sure that each group gets what they need, because it's not always the same.
I wanted to piggyback off of what Dr. O said there, because I think it was brilliant. And I think if I was to speak again transparently, because we're here, is that there's all these great activists and public health terms. And one of them that I really love is called collective efficacy, which is this idea that, together we can be more effective than, in our individual parts. And I think that type of concept is what makes the erasure of individual minority groups' needs for the sake of aligning to a very specific and specified end goal okay, right? Which is to say, if you and you and you don't think about what you individually need, but we can come together to create one need that will somewhat satiate all of us, our collective efficacy will be effective, meaning in all situations, and efficacious, meaning in the best case scenario. Here's the actual problem with that, though, in other situations. Very real example. I remember this past year, I'm so sorry if anybody on admissions is on this call, Michigan had a very extreme drop in the number of African-American students that were that enrolled in the university. I think it went to 5 or 6. And I remember myself starting to say this over and over. The number of minorities is dropping in Michigan. I said that. And I remember thinking a couple of weeks later, is that true for the other groups? I never really asked. I was so geared up based off of this one statistic that I completely neglected to see if the other groups were affected in the same way. Why does that matter? Because the solution is not the same for all of the same groups, right? So if the situation is we're not recruiting enough African-American students, or is it we're not retaining enough Indigenous students, or if it's we're not actively doing X, these are actively different approaches and mechanisms to different problems. But the erasure, a collective efficacy, increased URIM retention is not going to get at the other individual groups. So there's a sacrifice there that I understand. In some scenarios, it seems fine, because if we can say, everybody come to the Black Lives Matter rally because it's important, and I get that. But if tomorrow we don't have the same level of arousal to the increase in attacks against Asian American individuals because everybody says, I was at the Black Lives Matter rally yesterday, so I care about minorities. I care about all minorities. But this group is experiencing a different type of attack. I think that is to say, we have to understand there is a sacrifice. It's not a problem that I think is insurmountable, because we all have different voices and different spaces where we're salient and powerful. So if we all tap into that, idealistically, I think we'll be fine. But I think it's a matter of realizing that the erasure has pluses and minuses that are going to be evident in different spaces.
So we have a couple questions in the chat that I think are grouped together really well here in the last few minutes that we have together. So the first question is, what are some ways to motivate other students, allies, and other people of color to join a cause and stand by it? And then the other side is, do you have any tips on how to navigate relationships like the ones you have with administrators that seem necessary to accomplish any work and are plagued with toxic power dynamics and active barriers against health equity work? So 2 components to that question, but I think they're tied together really well in how you can leverage that conversation. So if anybody wants to take the floor to answer that.
Yeah, I can start this one. So I think this one, I think it's one of the biggest lessons I've learned throughout my advocacy career, and that's storytelling. I think putting a face to these issues is one of the most important things. Personalizing these issues is, for me, has been one of the strongest things. I think, Loyola is known for being a DACA leader around the country. We accepted DACA students in the beginning, and I think a big success of that was us sharing our stories, us sharing, what we were going through. And I think that had a lot to do with the institutional changes that were made at Loyola and beyond, and now nationally. So I think, part of getting allies on your side is, I think, number one is to share your story. I think it really personalizes the issues. I forgot what the other parts of your question were, Maria, but I think Could you repeat them?
Yeah, so the other part is like how you manage like other students and bring in other students to work with administration, and like also recognizing the power dynamics that there are in that. Sorry, I like forgot to pull it up.
All good. So I think the other parts is I think like you said, finding the allies. I think something that's also is really beneficial is finding the allies at your school. I think having the leaders, having the right people be on your side. I think the bigger your team, the bigger your effort, right? So I think it's something that's worked for us and it's worked for me. And yeah, I don't know who else would want to add to that.
Yeah, it's a process to recruit people because I think Erica mentioned this earlier, where it's like, well, they don't have to worry about, they don't live with this every day. They don't carry this every day. It's something that people visit for one day and they're like, oh, that situation really sucks. And then they can move on. So it's just reminding them that this is happening. And so here, after we realized during our first year in med school, there were a lot of cases of race-based medicine that we were being taught and we were very angry about, and we were speaking up about it and nothing was happening. So during the summer, we decided to create a group of student leaders, most of which were representing the different cultural groups, but we came together to force this group upon administration that I don't think was very invited at first, but we kind of demanded a seat at the table. The Medical Education Reform Student Coalition, we created these small groups within it. At first it was chaos. We didn't know how to do this, but we had a weekly meeting with the dean of the med school, and we knew that we had to bring these issues forth. And it was, again, chaotic. We were just like, we don't like this and this and this and this and this, and we had no structure to it. And so we decided to sit down and really just create these tiny bubbles within that became their own initiatives. And so one of them was curriculum based. Another one was our clinical encounters. So we have standardized patients that we practice clinical encounters with. So how do we recruit more people of color? Here in Minneapolis, we have a large Somali and Hmong population that we are not exposed to until we enter the clinic, and that just is not okay. And for many of us who are diverse medical students, we're not from the state of Minnesota. A lot of us are what we call transplants. So it's, I still have not met a Hmong family, but one day I might have to take care of them. And for them to not offer us that exposure is ridiculous. And also Native American families here. And so we are really going out of our way to tell them, you need to do something to make sure that our medical students are being trained in these specific cultural groups that have different needs, that we just are not sure of how to take care of these specific patients. So we are still having monthly meetings and we're still keeping them accountable. So we demanded this last month, why has nothing been done? And we also have reporters from local newspapers that are following up. And we have a live feed of what's being done and what's not being done, and keeping the med school accountable. And so we've already started recruiting first year students to take up on our shoes as we're kind of transitioning out of our roles.
I just wanted to add in incredible comments from everybody. This is so amazing. What I wanted to add in is something that I'm learning every day, which is just that when the concept of mobilizing arises, I think we should find out if we're trying to bring people into our cause or if we're trying to address a cause. I think it gets so confusing when you realize that that the things that you're rallying for, they may be important to you, but not the most important thing or important to someone else. And I think that the humility of knowing that there's things that are important that you don't care about will help you broaden your perspective. 100% true, which is to say, when you mobilize, I really pray that we all show up for someone else's recruitment the same way we're recruiting for our own causes. If the only things that I attend are rallies to support Yoruba medical students in Michigan from California, then I will be the only one there. It's not a testament that it's not important because I'm the only one there. That's equity and equality, it's fine. But it's just the reality of, am I only acknowledging my own ailments, or am I opening myself to the fact that this world is much bigger than myself? I think I would say within that, show up for other people to the same energy and capacity that you show up for yourself, because hopefully you will find yourself when you show up for other people.
So I now take a stab at this. I don't know if I'm centered. Can you guys hear me? Okay. So one, I think it's really important to recognize our individual and collective power. The hierarchy in medicine is very real, but the hierarchy doesn't exist if there aren't people below. And so the idea that there is no medical school without students. And so first, I think your allies have to come from within the group around you, right? So if we are trying to improve something within the medical school, it is to share the individual experience with your colleagues and then go to the administration. I think once we get to leadership, then we have to look at power dynamics and leveraging. And as Dr. O already pointed out, first you look at the budget and then you look at the organizational chart. And this is how you determine where your leverage needs to be. And while your target may be admissions, how you reach changes in admissions may be different depending on the budget and dependent on the organizational chart. And I think when we are having bigger issues, so I was removed from my institution, so I could not necessarily use anything with my institution because I was supposed to be silent. Otherwise, I would have been immediately dismissed before my actual dismissal. See how processes go. But then it was, okay, I need to make this a public matter. Now, I'm not necessarily great at that. I'm fairly bullheaded. It's my Lebanese Indian side. I feel like if I speak my truth, it will resonate with someone. And as long as I'm consistent in my truth, my integrity will continue to speak out. All I see on my screen is Erica laughing. And so with that integrity, with that continued dedication to my issues and concerns, I feel like people will come when they are ready. Because that's the other thing that we have to balance, is that especially those of us who are wanting to be in an advocacy space, there is that potential for burnout, and there is that potential for tiring. And there is that if I am not getting a win, I'm just gonna pivot to the next cause because I didn't get my win in this cause. And that's where we need other people to be faithful and to be dedicated. And it's okay to take your week off of Twitter. I do it very regularly, but then to come back and to come back re-energized and refreshed.
Thank you all so much for joining this panel, for being here with us and being vulnerable in this space too. I'm like speechless. I don't have any good words. It's just all been incredible. I've learned a lot, and hopefully all of our audience has learned a lot too. We're going to take about a 1 to 2 minute break really quickly before we start our next workshop with Dr. Alistair Martin about voting like your health depends on it. So civic engagement in the healthcare space. And we'll get into a little bit more of, actionable change that he is already working on. So thank you all again. I can't say enough good things. I did see a question that was unanswered. I'm going to send it off to the panelists to answer, and then we'll send it out to the audience because I think it's a worthwhile question for sure. It's about tokenizing minorities, one of my favorite topics. So I will see you guys in about 2 minutes, and then we'll get started with the next session. Thank you all so much. All right, everybody. I think everybody's coming back. So I already introduced myself for those of you joining us. My name is Maria Santos. I am an M4 here at the University of Michigan. I go by she, her, hers pronouns. I am an able-bodied cisgender female, first-generation immigrant, born in Bogota, Colombia, very proud Latina, raised in Atlanta, Georgia, and I'm going into family medicine this summer. I am so excited to introduce this next speaker, who I'm so proud to call a mentor, friend, a dance partner, if you will. And I'll just give a very brief bio. So Dr. Alistair Martin is a practicing emergency physician and former chief resident at the Massachusetts General Hospital. He is a dual degree graduate in Harvard Kennedy School and Harvard Medical School joint degree program, and served as a former health policy aide to Governor Peter Shumlin of Vermont and Congressman Raul Ruiz of California, and blends state and federal policy knowledge with hands-on patient experience. He now serves as faculty at Harvard Medical School in the Center of Social Justice and Health Equity, working at the intersection of public policy and medicine. He is the founder and executive director of ODR and the national organizing director for Get Wavered. And like I said, I can't say enough good things about him. And without further ado, I'll let him speak.
Maria, very good to see you, and so glad to be here. Thank you for inviting me. My name is Alistair. I use he, him, his. I'm an able-bodied cisgendered man, and I'm an African-American man. I take care of patients at Mass General Hospital as an ER physician. And today we're going to be talking about the intersection between voting and health, and how if we really want to change things in this country, we've got to help people vote, and we've got to do it in the settings where they often are sitting, waiting for hours, like, emergency rooms, community health centers, primary care clinics, where we have effective, trusted messengers like healthcare providers to invite them into the process of voting. So first, I'm going to share my screen here. All right, we're going to get right into it. They told me to make this a little interactive, so I gotta meet the demand here. And we're going to start with a little pop quiz. Pop quiz. You're going to see a couple of questions here on the screen. And what I want you to do is I want you to look at the questions real hard, and I want you to try your best to come up with the answer for each one of the questions. And in the chat, I'm going to give you a minute and a half, okay? In the chat, I want you to put how many of these questions you think you got right, okay? Be honest. Question number one, what is a Republican form of government? Who knows the answer to that? Question number two, what are the names of the three branches of the United States government? Number three, in what state senatorial district do you live? You cannot use Google, by the way. It's a pop quiz. It's not an open book test. You cannot use Google. I don't want to see anybody's phones. I don't want to see any other tabs on Chrome. You got to answer these questions right off the top of your head. Question number four, what is the name of the state judicial court in which you live? And what are the names of the county or counties in such district? So write in the chat, please, how many of these questions you think you got? I feel like I could get one of these right. So I'm just going to say that just to sort of figure out, just to let you all feel sort of normal about where you might be coming in. So let's look at the chat. Let's see what we got. See, if I see a bunch of fours in here, I'm going to have some questions. Let me see. I see 2.5. I see 1 out of 4. I see a lot of ones. A couple twos. Sarita, I like that a lot. Oh no, the top of my head is broken. LOL. Excellent. Okay, so on average, I mean, I'm not a statistician, but I would say on average, the average is about 1 to 1.5 from what I'm seeing. Let's keep the answers coming in. We're going to get a little harder now, a little bit harder, just a little bit. Okay, a little harder. These 4 questions. If a person is charged with treason, if a person charged with treason denies his guilt, how many persons must testify against him before he can be convicted? Who knows the answer to that? Question number 2, at what time of day on January 20th, each 4 years, does the term of the President of the United States, and again, I want to see no Google, nobody looking at this on your computer. Question 3, if the President does not wish to sign a bill, how many days is he allowed in which to return it to Congress for reconsideration? Question 4, if a bill is passed by Congress and the President refuses to sign it and does not send it back to Congress in session within the specified period of time, is the bill defeated or does it become a law? Short answers, please. So I want to look again. I'm going to check the chat out and see what we got in terms of how many people, how many questions you think you could answer correctly here. Let me take a look. Take a look. 0. 0. I see a lot of 1s. Which one would you guys, are you kidding me? You would get 1 of these right? Unreal. I would get 0 of these questions right, but okay. I see a lot of 0s and I see a lot of 1s. So I'm going to say that the average here is about a 0.5. What did I just make you guys do? We've been joking. We've been having fun. In order for you to have voted in the state of Georgia in 1965, you would have had to answer these questions correctly. These are the 4 easiest questions out of 30. These are the 4 easiest questions out of 30. You need a 100%, by the way. These are the questions from Alabama. These are the 4 easiest questions out of 25. Again, 100%. If you're a person of color in certain parts of this country, within the lifespan of our parents, and you saw these questions, it's possible that you saw these questions because you were trying to vote in this country. This is a literacy test. And throughout the South, and by the way, also throughout some parts of the North as well, and the Midwest, African Americans and people of color throughout this country were systematically obstructed from voting. Why? Because voting is how you change things. You know, I have a lot of conversations with my patients about voting, you know, because of this whole vote ER thing. And often I hear patients say, you know, well, what does it matter to me? Like, I don't, like, voting ain't, you know, it's not that serious. Well, if it's not that serious, why are they trying so hard for you to not vote? This is the state, and I want to sort of make sure that the history is clear here. We got to start with the history to understand why it's so important to make sure that we vote and to make sure that our patients do it too. Let me give you just one more. This is the state of Louisiana. I saved the best for last. First of all, just check this proviso out at the top. Do what you are told to do in each statement. Nothing more, nothing less. Be careful, as one wrong answer denotes failure of the test. You have 10 minutes. Let me draw your attention to this one. In the space below, draw 3 circles, one inside, engulfed by the other. What? What about this one? Draw a line from circle 2 to circle 5 that will pass below circle 2 and above circle 4. But like, is it a line? If it's like, there's so many questions. The bottom line is these were set up for you to fail. Now, a lot has happened since then. Thankfully, we had the 1963 and 1965 Voting Rights Act, which did a lot to peel back and to protect the ability for people of color in this country to vote. But let's just look at the most recent history. In 2013, we had a really, really important court case. And Shelby versus Holder basically gutted the Civil Rights Act. We're not at square zero again, but we're like at square 0.5, okay? The things that you just saw, now because the Civil Rights Act has been gutted, are on the table. And if you don't think that, the folks that don't want people, like me, people of color on this line to vote, well, guess what? It's already happening right under your nose. This is from the Brennan Center. 2021 restrictive bills. Basically, each one of these states is where there is a law that is either being proposed or has been proposed to restrict voting access. So the fight continues, and it's incredibly important for us to stay vigilant and understand and protect from backslide sort of all the gains that we've made. I want to tell you one other story. This is a legend right here, Frances Fox Piven. This woman is 89 years old. Does anybody know what Frances Fox Piven did? If so, put it in the chat. I'd be so curious. While you're doing that, let me tell you, Frances Fox Piven started the Human Serve campaign, okay? This was a campaign that she started back in 1983. She's a social worker. She started this with a very small team of social workers, and really this turned into an incredible movement. In 1983, the Human Serve campaign aimed to increase voter registration among clients at public and nonpartisan and nonprofit agencies. She first started by trying to persuade governors and mayors to implement voter registration basically by fiat, sort of by decree in state agencies and city agencies. She then went to directors of voluntary and social agencies, places like WIC, welfare, unemployment, and tried to persuade them to make voter registration a function of, getting your WIC resources, a function of getting welfare, a function of getting unemployment. And she went one by one to these agencies and these services and these governors and these mayors until she hit it big. In 1993, she was able to work with then first-term President Bill Clinton to pass this law, the National Voter Registration Act of 1993. And what this law set out to do was to make it mandatory in places like DMVs to do voter registration. So if you're at the DMV, it mandated them to offer you and invite citizens voter registration. It also encouraged hospitals to promote voter registration, but it didn't make it mandatory. And so I was talking to her. I actually had a conversation with her just a couple weeks ago, and I was like, "What's up?" So, like, Frances, first of all, this is, it's an honor for me to be talking to you. I feel like in many ways, the work that I'm doing sort of stands on your shoulders, and you've just been an incredible trailblazer. But I got to ask, why did you pick DMVs as the place to do mandatory voter registration? You know what her answer was to me? It was a negotiation. I said to her, why didn't you pick hospitals? She said, we knew healthcare was an important place to register poor people to vote. And so did the opposition. It's been one continuous story in this country, trying to restrict and obstruct poor people, vulnerable people, people of color, from the ballot box. And how does healthcare fit in? Well, healthcare fits in because when you look at the demographic overlaps of who is not registered to vote in this country and who is most marginalized by our healthcare system, the Venn diagrams are nearly completely overlapping. Young people, poor people, people of color. And so we at VOTER believe that there's an opportunity there an opportunity to bring hard to reach potential voters into the electorate via trusted messengers, like healthcare providers, like physicians, like nurses, like social workers. We do that with these 3 different tools. Some of you have these already, which is great. Some of you, by the end of today, will have to think about, what role do you want to play? We use tools like the Healthy Democracy Kit. These are lanyards that basically have a visual prompt on them. And often patients will ask me, hey, doc, why does your lanyard say vote on it? I say, well, it says vote on it because if you're interested, I want you to take 30 seconds right now, and I want you to just make sure that you're registered to vote. That's it. I don't care who you vote for, but just make sure you're registered. Number 2, we create site-based materials like these posters, and we deploy them to hospitals, and then we create text messages like you see on the right, and we have health centers send them out. This is Dr. Steger. She's a physician, a pediatrician in Ohio. She does this as part of her social history. She says, do you smoke? Do you drink? Are you registered to vote? Simple like that. 24,000 healthcare providers like Dr. Steger have these Healthy Democracy Kits. 60% of them are physicians, 23% are medical students, 10% are nurses and PAs, and 7% are social workers. When you ask these healthcare workers, why are you getting involved in voting? Why are you making sure that patients can vote? The number one motivation, the number one answer is to address social and racial inequities. And interestingly, we saw the biggest spike in these orders for Healthy Democracy Kits after George Floyd was murdered, after the protests started, after this period of racial reckoning in this country really got going. Who did we help? When we look at the data in terms of who, from an age and race standpoint, who are the people that were helped to vote, 50% were people of color and 40% were younger than the age of 29. So the population that we're helping skew more likely to be people of color, and then also they're more likely to be younger. So in summary, in terms of just the high level impacts, this is just sort of the numbers. We're going to talk about some other impacts in a second. About 46,000 people were helped to vote in 2020 by VoteER. That's either with voter registration or mail-in ballots. And that's because people like you, many of you, how many are there? 197 people. I think there are probably several dozen of you who are already doing this, who are already helping people vote. Thank you for that. You contributed to that number. 24,000 healthcare workers across the country got these kits, and about 700 sites use these posters, these discharge paperwork. And there are about 100 medical associations and national organizations like SNMA, like LMSA, like the American Medical Student Association, who are our partners. Hospital CEOs have also gotten on board. There are over 300 hospitals that promote voting through VoteER. These are just some of the emails that have been sent out throughout the country at some of these big tier 1 hospitals like U Cincinnati, Mass General Hospital, the M Health Network. This is University of Minnesota. And then obviously, as I mentioned, the organizational sponsorships and partnerships really sort of helping to blast this work to the next level in terms of making sure that healthcare providers can be defenders for our democracy and healers in a new way, not only healing people in the individual body, but healing the body politic. This is the most exciting thing I want to share with you today, and that's because it's people like you all, like many of you all are students. Guess what? Our student program was by far the most successful thing that we did over the course of the 2020 cycle and in the Georgia runoff, in the Senate runoff. The work that we did in the 2020 and the Senate runoff with students was called the Healthy Democracy Campaign. Okay. At each medical school, we got 2 medical students who were selected to be the captains. We taught them very, very, very basic community organizing principles. They put together a team. Most times they're just best friends, like they're 5 to 10 best friends, but some of them actually made the whole school into their team, which was really dope too. And we created kits that were specific to their medical school. So every time someone used a kit at their school, they got a point. These captains were able to hold each other accountable, the teams accountable, and the students were able to see how many points they got. And so there was a really cool gamification aspect. Each one of these students alone accounted for 40 people registered to vote. That's insane, absolutely insane, and so productive. Just the students alone across these 80 medical school teams that participated helped nearly 15,000 people, either with voter registration or with mail-in ballots. That's like unheard of. So how can you get involved? There are 3 easy things that you can do right now, and then 3 things that I want you to think about, okay? Number 1, make sure you're registered to vote. You got a phone, scan that QR code. And if you don't want to scan the QR code, there's a URL right there. Take 60 seconds and make sure that you are registered to vote. Some people are going to say, no, I'm good, I just voted. Okay, have you gotten married recently? Because if you change your name, you got to register to vote again. Have you moved? You got to register to vote again. Did you just, go from one program to another? You got to register to vote again. If you went cross state, for example. So take 60 seconds. Number 2, get a kit to make sure other people can vote. There are thousands and thousands and thousands of people who are already doing this. They're just like you, and these kits are free. So take advantage of it. We really don't need to sell anything here. At the end of the day, this is all about just making sure that the idea of healthcare providers helping patients vote gets promoted. And then lastly, if you work in a clinic where you do rotations and the clinic director is super engaged and interested in voting and civic engagement, or if at your hospital you've got a champion or a faculty provider, or if you yourself are an authority figure at your hospital or your residency program, and you want to get posters or discharge paperwork, you can do that here through our site-based program, and there's a QR code right there. Lastly, in terms of the 3 things I want you to think about, there are a couple ways to get involved at sort of a higher level, and that is through these 3 different options. So number 1, at the end of the day, if you're not building power in people, then all you're doing is really sort of mobilizing these one-time efforts, and we understand that. And so, if we really want to make a difference, we've got to train you and build your capacity and your skills as community organizers. And so if you want to get involved as Healthy Democracy Campaign, which Maria was a captain for, and I think University of Michigan came in pretty high as well in terms of how well they did. If you want to get involved, then please go ahead and I'm putting a campaign link. You can learn about it, you can get involved, you can click there and you can sign up for it and be involved in the campaign. Number 2, you can learn the basic skills of community organizing through our Civic Health Fellowship. The Civic Health Fellowship is going to be starting in May. And it's going to be a great one, and we're going to have a lot of fun, and we're going to teach some people how to organize. And that's sort of a more in-depth, a more robust training experience. And then lastly, we have our Civic Health Conferences coming up in April. And if you hit that link that I just put in the chat, we'll make sure that you get signed up for it and you're ready for it. That's all I got. I have not been paying attention to the chat. I am so sorry, but I will definitely take a look and see if there's anything I can get anybody else.
Yeah, and Alistair, we have about 2-3 minutes, but there are a couple questions. I don't know if you can see them on your end. I can read them out loud. The first one is, how do you believe this maps out to our disabled patients who are unregistered to vote? Then if they can register, deal with inaccessibility at polling places and voting locations?
It's a really good question. And the hard part about that is that it's really state dependent. For example, the voter registration process in general can be done for someone else if that person has valid ID. So there are some states where, if you have your social security number, you can use that number as the sort of proof of identification. You can sign up on a website via online voter registration. So that person doesn't have to actually go to any facility to get registered. Now, when it comes to actually voting, it's really, really challenging because you have to get someone to sort of be your designee, and that's very much state dependent. So my answer to that question would be make sure to check in with the state, with the Secretary of State offices, and just see, what are the options, and is there a possibility for someone to be sort of designated as being able to vote on behalf of someone else.
Next question here. It seemed like some of the institutional support, at least my community hospital, was tied more to the potential changes in health policies, such as the ACA, not to address racial inequities. How do we push to continue the support for promoting voting when health isn't always as clearly on the ballot? And then in parentheses, though, of course it always is.
Well, I think what we have to do is, we as physicians, as medical students, as clinicians, we have to make it a point to draw the connection between health and voting. We have to be the ones to say, I'll tell you a story. I was taking care of a patient recently in the ER who was coming in for asthma. We talked about, her asthma. I was able to get her feeling much better. And as she was leaving, I said, by the way, we got a big race coming up here in Boston, the mayor's race. Are you registered? So why would I want to do that? Like, I'm good. I was like, okay. Well, you see how I'm writing you this prescription for albuterol, right? I'm writing you a prescription for albuterol because you have asthma, just like everybody else in your neighborhood. And everybody in your neighborhood has asthma because you have toxic chemicals that are being burned right down the street. You have a tire factory and a gypsum plant, and the air that you all breathe in that community is polluted. That's why you have asthma, and the patients that are living all across the way in the richer parts of town, they don't have to come in to see me for their albuterol. And guess what? Those companies needed a place to dump their chemicals. They needed a place to pollute the air. And they weren't going to do it in the downtown, nice, rich, wealthy, white suburb. Why? Because they knew they would catch hell. Because those people vote. So at the end of the day, we as physicians and healthcare providers have to make it clear why it's important, why voting and health are linked. And you're right, every year is an election year.
And so I think we're actually out of time, but I will consolidate some of these questions and get them up to Alistair so he can answer them, and then we'll send it out to everybody who was here and was unable to attend as well. Dr. Alistair Martin, thank you. Thank you so much. This was a wonderful talk. I think we're going to take about a 1 to 2 minute break, and then we'll move on to the next workshop.
Okay, so I think we're ready to start the next workshop session. My name is Sheena Barlumi. I use pronouns she, her, hers. I'm an able-bodied cisgender female, and I'm a third-year medical student at the University of Michigan Medical School. I am an Iranian American born in Rochester Hills, Michigan, and today I'm wearing a black shirt with a tan background. And I want to welcome you to a very exciting workshop. It is the Disabusing Disability Workshop. Enough about me, though. I will just be your moderator, kind of fielding questions back and forth between our speakers and the chat room. So if we can just do a quick introduction of the people who will be leading this workshop. I think we can start with Dr. O, who you've heard from today.
I will ask all of my fellow panelists to show their cameras first before I start. So as you all have heard, I'm Dr. O. I use he, him, his pronouns. I am a disabled, young to middle-aged Black man of Nigerian origin, cisgender, heterosexual, living in Michigan. I'm an assistant professor of family medicine, physical medicine and rehab and urology, and I'm the interim director of services for students with disabilities and the director of adaptive sports and fitness at the University of Michigan. And now I will hand it over first to Miss Elise Zonlak.
Hello, I am Elise Zonlak. I use the pronouns she, her, hers. I am an able-bodied cisgender female. I'm a Caucasian American born in Ypsilanti, Michigan. I'm wearing a dark purple blouse with a plain tan background, and I'm a third-year medical student here at the University of Michigan.
Next up, we'll go to Miss Kate Panzer.
Hi, everyone. My name is Kate Panzer. I use the pronoun she, her, hers. I am an able-bodied cisgender female. I am an American, part Filipino, born just outside of Philadelphia, Pennsylvania. And today I'm wearing a black and white striped shirt with wood panel background. And I'm a first-year medical student here at the University of Michigan.
Thank you, Kate. And then how about Mr. Eric Rebesniks?
Thank you, Dr. Okunlami. My name is Eric Rebesniks. I use the pronouns he, him, his. I'm an able-bodied cisgender male, and I am of Canadian and Latvian descent, born in Toronto, Ontario, Canada. So pleasure to be joining all of you. My role is the project manager of the Adaptive Sports and Fitness program at the University of Michigan, and I'm sitting here with a navy blue top with an Adaptive Sports and Fitness logo. To my top right is an Adaptive Sports and Fitness logo, and behind me is our Adaptive Sports and Fitness program at the Varsity Tennis Center at the University of Michigan.
Thank you, Eric. And then we'll go to Miss Rachel Hargis.
Hello, my name is Rachel Hargis. My pronouns are she, her, hers. I'm a white wheeled woman wearing a white shirt and black blazer, sitting in a room painted gray with pictures hanging on a wall over my left shoulder. And I work as a coordinator in the University of Michigan Services for Students with Disabilities office.
And last but not least, Miss Jordan Funk.
Hi, everyone. My name is Jordan Funk. I use pronouns she, her, hers. I'm a disabled white female from Ohio. I'm wearing a black blazer with the Diversity in Medicine blue and yellow kind of polka dotted background. And I am also Disability Services Coordinator at the University of Michigan.
Thank you to the amazing team. And I will say that, look, I forgot the rules that we try to abide by, and I did not even mention that I'm a brown-skinned man with dark rim glasses, a wooden bow tie, a Diversity in Medicine maize and blue background with a white coat on. Now, disabusing disability is the talk that we're going to present to you all today. And I tell people that hear me speak that I don't like giving talks. Now, anyone that knows me will chuckle because everyone knows I love talking. And I said, it's not that I don't like talking. I don't like giving talks. I like starting conversations. So I really hope for today to be a conversation amongst all of us here on the panel and you in the audience as well about disability, because disability is something that is ubiquitous. We're here talking about diversity in medicine, and too often disability is missing from the conversation of what diversity truly means. And as we were mentioning in some of the earlier conversations and panels and workshops, we need to recognize that we are all better together And too often what we do is we silo and separate to then make people feel as though they are specific in their own struggles and not recognizing that it's because of a lack of understanding of the diversity that ties us all together as humans, that we need to then recognize how it is important to see that just because we may not have a certain lived experience doesn't mean that there are things that are not happening in life because we don't know them. So I tell everyone that my slides are merely a suggestion, and that if we are able to then have a conversation that then carries us beyond any of the things that we're saying, I don't care about the slides, and I want you all to put things in the chat to then bring things up that you want to mention so that we can then engage you in conversation. So I start with this slide. I usually use this slide because conversations about diversity, equity, and inclusion are often difficult for people. People don't know how to then have these uncomfortable conversations, and this slide has been used in many different ways to talk about what equality is and what equity is. So to describe it, this is an image that has 3 individuals. There's 2 panes of this slide. On one side, it says the word equality. The 3 individuals are each on one box trying to look over a fence at a game. The tallest individual is able to see the game, the medium height individual is still able to see the game, and the shortest individual cannot see the game. Now, the next slide on this, the next image has equity under it. And with equity, the tallest individual can still see over the fence with no boxes. The shortest individual has 2 boxes and can see, and that medium height individual has 1 box and they can still see. Now, I use this slide because this is what I like people to think of when we're having conversations about diversity, equity, and inclusion, is that we need to understand the needs of people on both sides of this fence. Because when you show this slide, people that are woke, that know diversity work will say, why is the fence there in the first place? We need to have the image that says justice, where the fence is taken down. We should not be putting up barriers. But when we show this slide, I've had individuals that play softball or baseball and say, the fence is not there to keep people out. The fence is actually there to keep things in. And so we didn't realize that people felt as though we were excluding them by the things that we were doing. We just realized that we needed to know how to hit a home run over the fence. We didn't want the ball to go out into the street. And so I think that if we recognize that there are fences there for certain reasons, but if we have conversations with people on both sides of that fence, we can understand what it is that people want and need. But the important point here is that sometimes people on either side of the fence do not want the people on the other side of the fence to have access. And so if we recognize that not everybody wants the same thing, and that not everybody thinks that equity and equality are things that we should even be discussing, it will allow us to then focus our efforts on the individuals that just may not know that they are keeping people out by having the fence up. Because there are absolutely people that want to keep fences up to keep people out. Because when I show this slide, people will say, in the chat after I presented it, someone said, why don't those insert racial expletive here buy tickets like everyone else and watch the game from the inside? I'll say it again. They say, why don't those insert racial expletive here buy tickets like everyone else and watch the game from the inside? Some people look at this slide and see that this is people trying to take from one another. Some people look at this slide and think that the people outside that are dark-skinned in this image are stealing or are not doing enough or are just trying to get something that they are not due. Now, that is the reason why this is an uncomfortable conversation to have, especially when the reality of our lives looks more like this image that now has a third pane where the tallest individual has many, many more boxes than they need. We show this because the resources are not often allocated in a way that everybody gets what it is that they need to have access to something that we think is the same. Some people will say, why did I have to give up my box in that first image to that smaller person? They will look at this third image and say, that individual dug themselves that hole and we should not have to give up our resources for that person. The conversation comes around, why should people have the same access to things if people have different life experiences, different ability to do things, that should not be fair because fairness is not what we strive for. So these are uncomfortable conversations, but when we just talk about moving boxes around, it allows people to then show their emotions and how they perceive these things, because this image was just an image, but this last image is what's going to tie it together to our conversation today. Because when we have a conversation with people on both sides of this fence, we then look at this image, which is an attempt to demonstrate there is more diversity in this image than in the first few. You could make an assumption based on gender norms that I do not ascribe to, but that I want to then say based on what this slide is trying to show, This image can say there might be more genders that are being represented in this one. Some people assume that the first slides were just all men. You could also say that that first slide did not have different races because everyone seemed to be brown skin, and in this one, there are different races represented. I tell people all the time that even with the reallocation of boxes, if you gave me a box as a wheelchair user, it would not improve my access in any way. So sometimes you need to take that wood and then create something different, which is a ramp to allow people to have access. And then the last part of this is looking at the rainbow in the top right corner. Now we also identify LGBTQ. This slide is just meant to cause people to think and have conversations to say, if we want everyone to be valued, if we want everyone to have equity in terms of the access that they're provided, we need to then have a conversation that represents everyone. We need to recognize that the resources needed for everyone may be different. And that if we start to acknowledge that and talk to people, we will find what resources they need and allow them to get the things that they need to have access. Now, I talk about my story not because I'm the first or the best or the only, but because my story is the only story that I know personally. No one is going to have the exact same lived experience as anyone else. And therefore, we are not here to then judge others' experiences, but we're merely here to recognize that the things that we experience are valid to us and should be important to you because of the shared humanity we have. I lived my life as an academic All-American athlete at Stanford, almost trained for the Olympics, turned medical student here at Michigan, orthopedic surgery resident at Yale, before I had a spinal cord injury in my third year. These types of things, jumping into the sand, jumping after I graduated from medical school, having a wonderful family to support me, I thought that those things were what made me able. I thought that those things gave value to my life. I was judged by the way I could jump into the sand. I was judged by how high I could score on an exam. And those were the metrics that were success for me until this. Until I had a spinal cord injury that made me paralyzed from my chest down with minimal use of my upper extremities. And at that point, the question was, what is my worth? If disability means inability, I'm now unable to do all the things that I could do before. I'm now unable to be a doctor. I'm unable to have a voice. I'm unable to be seen as the person that people saw me as before. Now, I tell people I've lived my entire life as a Black man, believe it or not, but I felt discrimination more prominently post-disability than I ever had as a Black man. Because my Deerfield, Stanford, Michigan, Yale, Notre Dame degrees seemed to shield me in some way from the belief that I wasn't qualified. However, after having an injury and then now learning life, as I call it, on the other side of the stethoscope, I have been exposed to a world where our life and our world is not accessible for disability. And I will say I'm even lucky that my disability is one that is visible because many people understand trying to build a ramp to give someone access. But people don't understand the other ways that our world is very, very ableist and does not provide the accessibility we all need. So here in medicine, I was blessed with the opportunity to be given certain resources. So these are the boxes and the ramps that were built for me. This is a standing frame wheelchair, which has allowed me to get back into doing procedures the way I did before. I'm looking at a microscope here on the OB rotation in my family medicine residency, looking for ferning. Those of you that don't know, look that up later. And the slide next to that, I'm in my chair as about to access someone's carotid artery to then do a catheterization in the cath lab. And so these things made it such that I then had the access and the resources to demonstrate my ability to be successful. That ability did not change at all because I was disabled. And anyone that either lives life their entire life with disability or comes into that world later on is no less of an individual and is no less qualified to have access to all the same things. So with that, that is the reason that I've invited this team here today, because the first step for this is talking about how we provide these access needs. How is it that we're going to provide individuals with what they actually need to be successful? So Ms. Jordan Funk and Ms. Rachel Hargis in the Office of Services for Students with Disabilities are going to talk to you a bit more about what they do in that work and how we can demonstrate that the individual with the disability is not the problem or the barrier. It is the institution and the structures in place that make our world inaccessible that are the things that we need to change to then make sure that everyone has equitable access. Take it away, Rachel and Jordan.
So, disability is the largest minority population in the United States. It spans all identity groups and is the only minority group you can join at any time in your lifespan. And the chances of you becoming disabled increases the longer you live. While disability is an integral part of diversity, it is often overlooked as some disabled individuals need accommodations for equitable access. In the past 48 years, 3 civil rights laws have been passed to ensure equitable access for disabled individuals. The first is the Rehabilitation Act of 1973, specifically the 504 the Americans with Disabilities Act of 1990, and the Americans with Disabilities Amendments Act of 2008, which had the most impact on accommodations, as it expanded the definition of disability to a person who has a physical or mental impairment that substantially limits one or more major life activities. This includes people who have a record of such impairment, even if they do not currently have a disability. It also includes individuals who do not have a disability, but are regarded as having a disability, which subsequently allowed more people to become protected under the ADA and subsequently request workplace and educational accommodations.
And to jump into the role of disability services and educational accommodations from there, disability services work is guided very heavily by the laws that Rachel mentioned. In practice, it's important to engage in an interactive process with students to identify barriers they experience in the educational and clinical settings and what is a reasonable accommodation that may remove those barriers. In recent years, there's been a large uptake, and I know a lot of faculty have noticed that too, in students requesting and receiving accommodations. And there's a lot of reasons for that, but some of them include there's more students with disabilities attending college. Students are covered, students have been covered by the ADA since birth at this point. The folks that we're seeing now have received accommodations in the K through 12 setting. They're used to receiving those accommodations. And another one is new technology allowing access to students with sensory and physical disabilities. One example I like to bring up, there's a Supreme Court case from 1972, Southeastern Community College versus Davis. It was about a deaf nursing student who was denied entry into the program. The program required students to use a traditional stethoscope to hear heartbeat, and the deaf student could not do that. The court ruled in favor of the school at that point in time and said that they did not have to admit the student. They did note, however, that the future technological advances may enhance opportunities where this ruling would become unreasonable and discriminatory. So now, fast forward to today, we're seeing technical standards that say a requirement is to detect instead of to hear a heartbeat, with the knowledge that students can use, a visual stethoscope who may be deaf, or an amplified stethoscope for those that are hard of hearing. So there's a lot of examples of these improvements in access, but technology is one that has really allowed us to further explore disability-related barriers and, what is a true essential component to learning. So with that, I could go on for a long time, but next up, we're going to hear from Kate about medical students for disability and health advocacy.
Thank you so much, Jordan. So again, my name is Kate. I'm a first-year medical student at the University of Michigan. And this year, I worked with a couple of classmates to start a new group called Medical Students for Disability, Health, and Advocacy. And really, we wanted to start this group because we recognized that there was a lack of space for medical students to come together and discuss different topics and issues around disability in medicine, but also to support and advocate for medical students with disability and chronic illness. So those are the two components of our group that we're really focusing on. We're really excited to get this group started. We have our first event coming up next week where we have a panel discussion of different faculty describing their experiences with going through medical training and clinical practice with a disability or a chronic illness. So really excited for that. And then just to give you an idea of what's going on across the country related to this, there are several institutions that either have a student organization focused on disability in medicine or are currently working to form one. And so that's really exciting to see the progress there. And there are also groups that are focused on connecting these institutions and these groups together. So for example, there's a group that was started by students at Stanford University called Medical Students with Disability and Chronic Illness, or MSDCI National. And so that's another group that just started recently this year. And so just really excited to see what we're able to do together and accomplish as we connect with other student groups. So if you're interested in this at all, I'm happy to talk with any students, faculty, really anyone about this. I'll share my email in the chat. And then also I encourage you, if you're from a different institution, to look and try to find if there are student groups that are focused on this at your institution as well. But thank you so much. And then next, I'd like to pass it on to Elise to discuss the disability health elective.
Hi, so I'm Elise, and I am in charge of the Disability Health Elective here at the University of Michigan. This was a project that was originally proposed by a graduating medical student who is now Dr. William Zhu, and passed on to me. And what this elective is it is a 2-week elective for clinical medical students, so people who have finished their clerkships. And it's a hybrid elective, so we have online components of the elective where we have lectures and didactics that are pre-recorded, as well as some live discussions with faculty members. And then the clinical component of this elective involves going to different clinics that specialize or have a high population of different individuals with disabilities. And so we cover a pretty broad spectrum, anywhere from physical disabilities, sensory disabilities, and then cognitive and mental health disabilities. And then the last part of this elective is this community experiences, which I think is the best part of our elective. Students get to go and participate and talk to and interview some individuals in different programs in our community. We work with the Special Olympics College here at the university. We also work with the Ann Arbor Center for Independent Living, as well as a couple different organizations that we're trying to get in contact with. And so this really provides students an opportunity to learn more firsthand what it's like, the challenges that their patients with disabilities are facing, as well as the special needs that, needs to go into the care for these individuals. And so I can also put my email in the chat for anyone from different schools that are interested in talking more about this. There are some great programs at a couple different schools that are working on this curriculum, which has been shown to really be something that students miss throughout their education. So I'm happy to talk about this with anyone. And next I will be introducing Eric, who is going to talk to us about adaptive sports and fitness.
Thank you, Elise. Now, why sports? And why is this a part of the conversation? And, it's a question that I often reflect on, and I think a lot of people reflect on, and especially given recent social events that have occurred over the past year. And I think sport is just an extremely powerful tool, especially because it's so rooted culturally in our daily lives, and really impacts a lot of the things that we do, whether it's individual transformation or whether it's the social groups that you're then connected to, the way that it could empower a certain sect of society, and how it can really elevate new potentials and new horizons, and ultimately at the societal level in terms of what it does for policy change, and what it does in terms of inspiring a greater collective. But at the same time, sport isn't always equitable when it's delivered, and how it's accessed, in the people that it benefits. And even if you do have access, it doesn't always benefit people in an equitable fashion. Think about the first slide that Dr. O showed us. And it's not just about the people taking in the experience from the sidelines, but it's also the people on the pitch, the people in the stands, the people broadcasting. And overall, sport touches so many people in so many different ways, but is not equitably enjoyed by all the time. And with that, I want to really force everyone to recall a time in their daily lives where they felt they didn't belong. And I think that the intersectionality of this workshop, of this conference, and of all the speakers that we've seen today is I think everybody can draw upon a time where they felt they didn't belong. Now, also think about a time that you did belong. Think about a time where you were given the resources and the social support and the physical resources to succeed. And think about that moment in the sun where you felt lifted, where you felt inspired, where you felt transformed. And I think that's really the purpose of why the Adaptive Sports and Fitness program exists. We know that there's an inequity of access when it comes to adaptive sports or sports for people with physical disabilities. So what are we going to do then to address that inequity so that everybody has that opportunity to achieve, whether it's personal success at a physical, psychological, mental, or social level, whether it's changing attitudes and behaviors within schools and institutions and programs, whether it's driving greater policy change. I think there's a lot of things that can be done through sport as a means to generating greater inclusion. Now, as such, what you see on the screen here are the 4 key pillars to the Adaptive Sports and Fitness program. But what you don't see are all the people, all the resources, all of the key individuals and groups and community members and organizations that it takes to really create a seamless and integrated and inclusive system. When they say it takes a village, it's really true. And that's what we're trying to do with the Adaptive Sports and Fitness program, is identify, how do we go beyond our barriers and the confines of the institution and engage with community members, engage with primary health providers, engage with schools, engage with all levels of the community to ensure that everybody has an equitable opportunity to access and to participate and enjoy the benefits of sport participation. We have our Adaptive Sports Student Interest Group, which aims at generating an increase in awareness and knowledge among students and faculty at the University of Michigan about the Adaptive Sports and Fitness program and the movement of adaptive sports. We have our Adaptive Sport and Inclusive Recreation Initiative, which aims at embedding adaptive sport and reforming the educational policy within the state of Michigan by adding adaptive sport as part of the physical education curriculum that then all students go through at a K-12 level. Too often students with physical disabilities are left sitting on the sidelines, and that can be related to any domain, any field, and quite frankly, any minority as well. So what we're really trying to do as a program is not just deliver sport programs, but really understand the different antecedents and different factors from all aspects of society that contribute to equity of access. We also have an adaptive fitness aspect of our program, which addresses the need that people with physical disabilities need to go to the gym just as much as able-bodied individuals. And lastly, we have our adaptive sports side. And I want to draw upon a little story and how it relates to the field of medicine and how it relates to the Diversity in Medicine conference. We recently had an athlete join the program who was not completely aware of and had knowledge of about his disability and how that then connected him to an adaptive sports world and society and community. It often participated in able-bodied systems or systems that benefited able-bodied individuals and wasn't given the equitable opportunity to really thrive in a situation that accommodated his disability. Now, this individual was very successful in the sports that they competed in and in the activities that they pursued. But often what I point to is that when you see minority groups and individuals that succeed, and we often point to them and shed some light on them and point to the successful minority individuals that exist in the current system, well, it's not because of the system. The system did not get them there. Those are just extremely talented individuals with determination and a really good local support system. So how do we then make a system that is more supportive? And how do we build a system that gets more people, that equitable opportunity to succeed? Now, just recently through the medical system, people started engaging in conversations with the student about adaptive sports, about the opportunities for people with physical disabilities to get the resources they need. They are now on their way to train at a national level and perhaps even compete at the Paralympic level. Why? Because all it took was a few conversations in the doctor's office, in the clinic, to just direct this person to the resources that exist. But at the same time, the resources also need to exist. The point that I'm trying to make is that collectively, there needs to be an integrated support system so that people know about, so that there are resources and there are opportunities for people to participate. But at the same time, those key influencers and key individuals, whether they're teachers, whether they're parents, professors, your friends, your family, whether they're primary healthcare providers, whether it's your doctor or your dietitian, that they're referring you to the opportunities within your community, to have that social support, to set you up for success. That's what the Adaptive Sports and Fitness program aims to do.
So I want to call all of our team back up onto the screen at this time. I know that we are running up to the end of our time, and Dr. Blackstock has already joined us and will be speaking soon, but I want to answer one question that was asked in the chat about when to disclose. Now, I think the issue of disclosing when one has a disability is something that, unfortunately, this system has made it such that that question is even needed. Because if disability weren't seen as a four-letter word, if disability weren't seen as something that was a negative, I'm sorry, I live next to an airport, so you're hearing my planes. If disability were not something that were so stigmatized and marginalized, and if people weren't thought that they were not as qualified if they were disabled, then the notion of disclosure would not be such an issue. Now, the reality of this is that we have to hold these truths at the same time. That one, I want people to be able to have a system that supports them and views them as equal to everyone else, even if their disability, visible, invisible, apparent, not apparent, is something that they have. Simultaneously, we need to then allow people to then recognize that disclosure is not something that everyone is going to be comfortable doing, and therefore our system needs to be put in place to then make sure that access is a given. Access should be something that all have, such that accommodations aren't even necessary in many situations. Because one of the things that I say is that everyone can use the ramp, but not everyone can use the stairs. And so therefore, what each of these individuals is talking about is building ramps to access for all, whether that's the amount of time you have on an exam, whether that's giving someone time to stim during a class, whether that's making sure that we introduce ourselves with a visual description, have CART services present, an ASL interpreter, and make sure that no matter what the disability is, they do not feel like a burden by getting the access that all of us just enjoy as a given. I tell people that I do not blame you for not understanding this, because prior to my own disability, I did not recognize how inaccessible things were. But what I also say is that the past may not be your fault, but the future will be. So if you've learned something today, if you've heard of things that you did not know existed, if you've discovered barriers or fences or walls that were put up that keep people out, then what can you do to try to create that access? Whether it's a student group, an adaptive sports program, an elective, or providing the educational accommodations that everyone deserves. Each of us can work within our sphere of influence to then impact change. Each of us can enact change with the roles that we have, no matter where in the system you feel you fall. Because as someone said earlier, and I'm going to say often, it is not that people don't have voices that we need to speak for them. It is that those voices haven't been heard and are not listened to. So each one of you can use that voice to then provide access for everyone. Thanks, guys. think with that, I will allow, I don't know if Adure is in here yet. I will turn it over to Adure to introduce our final speaker of the conference. Here you are, Ms. Nwaba.
Hi, everyone. We'll give you guys, thanks, Dr. O, that was great. We'll give you guys another 1 to 2 minutes, 1 minute just to breathe real quick, catch your breath, and then we'll come back for our next and final speaker.
Should I share screen or no? Not yet.
You can share screen. Oh, not yet, sorry. After I do your intro, then you can share screen.
Okay.
Okay, so we're back. My name is Adure Waba. I use the pronouns she, her, hers, and I'm an able-bodied cisgender female. I'm Nigerian American and was born and raised in Maryland, closer to Baltimore. I'm wearing a gray sweater today and I have a white sunny background behind me. I'm a third-year medical student at the University of Michigan. Today, I'm honored to introduce Dr. Uche Blackstock, our final keynote speaker for the conference. She's one of the leading voices on speaking about bias and racism in healthcare, and she earned both her undergraduate and medical school degrees from Harvard University. She's the founder and CEO of Advancing Health Equity, which partners with healthcare organizations to eradicate racial health inequities through keynote talks, trainings, and consulting services. In 2019, she was recognized as one of the 10 diversity and inclusion trailblazers you need to get familiar with. And in 2020, she was one of 31 inaugural leaders awarded an unrestricted grant for her advocacy work from the Black Voices for Black Justice Fund. She's a former associate professor in the Department of Emergency Medicine and the former faculty director for recruitment, retention, and inclusion in the Office of Diversity Affairs at NYU School of Medicine. She left her faculty position at NYU in December 2019 after almost 10 years to focus on advancing health equity. Since June 2020, she's been a Yahoo News medical contributor and appears regularly on cable and broadcast news programming to amplify the message around racial health inequities. So without further ado, here is Dr. Uche Blackstock to close out our conference today.
Oh, thank you for that intro, Adure. So hi, everyone. I'm Dr. Uche Blackstock. I use she, her, and hers pronouns, and I'm an able-bodied cisgendered female. I'm Black American. I was born in Brooklyn, New York, and I'm wearing a blue and green dress and green earrings, and I'm sitting in a sunny room with artwork on the back. And I'm also founder and CEO of Advancing Health Equity. Thank you so much for having me. I'm going to just share my screen with you. And so I just want to give everyone a heads up that I like to just engage with you all in the chat. I know virtual talks are very interesting. I wish I was in person with you all, but I may ask for your just feedback in the chat, and just let me know if the chat box is ever making, like, sometimes it makes a black box on the screen. So just give me a heads up for that. I just usually start my talks by telling people a little bit about myself. So this is my mother. She's the original Dr. Blackstock. This is her holding my twin sister, Oni, and me. She was a second-year resident at Harlem Hospital at the time. So that's why she kind of looks both happy and tired. And this was at our christening. But my mom grew up about 15 minutes from where I am right now here in Brooklyn, New York. Very different circumstances that I did. She's a single mom, born to a single mother. She's raised on public assistance. First person in her family to go to college, and she went to Brooklyn College, and she was fortunate enough there to have a professor, chemistry professor, who saw the potential in her and encouraged her to apply to medical school. And so she applied to medical school and got into every single medical school. And she ended up matriculating at Harvard Medical School. And afterwards, she came back to Brooklyn, and she trained here, and she cared for her neighbors, mentored many medical students and faculty, and just really
was the definition of giving back. This is Oni and me with our dad at our medical school graduation. Unfortunately, our mom couldn't be there because she passed away after our sophomore year in college from acute myelogenous leukemia. But both my sister and me, in the work that we do, we hope to honor her legacy always. But our dad is an immigrant from Jamaica. He worked probably about 10 different odd jobs before he ended up in college. He came to the States when he was 18 years old, and he and our mom just worked incredibly hard to give us lives that had more opportunities than they did. So we just are incredibly indebted to them. And then some of you also know that I was in academic medicine, as Dory mentioned, for about 10 years. And it was my own experiences in academic medicine and really recognizing that, these institutions that are supposed to be, training us and supporting faculty are not doing that. And they often are very, have environments that are inequitable, and that inequity often trickles down to the care that is provided to patients. And so I started advancing health equity about a year before I even left, because I knew that I wanted to work more so externally with these institutions to address issues around racism in medicine. So these are the objectives. I only have 30 minutes to speak with you all, so I'm going to try to not go too quickly, but I have a lot of content. So these are the objectives: how systemic racism produces racial health inequities. We'll talk about the 4 I's of oppression framework, and then hopefully end with some practical strategies. And so, a lot of what motivates me to do the work that I do is, these statistics that we have, that are really, despite advances in healthcare innovation and technology over the last decades, we actually have had inequities even worsen during that time. And so these are just some of the current statistics, which I know most of you are already aware of. But even thinking about the recent CDC data showing from January to June of last year, Black men who already had the shortest life expectancy of any racial demographic group, their life expectancy dropped by 3 years from the COVID pandemic. And so I'd like to use this slide just to give some context for some of the inequities that we're seeing today. So if you look towards the left, about 15 years before the end of slavery, many babies did not live to their first birthday. The infant mortality rate overall was quite high. However, Black babies still were more likely to die within their first year of life than white babies. But over time, with improvements in sanitation, nutrition, living conditions, overall rates improved. However, in the 1960s, the US was still last among all industrialized countries with the highest infant mortality rate. And then fast forward to current day, if you look at the numbers in the upper right corner, while the overall infant mortality rates have improved significantly, there's a larger Black-white disparity today, with Black babies more than twice as likely to die in their first year of life than there was in 1850, 15 years before the end of slavery. And so while significant work has been done, we still have a lot more work to do. And I know some of you are familiar with this study that Dr. Hardiman out of Minnesota and her team published, but looking at how racial concordance, even in the in neonatologists and pediatricians, actually influences infant mortality rate. And I know many of you know about the maternal mortality rates, and I actually would recommend reading this article. Even it's not in a journal, but it's a really well written article by Linda Villarosa about the Black maternal mortality crisis. It was in New York Times Magazine in April of 2018, but really puts a really personal twist on it. And she follows several Black mothers that have experienced pregnancy complications. But what's interesting is that, we know that the data, Black women are 3 to 4 times more likely to die of pregnancy-related complications than white women. And here in New York City, it's as high as 12 times. So Black women are 12 times more likely to die around pregnancy. And even myself, as a Black woman with a medical degree, I have a higher likelihood of dying than a white woman who has not finished high school. And so that's where we are. And we know even these two women talked about their own experiences. So does anyone know, and you can just drop it in the chat, what did these two women talk about during and after their pregnancies that they experienced? And so I put them on the screen because often people will say health inequities are a result of socioeconomic differences in status. And the fact is that they're not, is because we still see these inequity gaps across socioeconomic status and across income. So yeah, Serena Williams had a history of a pulmonary embolism, and after her pregnancy complained of shortness of breath and ended up having another PE, but she talks about feeling like her concerns were not heard. And then also Beyonce talks about her own situation. I think she had some signs of preeclampsia that she shared with her team, and also feeling like she wasn't being listened to. So, hi Abubakar. Okay, so Abubakar says Serena Williams had DVT, that she had to self-advocate to get properly diagnosed and treated, right? And so this is a woman of affluence, of means. She's a professional athlete. She knows her body, but still, as Abike said, not being heard. Anna says knowing that they were sick and not being listened to by numerous health professionals. So exactly. And so just to ask everyone this question, why do we see these racial health inequities despite status? So someone mentioned, Lisa mentioned not being listened to. What are some other reasons why these health inequities still persist? So Patricia says stigma and stereotype. David says the weathering of racism. Jenny says racism, white supremacy. So, right, so not much diversity in medicine, right? So we know that racial concordance matters. We know that there's provider bias. We know that there is the weathering effect, like the physiologic aging of the bodies of people of color in this country due to everyday racism. And then Lisa makes the appropriate comment that this is not just a medicine issue, it's a nursing issue, it's a healthcare issue. And then Sarita mentions that this belief that Black women have a higher pain threshold. And there's so much literature in the pain literature that supports this, that the pain of Black people and other people of color is often underappreciated and undervalued in the healthcare setting. And so Jonathan says both conscious and unconscious bias. And I just want to make a point of saying that, we often talk about unconscious bias as if it's this benign phenomenon, but it's not. It's just as harmful as explicit bias, as explicit racism. So thank you for those comments. And so I'm not going to spend too much time on this slide, but I know that I just think it's important that often we conflate equality and equity. And the difference with equity is that we are acknowledging that people are starting out with different advantages and disadvantages, differential access to resources, power, opportunities, and experiences. And so equality is essentially giving everyone the same thing without recognizing the barriers and disadvantages that people are starting out with, whereas equity is giving each person what they need to reach their highest potential. And so I wanted to share this slide with you all, and I don't know how much you're discussing structural competency at your respective institutions, but it's this idea, this shift away from cultural competency, which essentially sometimes boils down to a list of stereotypes about different non-white racial and ethnic groups. So it's this idea that we need to think further upstream, so towards the left, than the social determinants of health. So we know the social determinants of health are incredibly important in terms of influencing health outcomes, but there are social structures that dictate social and economic policies, the fact that we live in a capitalist system, the fact that there is systemic racism that actually shapes and influences the social determinants of health. And so if we're thinking about, what do we need to do to address health inequities, it's not just about addressing social determinants of health. We need to think further upstream. And so this is another kind of like a money slide that I want you all to just take home with you. And I feel like the whole conversation about that JAMA podcast, I think is almost exemplified in this slide, that, when people think about, when a lot of often people think about racism, they think about this interpersonal racism, because that's the racism that you can see, that's more overt. Hate crimes, microaggressions, calling someone a racist slur. But what is the foundation of racism is systemic racism. It's what is more covert, what is more difficult to see, what is under the water, and what really sustains racism. And so thinking about practices and policies that reinforce negative stereotypes in the media, mass incarceration, political representation, the policies that have led to residential segregation, like mortgage redlining. And that is what we need to really be focusing on and addressing if we want to address health outcomes. And so I have some history lessons for you all. Who's this person on the right side of the screen? I want you to drop that in the chat for me. So thank you. Oh yes, it's FDR. And FDR is well known for developing the New Deal. What do you know about the New Deal? What was the whole point of it? I want to make sure I'm staying on schedule for you guys. So Maria says social welfare. So yeah, so does anyone remember what the point of it? It was to help, right. So Barbara says, right, help Americans, pull Americans out of the Great Depression, exactly. Americans, businesses. And so the New Deal is known for the creation of the federal, one of the reasons, the Federal Housing Association. And the FHA is actually responsible for the creation of the suburbs. We'll get to redlining, Thomas, but we're gonna first focus on the suburbs. And so there's a reason why suburbs were mostly white to begin with. The reason why these mass subdivisions were mostly white was because as part of the New Deal, there were clauses in the deeds of these subdivisions that prohibited sale to Black Americans and other Americans of color. You could only sell the property to a white person or white family. And additionally, there were clauses in the deeds that prevented resale. So even if a white family purchased a home in the suburb, they can only sell it to another white family. They could not sell it to a person of color. So this is just one aspect of the New Deal I want you all to understand, and that had led to the suburbs being mostly white. Now, Thomas mentioned mortgage redlining, which I know a lot of folks know about. And I wonder if people can just drop in the chat, what do you know about redlining? While you're doing that, I'll just let you know there is a map on the right side of the screen from Portland from the 1930s. And Richmond University has a really wonderful supply of redlining maps from all across the country. You should just go there and take a look at it. But essentially, I was hoping people would drop in the chat what redlining is. I don't want to have to give you the answer. I know people know. So the New Deal also led to the creation of the Homeowners Loan Corporation. And yes, Maria says people went around block for block and gave these blocks colors. Yeah, so there are these essentially based on who lived in the neighborhood, and really not much else, these neighborhoods were graded. And so essentially if the neighborhood was mostly white professional, that neighborhood got an A grade. And what that meant was if you lived in that neighborhood, simply because you lived in that neighborhood, you were more likely to be able to qualify for a federally backed mortgage and mortgage insurance. Conversely, if you lived in a redlined neighborhood, so the ones that are lined in red, you were, just by virtue of living in that neighborhood, unlikely to be able to qualify for a federally backed mortgage. And so I'm going to go more into some details. I'm going to blow this up a little bit. This is an actual redlining document, and people are putting a lot of great comments in the chat. So this is from a neighborhood in Portland called Gainsborough. And if you notice, it says it's asking for the occupation. This is mostly business and professional men, white collar, foreign-born families, none. And this is a federal document. They're using these very pejorative terms, subversive for foreign-born families. They ask about, are there any Negro people living there? And then item E, is there any infiltration? So infiltration, again, really pejorative terms talking about whether or not there's infiltration of racial and ethnic minorities in this neighborhood. So this neighborhood got an A-. So if you lived in this neighborhood, it was a green area, you were more likely to be able to qualify for a federally backed mortgage just because you lived in this neighborhood. This is another neighborhood in Portland called Lower Albina, and it was mostly made of service workers, laborers, artisans. The income was slightly less, mostly 40% foreign-born families. It says Southern European and Orientals, Negro many, and infiltration, subversive races continuing. And if you look in the clarifying remarks, it says the area constitutes Portland's melting pot and is the nearest approach to a slum district in the city. 3/4 of the Negro population of the city reside here. In addition, there are some 300 Orientals, 1,000 Southern Europeans and Russians. And so this neighborhood got a D-. So if you lived in this neighborhood, just because you lived in the neighborhood, not because of anything else, you were less likely to be able to qualify for a mortgage and to buy property. So I have one more policy I want to share with you, the GI Bill. What do you all know about the GI Bill? What was the whole point of the GI Bill? And just drop that in the chat. So yes, Anisha says, so most people think about the GI Bill as assistance, offering financial assistance, educational assistance to returning, World War II veterans, and help them to pay to go to college. However, most people don't know, and thank you, Jenny, that it's actually, there's a housing provision of it. And the housing provision helped to give mortgages to these returning World War II veterans so they could buy homes. However, as Nisha points out, banks would not give Black veterans mortgages to live in Black neighborhoods. They said it was too risky. And if you recall, at the time, in the 1940s, Black people were not permitted to live in white neighborhoods. So they could not get a mortgage to live in a white neighborhood or a Black neighborhood. So they were not actually able to take advantage of the housing provision of the GI Bill. So Thomas says returning service people could get assistance with college costs. Yes, so definitely that, but the housing provision, everyone was not able to take advantage of that. And these policies I just went over with you, and these are just some of the policies. That wasn't even an exhaustive list, but has led to the racial wealth gap that we see today, where Black and Latino families essentially make or have a fraction of the wealth of white families. And it's not because Black and Latino families did not work hard. It's because there are federal policies that advantage white families and enabled them to purchase homes. And what's one way that we accumulate wealth in this country? The main way is through home ownership, right? And so if you're blocking people from buying property, then they cannot establish wealth, right? And they cannot pass it on from generation to generation. And so that's why we have maps like this one from St. Louis, where literally just blocks apart. And I know probably so many of you that are listening in have the same experience, like where you grew up, just like blocks away, the neighborhood changes, right? Home values change, the income of the people who live there, the racial demographic, all of that, right? And that's not by mistake, it's by design, right? So why do we even care about this? The reason why we care about it is because if these neighborhoods, what happens to a neighborhood when people are not able to buy property in that neighborhood? What happens to the neighborhood? So people aren't able to buy property, right? The home values depreciate. They're not able to accumulate wealth. Do businesses want to come to those neighborhoods? No. If businesses don't come, jobs don't come. What happens to the schools? Okay, so Maria's ahead of me, right? Because property taxes go towards funding schools. Exactly. And then thinking back, what are all the social determinants of health, right? Jobs, housing, education, right? So directly, and I'm sure many of you already know that, in many cities, the neighborhoods that were redlined in the 1930s, those are still the same neighborhoods that have the worst health outcomes if they haven't been gentrified. So here in New York City, the neighborhoods with the highest infant mortality rates, with the shortest life expectancy, are those same neighborhoods that were redlined in the 1930s. And so what we do need in order to improve the health of these communities is we need policies for people to have opportunities for home ownership, for people to have opportunities for gainful employment with sick leave, right, and benefits. We need to improve education in our communities, right? So when we're thinking about how do we strategize to address health inequities, we have to also think outside of healthcare. Okay, we have to think about what policies are going to improve and empower communities, right? How can we center our communities? I'm just going to move forward because I'm running out of time, but I want you just all to think even on a personal level, right? In your own experience, how has systemic racism, right, through some of these policies that I mentioned, and I'm sure they impacted your own families, right? How did they shape opportunities, exposures, and stresses? Okay, I love the chat. Thanks, Brian. Okay, so just based on all of that and the policies I just presented to you, I love this diagram with the escalator analogy. I don't know if people have seen this, but so say on the left side, right, you have a down escalator. What happens if someone's trying to go up the down escalator? What happens to that person? Have you ever tried to go up and, okay, they lose their balance, what else? Can they get to the top? They get tired, they go slow, they stay in the same place or can't move up, exactly. On the right side, you have an escalator going up and a person going up. Does that person have to put much work in? They can make it without even trying, right? But a lot of times people get uncomfortable with the whole privilege thing because they say, oh, I worked hard. Yes, you worked hard, but there was assistance. And so I like to really draw the analogy with those federal policies, right? These policies made it easier for white Americans to be able to purchase homes and to accumulate wealth. And it made it more difficult for people of color too, right? And so when we talk about systems of oppression and privilege, right, we're talking about these policies that advantage one group and disadvantage another group. And then Sarita says the up allows for white disabled people to go up and access the support they need. Thank you. Thank you for mentioning that. And so I just wanted to share, I don't know if people have heard about the 4 I's of oppression, but it's just sort of a great way of thinking about systems of oppression and classifying them. And there's actually a great YouTube video online. I didn't have time to show you all, but if you Google it on YouTube, there's a 4 I's of oppression video that really explains that well. But essentially the first I is ideological, that any oppressive system is based on the idea that one group is better than the other. So this is not just racism, it's sexism, ableism, cissexism, institutional oppressions that are embedded at an institutional level, healthcare, our education system, our political system, interpersonal, which is the oppression I think that we are more able to see very easily because it's usually overt, that takes place between a member of a dominant group and a marginalized group. And then internalized is when a member of the marginalized group often internalize those really damaging beliefs. And so I want to give you just a few examples. So just think about the 4 I's and just recognize that often multiple I's are operating at the same time, but there's usually more of a predominant type. So I just want to give you some examples. So I shared this earlier, Black women are 3 to 4 times more likely than white women to die from pregnancy-related complications. Which I is that? Like, is that ideological, institutional, interpersonal, or internalized? So just drop that in the chat. Right, so that's more, so it's, yes, it's absolutely all of the above, but the outcome is more of an institutional one. Great, thank you. And let me know if the chat box is blocking the screen. Okay, what about this one? The cultural narrative that white patients are more compliant and more likely to follow clinician instructions than Black patients and other patients of color. Is that ideological? Is it institutional? Is it interpersonal or internalized? So good, it's ideological because it's like this idea that one group does things a better way than the other. Ideological, great. What about this one? A Black child identifying a white doll as good and a Black doll as bad. Which I is that? Good, yes, internalized, good. And then this last one, clinicians are less likely to prescribe pain medication to Black patients than to white patients. Which I is that? Good, interpersonal, great, great. And so I just want you all to think about the 4 I's and we won't have time today, but like thinking about how can we use this framework to envision change within medicine for Black, Indigenous, and people of color, not just patients in their communities, but also clinicians as well. Okay, and as I mentioned, I'm happy to send a link to the organizers for the YouTube video, which is amazing. It's very powerful. So just going back, this is like kind of like the take-home slide from the structural competency working group. I want to challenge you all to think further upstream. So on the left side, when thinking about how are we going to address health inequities. And then just some examples from the structural competency working group of structural competency at work. Is this person, does anyone know who this is on the left side of the screen? This, yes, yeah, right, Dr. Mona Hanna Atisha, who, essentially was an advocate for her patients. She noticed that her pediatric patients' blood lead levels were high, and she wrote to her representatives about it. No one responded. So what did she do? She had a press conference, and that's how the world came to know of the Flint, Michigan water crisis. But what was so powerful about it is that she didn't just think about what can I do within the four walls of this clinic or this hospital, but I'm going to be an advocate for my patient, thinking about what structural change needs to happen. Right? Oh, great. Oh, Tanya. Yeah, she sounds amazing. And then the Black Panthers, I always have to, amplify their work, right? Because they were thinking about structural competency before it even had, a name, right? So 13 free clinics across the country offering free care, food giveaways, free breakfast programs, clinics where they would offer community members legal advice, offering transportation to families to visit loved ones in prison, even performing testing for sickle cell disease, which we know is severely underfunded by the government. And so, yeah, so definitely thinking about how we can all advocate for our patients. And then just to give some context, what does structurally competent care look like in a pandemic? What should healthcare centers do? Healthcare centers should make sure that their patients have broadband access. Yes, they don't necessarily have to provide the access, but they need to connect them with the social services that can help them get access, because how else will they have their telehealth appointments? We should be concerned about our patients' food insecurity and housing insecurity, and ensure that there are services available to help support them. We should, as healthcare professionals, be delivering PPE to community members and thinking about new medical, financial, legal partnerships to help support communities. And so I want to challenge you all just to think about, where are you going to make a difference? I would say that the low-hanging fruit is the individual and interpersonal level. I want you to think about what you can do within your institutions, how you can center communities and engage with communities. Because communities often they have the answers. We just need to listen to them. And how will we do research and policy and enact policy that will also make a difference structurally? And so these are my take-home points. So we know based on that racism iceberg, right? It's systemic racism is the risk factor for morbidity and mortality, not race. I want you to think about using the 4 I's and structural competency to think about how do we dismantle racism in medicine. And I want all of you to be inspired to mobilize for health equity. So thank you so much. I don't know if I have any time for questions. I went over a little bit, but thank you so much for engaging in the chat and for your comments.
Thank you so much, Dr. Blackstock. That was such a powerful conversation. I don't know that we have last minute questions. I didn't see any, but I think people have your contact. So
yeah. And I think I saw, who sent out the link for the YouTube? I think one of my friends sent it out. Ijeoma, yes, Ijeoma sent it out. Thank you.
Awesome.
It's in the chat for the 4 Eyes of Oppression YouTube.
Thank you. So that was a great end to our day. Matt and Dina are here, and they're going to close out the rest of our conference.
Thank you.
Thank you so much, Dr. Blackstock. That was truly the perfect way to end this incredible day of programming. Matt and I were the co-directors of the executive board of this Diversity in Medicine conference. We just wanted to say a quick thank you for attending the Diversity in Medicine conference today. It truly exceeded all of our expectations. As a medical student group planning our first ever virtual conference, we truly did not realize that this would, one, work, or two, be as successful as it is. And we're so incredibly excited about, one, all the incredible speakers that we've been able to learn from, and two, all the engagement that we've seen. We had over 1,000 people registered to come to this conference and over 200 people at all of the sessions. So we are so excited. Just a few logistical points. Please, if you haven't made a Socio account, do so and check out all the amazing poster presentations on Socio. Those will be available for 30 days after this conference. So please check them out and see the incredible work being done across the country. And we will be working on uploading these videos of these talks to our Socio and to a YouTube channel so that these are accessible after the conference, so we can continue the conversation and continue learning. But like I said at the beginning of the day, we just hope that this conference inspired you. I know I'm so incredibly inspired, and we just hope that the conversation doesn't end here. It's just beginning, and we just continue to take this offline. But Matt, if you could say a few words.
Hi, everyone. My name is Matt Poon, and like Dina said, I'm the other conference co-director and a student here at the University of Michigan. I use the pronouns he, him, his, and I'm an able-bodied cisgender man of Chinese, Peruvian, Polish, and Czech heritage. And I'm wearing a blue jacket and tie with a blue Michigan background. In addition to everyone that Dina mentioned, we also would like to thank our generous sponsors here at the University of Michigan, the Departments of Surgery, Anesthesiology, Urology, Orthopedic Surgery, and Obstetrics and Gynecology. Without their support, we could not put on this event. Thank you also to all of you who have done the fantastic work to make change. Your posters and recordings will continue to be available, as Dina mentioned, and there are so many posters to go through. I haven't gone through them all myself, so we'll make sure that they're all accessible. Thank you also to our faculty advisor, Dr. Okalami, for his guidance and incredible support in planning this conference, and for connecting us to our incredible speakers, panelists, and workshop leaders. And lastly, thank you to the incredible team of students who have contributed over the last year in putting this event together. I'd like to now ask everyone on the team to turn on their cameras so you can see the faces of everyone who made this conference possible today. We hope that everyone had an incredible time today, and we cannot wait to continue these conversations. We look forward to seeing you next year. Thank you.
Great job, team.
Dr. O, you can show your camera too. Turn on
Yes,
your
you should.
That was awesome, everybody. I don't know if somebody wanted, Maria, if you wanted to take a picture.
Someone should screenshot it.
If anybody's still listening and could fill out the post-conference survey, we would really appreciate it.
Okay, everyone smile. Got it. I'll send it out.
Maria.
Thank you all so much.
Amazing day, everybody.
Seriously, good job, guys. I know we still got 80 people, but you guys rock. That was awesome. I was awesome. So all the engagement in the Socio platform, Q&A, chat, green room, text message, Instagram, Twitter, you guys were managing this from all angles. So really, 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 really well done. That is going to be hard to top next